insulin being anabolic hormone will lead to macrosomia, and there is early metabolic imprinting which is going to affect the fetal life even in future. Even if she attains normoglycemia in later pregnancy, these effects are not going to undo. So this is the basis of the Barker's hypothesis: adult disease originates in fetal life. So this is a very important study, we all know about it, HAPO study, and in this we had 2,316 patients who were tested for hyperglycemia, and they found that there was a continuous positive correlation between maternal plasma glucose and the adverse maternal and fetal outcomes. And what is important to note is that the adverse fetal and maternal outcomes were observed even at levels below the thresholds. The threshold was set at 1.75 odds ratio, but the thresholds, they found that even below these levels, there were feto-maternal complications. So this is an important paper. Should the current therapeutic targets be challenged? So Hernandez et al. Evaluated the normoglycemic woman in 12 studies over 45 years, and they have recommended that the glycemic targets need to be lowered from the currently known ones. Fasting 71 plus minus 8 and 2 hours postprandial less than 110. In sync with this, the revised TIPSY guidelines were published in August last year. We all know about GDM, which is 2 hours after 75 gram glucose. If the blood glucose is more than 140, we say it is GDM, and it is a well-known fact that it is also associated with adverse feto-maternal outcome and future risk of diabetes. But 2 more sub-thresholds have been added. The second category is GGI, gestational glucose intolerance. So if the levels are between 121 to 139, these women have also been found to be having adverse feto-maternal outcome and risk of future diabetes. And the third new entity is early gestational glucose intolerance, which is defined as if 2 hours postprandial blood glucose, not post-glucose, prandial blood glucose is more than 110 at 8 to 12 weeks, then these women have been found to be having chances of developing GDM as the pregnancy continues. And this is the most important time when we can take care of these women and prevent primordial prevention of diabetes. So we are at present carrying out this study, diagnostic accuracy of first trimester. We are trying to test this hypothesis of Dr. Sachaya, whether this 110 at 8 to 10 weeks is able to predict GDM in later pregnancy, and we are getting very promising result. So you would wonder why we are concentrating on this 110. So here, the renal threshold for glucose in the fetus is about 110. So when the blood levels of mother are higher than this, the glucose is going to pass to the baby, cause hyperglycemia in the baby, and fetal hyperinsulinemia will occur. The insulin in the amniotic fluid has been linked and correlated to fetal hyperinsulinemia. Baby developing hyperinsulinemia, fat deposition sets up, and we all know that macrosomia sets up at about this time of 14 weeks. So when the baby is hyperinsulinemic, it is going to pull the sugars from the mother to the baby, and this is known as the fetal glucose steal. And sometimes you must have seen that women are having normal OGTT, normal SMBG, but they are having all features of diabetic fetopathy. That is, they are having polyhydramnios, they are having big babies, macrosomia. So this could be one of the reasons. So it is very important that before the development of placenta at 10 weeks, we are able to bring down blood glucose level to prevent fetal hyperinsulinemia and fetal programming. So this is a very important paper which has just come up in 2022, which says that if PPBG, postprandial blood glucose, is more than 110 at 8 weeks, we need to start at least metformin or medical nutrition therapy to bring down the level less than 110 by 10 weeks to prevent fetal programming. So another change is now we are all changing our protocol for testing for GDM from 2-step to 1-step. Earlier it used to be ACOG, NDDG or Carpenter-Kusten, and now All the bodies, the WHO, DIPSI, International Association of Diabetes and Pregnancy Study Group, ADA, WHO, NICE, all are saying that we should do one test, because the two test criteria is going to miss about 25% of cases. And the government of India has laid down that DIPSI test is the only test. It is very important that it is irrespective of fasting status. If then the woman comes, we can do it with the help of a glucometer. Point of care testing is there, so there's no need to, we will not have a loss to follow up. It is easy, convenient, and also it serves both as a screening and a diagnostic test. There is change from venous sampling to point of care testing. So this is a paper where we can see that capillary blood glucose has a good sensitivity and specificity as compared to venous glucose, and has been endorsed by the national guidelines and also by FIGO 2015. We are also now having innovations like flash glucose monitoring, and we have used this in one of our theses, where Dr. Anupam Prakash, Dr. Sachin Jain were there from the medicine department, and we found out in 70 women that these women, 92% of them had hypoglycemia at some time or the other, and it was able to pick up glycemic variability and hypoglycemia at a much better this thing, and the acceptability was very good. As you can see here, this was a DKA patient which was managed in medicine ICU with the help of this modality. So the recognition of fourth dimension, glycemic variability. So many times we had SMBG normal, HbA1c normal, but still the problems were there. So the excursions, we are not now able to pick up with the help of this flash glucose monitoring and able to give attention to that. From selective monitoring of only high-risk individuals, now we are doing universal screening, because Indian women are 11 times more, have 11 times more chances of developing IGT. So universal testing is being advocated by most of the international and national guidelines. The other important thing is the change. Do you remember in our conventional books, we used to read that diabetes screening should be done at 24 to 28 weeks time. The funda was that maximum glucogenic hormones are being produced at that time. So if we are doing the test at that time, we are not going to miss any woman. But as you can see in the study, nearly 41% of women are being picked up even in first trimester, and 20% in the third trimester also. So these thresholds below the overt GDM can be detected in the first and third trimester. So screening should be done starting from the first trimester, and high-risk patient, it should be also repeated in the third trimester. This is one of our papers, which was done in Lady Harding in 800 women, and we compared DIPSI with WHO GTT and HbA1c. We found the prevalence in 2017 to be 6.25. The sensitivity, specificity, diagnostic accuracy was 98%, and there was a very good agreement between the two tests. This is another study. This is one of its kind. And for the first time, we compared the DIPSI test with the age-old ACOG, American College of Obs and Gynae criteria, both Carpenter-Kusten and NDDG. This was done in 1,029 women. We found that the prevalence came out to be 10.4 with DIPSI. It was 6.4 with Carpenter-Kusten, and NDGG missed nearly half of these patients, and the prevalence came out to be 3.1. In this study, we correlated with fetal-maternal outcomes and found that DIPSI correlates well with fetal-maternal outcomes. And the diagnostic accuracy of DIPSI was 90, with Carpenter-Kusten and NDDG both was 95%. From conventional insulins, which were our only tool, the regular insulin and NPH, which were available, now we have designer insulin. We have rapid insulins, Lispro, Aspart, and Degludec. We have the long-acting Glargine, Detamir, and Degludec has also been approved recently for use in pregnancy. Women who are taking Glargine can continue Glargine during pregnancy. And now the research is being done, and by nanotechnology, oral insulin is going to be available soon. Another very important change is that metformin till now did not have regulatory approvals for use in pregnancy anywhere in the world. But now the European Union in 2022, and mind you, it's a very stringent regulatory authority, has approved and this oral anti-diabetic which can be used safely from conception till confinement, till delivery. Another very important focus point is postpartum care, which used to be neglected by obstetricians, and the patient never used to visit the physician. Now we are giving enough importance to establish the service and make a collaboration with the physicians. Call the patient back at 6 weeks to test her for IGT, IFT, or diabetes, refer her, and this is high time. We recognize that hyperglycemia in pregnancy is a major global health problem. We are facing a slow motion disaster, and 2 of the 3 deaths globally are attributable to NCDs. So non-communicable diseases are programmed and imprinted during pregnancy. It is all starting in the utero, and it is time to focus on the fetus for the future. So diagnosis and management may help to turn the tide of diabetes NCD pandemic. Thank you all for a very patient hearing. These are some of my books. Thank you.
Thank you, Dr. Picky. It was a nice presentation. Any question from the audience?
Dr. Picky, you said GDM can be diagnosed in the first trimester. So how do you know that is not predated type 2 diabetes? Because we have lots of young people now.
Yeah, it's a very pertinent question. It's a good thing you asked, because if the threshold of that 126 or 200 is crossed, then it is type 2 diabetes. If it is less than that, then it is GDM. Also, we can do HbA1c. If it is 6.5 or more, then we say it is type 2. If it is less than that, then we say it is GDM.
That was impaired glucose tolerance. It could be pre-diabetes.
Impaired glucose tolerance is parallel to GDM during pregnancy. So that is what I showed in the first slide. I think we should be very clear about it, that impaired glucose tolerance in non-pregnant patient is equivalent to GDM in pregnancy.
Thank you.
And after delivery, we should do OGTT, not the DIPSI test, to find out whether she is having impaired fasting, impaired glucose, or diabetes. And we need to have a very good referral system to the physicians, diabetologists, endocrinologists, even pediatricians and neonatologists. In fact, the babies' cards of the mothers who are giving birth to their children, women with GDM, they should be marked as high risk. And these children need to be taken care of by the neonatologists and the pediatricians, because it starts thereafter. Babies less than 2.5 and more than 3.5, both are very, very prone to develop diabetes.
I think the presentation which you made was quite an eye-opener also, and it's important that because we are, most of the people here are physicians.
Yes, sir.
And you see, your point that people in the pregnancy, they have the impaired glucose tolerance. It is very important because many of these patients in the early pregnancy, they are missed.
Yes, sir.
And obviously, all those people who are getting high-end care, these things are quite noticed and managed. But I don't think that it is this kind of facilities available to all the pregnant women. That's one point. Second thing is that the diabetes actually from fetus and then it goes on. So I think the pregnancy is one important area where the obstetrician can play a big role in educating the mother and the family, because all these people, they are going to become diabetics in due course.
Sir, I think you have pointed out a very important point. It has to be a family counseling. The mother-in-law and husband also need to be involved. And sir, I would like to tell you that in Lady Harding, we are having a DIPSI room in which any woman who is coming for the first time during pregnancy is tested for hyperglycemia in pregnancy. And in the DLHS data, we are getting, sir, about 40 to 50% women with hyperglycemia. In my PG days, we used to find hardly 1 or 2 women with type 2 diabetes. Now there are about 10 to 15% women with type 2 criteria. And it is there in the statistics, in the national statistics. We are reporting a very, very high level, and it is very, very important. We need a total support of the physicians, endocrinologists, because these women are so high risk. They are getting preeclampsia, chronic hypertension, and the preeclampsia, chronic hypertension plexus, and dyslipidemia, BP, BMI, all these need to be checked in the postpartum and also in the pre-pregnancy place. Thank you very much, sir.
Thank you, sir.
Thank you.
Thank you very much. Let's conclude the session. Thank you.
Thank you, ma'am, for the wonderful talk. Now I request all the chairpersons to please felicitate the speaker. Now I request Dr. Vijay Arora, sir, to please felicitate the chairpersons at the presentation desk, which is just outside the auditorium. So for the next session, I sincerely request the following dignitaries to please come on the stage for chairing. Dr. Rajiv Bansal, sir, he's the consultant and director, East Delhi Diabetes and Cardiac Center at Krishnanagar. Dr. Dhirendra Kuber, sir, he's associate professor, Department of Cardiology at ABVIMS and RML. Dr. Pratap Singh, sir, he's professor, Department of Medicine at Safdarjung Hospitals. And Dr. Anshuman Srivastav, sir, he's associate professor, Department of Medicine at UCMS and GTB Hospital. So heart failure with reduced ejection fraction is a fairly prevalent and a serious condition that requires comprehensive management strategies to improve the quality of life, reduce the risk of hospitalization due to heart failure, as well as mortality. So next up is a case-based discussion of heart failure with reduced ejection fraction and how to improve the left ventricular ejection fraction by appropriate use of GDMT, that is guideline-directed medical therapy. So for this, I call upon the dais Dr. Amit Malik, sir. He's the Director and Coordinator Cardiac Science at Max Super Specialty Hospital, Vaishali. He's the first Indian cardiologist to receive the fellowship in electrophysiology from National Heart Center, Singapore. And he's trained in robotic-guided radiofrequency ablation. He's also served with Indraprastha Apollo Hospital, Delhi, and BLK Hospital in the past. He has a number of publications in various international and national journals. And he's a fellow of various important international cardiology scientific societies. Sir, please.
Good morning, and thank you organizers for this wonderful Sunday scientific buffet. And in respect of time, I would like to take you a journey of a heart failure patient and like to improve his heart failure in next 15 minutes with your support and expertise. So let's start with the case. This is 55-year-old gentleman, 78 kilogram, smoker, hypertensive. He is being treated with the telmisartan 40 milligram OD for last couple of years, and there is no prior history of heart failure event, coronary artery disease, or diabetes. He presented with a progressive onset of dyspnea for last couple of weeks, and now he's in the class 4 with orthopnea. On clinical evaluation, his heart rate is 90 per minute, sinus rhythm regular, blood pressure 158 by 90, saturation at room air 95, has basal crepts in the chest, and aspidal edema. This is the ECG on presentation and chest X-ray. ECG suggestive of fair normal sinus rhythm with couple of premature beats, no significant acute STT changes. X-ray chest suggestive of mild cardiomegaly with pulmonary venous congestion and subtle haziness in the left costophrenic angle. During investigation, we found the blood parameters, hemoglobin, creatinine, electrolytes, fairly normal. Pro-BNP markedly increased to 3,800 picogram per ml. His HbA1c and thyroid profiles were normal. On performing echocardiogram, which is, I think, an essential tool initially to investigate heart failure patient, the LV was pretty dilated with the end diastolic diameter of 5.9, volume overloaded with the end diastolic volume of 210, ejection fraction reduced 30%, PA pressure moderately raised to 50 millimeter of mercury with a normal RV function. So with the background of this investigation and clinical history, so he was diagnosed as a case of heart failure with reduced ejection fraction and hypertension. Now we have to treat this patient in next couple of minutes, and how the journey goes and how do you modulate your treatment. So I would like to participate you actively in the discussion. We all know that there are various heart failure guidelines, ACC or ESC, and now there are 4 strong pillars of the heart failure treatment in the form of AS-ARNI, beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitors. These all are the class 1 recommendations. You have diuretic if your patient is volume overloaded, and there are certain other therapies to help your patient in stabilizing and reduce the mortality. So based on these, as your patient was volume overloaded, and intravenous loop diuretics are the class 1 indication, the all patient who presented with acute heart failure with the sign and symptoms of fluid overload. So he was started on IV diuretic. I think all of the expertise here, they give their consent to start this. Should I go ahead? Yes. Okay. So IV diuretic was started. And how do we monitor IV diuretic response clinically? Once you start an IV diuretic, then watch the patient for the next 6 hours. If he is pouring sufficient amount of urine, almost 100 ml per hour, then it's the sufficient dose. If it is less, then you have to double the dose. These are the basically practical bedside guidelines. Patient becomes symptomatically better in next 48 hours. There is no orthopnea. He is able to lying flat. Body weight has reduced from 78 to 75.5. There is marginal increase in the serum creatinine because of the diuresis, potassium little bit on a low, blood pressure, heart rate, and saturation settle down. Now this is a time that you have to think about that what next to be offered to this gentleman. So there are 4 options with us. As he was previously on telmisartan, so he should continue with the telmisartan, add spironolactone and SGLT2, switch from ARB to ARNI, start with SGLT2 and add MRA, and switch from ARNI, SGLT2, MRA, and beta blocker, all 4. So how many people they would like to prefer strategy A? Okay. Strategy B? Okay. Strategy C?
What was the heart rate?
Heart rate has settled down now to 77. Okay. Initially, there was discussion and debates that if somebody is on ACE or ARNI, or ARB, do we need to switch over to ARNI. Now it's a well-documented and established fact that ARNI has got an edge over ACE and ARB. So now there is a class 1 recommendation to replace ACE or ARB to begin with these medication in reduced ejection fraction heart failure patient. So this gentleman was started with the ARNI, that's standard Viamata 50 milligram twice daily. The diuretic was switched over to oral, 40 milligram of furosemide. We add Leadcon, that is MRA, 25 milligram, and SGLT2 in the form of dapagliflozin, 10 milligram. Now to add beta blocker at this point is all physician discretion. If you think that your patient is clinically stable, he is euvolumic, and doesn't require IV diuretic, so you can add beta blocker. Now all these guidelines, they recommend intensive initiation and rapid uptitration before discharge. So you have to start all these 4 pillars before discharge of these patients and try to uptitrate the doses in next 6 weeks. So gentleman was ready to discharge on day 5 with NYHA class 2, reduced body weight, creatinine, potassium stable, NT-proBNP goes down from 3800 to 900. Vitals were quite stable, pre-discharge cath, normal coronary. So he was discharged on 50 milligram twice daily ARNI, Lasix, Leadcon, DAPA, and metoprolol 25. I think we all agree with this regime, or okay, so the gentleman was discharged and ready for the follow-up after 1 week. So he presented it to the clinic after 1 week, though he was pretty asymptomatic, but has regained little bit of weight. KFT potassium within the normal limit, but BNP has gone up a little bit. Hemodynamically, he was stable. So at this stage, what would be the strategy? So strategy 1, would you like to increase the diuretic and stop ARNI? Increase diuretic, stop beta blocker. Increase diuretic, reduce beta blocker. And increase diuretic and stop rest of the medication. So strategy A, anybody in the favor of A?
Because potassium is high, 4 points.
So B? None of the above. So we'd like to continue the same?
No, I like to reduce the beta blocker reduce.
Okay. So this is basically a recommendation that in the follow-up, if you have got an increase in pro-BNP of more than 10%, it's a time to increase your diuretic and reduce the dose of beta blocker. So diuretic dose was increased. MRA and DAPA dose remains same, ARNI dose remains same, and beta blocker reduced from 25 to 12.5.
Will switching to carvedilol or any other beta blocker help?
Switching from one beta blocker to another beta blocker, I think it's a different debate. We can indulge in that debate after this case. So the gentleman was followed up. At 1 month, he presented to the OPD, pretty stable. Body weight reduced. KFT remains stable. BNP goes down. Heart rate, BP, SpO2 pretty stable. So now it's almost 4 weeks of the treatment. So he was tolerating ARNI, so it's a time to increase the maximum permissible dose. So we increase the dose a little bit, reduce the diuretic at this moment, and continue with the same dose of beta blocker and SGLT2. So gentleman was followed for the next 3 months. So at the 3-month follow-up, he was totally asymptomatic, NYHA class 1. Body weight pretty dry, 72. KFT remain okay. BNP comes down within normal limit. Hemodynamically stable. So at this time, withdraw the diuretic at all. ARNI, MRA, SGLT2, and increase the beta blocker. So gentleman remains okay, follow-up, and at the 6th month of follow-up, so when echo was repeat, so he was in class 1, ejection fraction has improved and remain hemodynamically stable with KFT and BNP level within normal limit. So now it's a big question that what to do next. You have a gentleman, hypertension, dilated cardiomyopathy, reduced ejection fraction, heart failure. You treated well with guideline-directed medical therapy, followed him meticulously for next 6 months. He improved. Now, what would you like to do? You would like to stop the medication at this moment? Would you like to stop the ARNI and reduce the other medication? Or would you like to maintain the medication same as before? Okay. This is, I think, a very important. In 2022 ACC-AHA, we know that heart failure has been divided in 3 categories: reduced ejection fraction less than 40, mildly reduced 41 to 49, and preserved more than 40. They introduced a new category in 2022, that heart failure with improved EF. Those are the category which previously have ejection fraction of less than 40, and with the due course of time and your efforts and medication, the heart failure has improved. So this is the category, I think, in your clinical practice, you encounter most. And what is the recommendation for this? The recommendation is that guideline-directed medical therapy should continue to prevent relapse, treatment to be maintained, because there is 40% of the relapse of cardiomyopathy in next 6 months if you like to stop or reduce the guideline-directed medical therapy. So the take-home message for today's discussion is that you prioritize the initiation of guideline-directed medical therapy. So initiation of therapy takes over from titration of the drugs. Do not waste time in introducing the life-saving therapy. Try to introduce all 4 pillars of the heart failure treatment in next 4 to 6 weeks, and maintain the therapy even after improvement in the symptom and the cardiac functions. And thank you very much for your attention.
Dr. Malik, it was a very nice case presentation. But I have a concern we are not having an ideal condition in our society. So what are the barriers to follow this GDMT in our society, from the patient point of view, from the physician point of view, from the cardiologist point of view? Because
I think, sir, in any subspecialty of medical science, it is the awareness of the both side. One is the treating fraternity, and other one is the patient also. If we can convince the patient that this therapy, which improved your medical condition, you should follow it meticulously. Patient education, I think, in the heart failure, because it's a chronic condition.
Definitely.
So patient education is very important, so that they adhere to the medical therapy. Poor drug compliance will waste your effort.
Dr. Amit, excellent presentation, very simple and very clinical. So my question is that when would you like to withdraw the loop diuretic? Because loop diuretics have no mortality benefit, they just give symptomatic relief. And next is, how frequently should we monitor NT-proBNP? Because NT-proBNP is an expensive test. So how frequently, and what is the importance of,
Yeah,
that?
so NT-proBNP gives you a rough idea that this patient is, how much diuretic this gentleman needs. Once you achieve a threshold of your rest of the guideline-directed medical therapies, and your patient is euvolumic, is dry, is BNP reduced within normal limit, this is the time you withdraw the loop diuretic, continue with mineralocorticoid receptor antagonist and SGLT2 inhibitor, because they also act as a diuretic in these cases.
Good morning.
Once if you feel clinically that NT-proBNP is come to normal, your patient is NYHA class 1 or 2, euvolumic, there is no signs of fluid overload, you maintain like this.
Dr. Malik, this is very well-treated patient, this is ideal situation and ideally treated patients. But as Dr. Pratap said, that these are not the patients which we are treating. They're like we are treating in the government hospitals. Itna bheed, itna load, and we are not able to maintain. And patients are also not following religiously. I noticed in my practice, even the physicians, the students, PG students, and everybody who is looking after the patients of heart failure in the clinics, they themselves have hesitation to increase the dose. Patient come week by week, and patient have continued the same treatment. No uptitration of dose, even AC inhibitor, RNA, beta blocker, and there is no management of the doses. So the lacuna or ignorance on our part, inertia, yes, to upgrade or uptitrate the dose as per the, as the name says, GDMT and optimization of GMT. Optimization is not there in a real life. So take a message from this lecture must be that whenever you see the patient of heart failure, follow religiously and try to increase the dose which is advised to improve the mortality, which is shown in the trials that this dose is have mortality benefit. Otherwise, you are just giving them like treating like a candy. One question I want to ask to Dr. Amit, that this patient has improvement in the ejection fraction. Initially, he has reduced ejection fraction, then improvement of ejection fraction. Whether you subjected this patient for further evaluation for angiography or you...
Yeah, angiogram was already done pre-discharge.
Okay.
Yes.
The new drug that I've just heard about, where you see CAT, or what are the indications for that fifth drug that is?
Actually, still it is not a class 1 recommended drug. It's just an add-on. They said that because heart failure is an ongoing process, and what sir says correctly, that you need to titrate your doses as per the patient need from time to time. Vericiguat was introduced in cases when there is a worsening of the heart failure despite of the optimally dosing of the all 4 pillars of these things. But still, it is not a class 1 indication and not a drug to begin with.
One more thing.
MRA basically, yeah. So still, as per the guideline, as we have in Indian subcontinent, so your old timer spironolactone is good. If your patient can afford, eplerenone is good. If your patient can afford, finerenone is here. But finerenone is still not recommended yeah, it is not still in guidelines of the heart failure treatment. It is there with the nephrologist. Yeah, it is there with the
One more thing I want to highlight here, that when the heart failure, this is only not in the medical management. Whenever you, if you left the patient on medical management, definitely they will succumb with progress of time. So whenever you have the patient of heart failure, which is either managed or ejection fraction is not improving on the medical management, you must think for the further therapies like heart transplant and all these things, because this is a game changer in the treatment of heart failure with reduced ejection fraction. So we must think for that, and we must motivate for the people for the heart transplantation.
Before this GDMT, the survival in heart failure patient was less than 50%.
One last question. Atrial fibrillation with heart failure, any change in the...
Nothing changed.
Same.
Is there any role of reducing RNA if the ejection fraction improves more than 50%?
Yeah, that is why the new category they introduced in 2022.
That's for...
Yeah, still it's too early. Yeah, it's still too early to say, because still the guideline says they continue with the same. Maybe, sir, in next couple of years they will come out with the data. Still the data is that you have to continue, because there are 40% chances of the relapse of these patients.
Well, not even reducing the dose?
Not even reducing.
Okay, thank you, Dr. Amit. Now we can close the session.
Thank you, sir, for sharing your expertise and knowledge with us. Now I request all the chairpersons to please felicitate our speaker. Thank you, sir. Thank you, chairpersons. Now we request Dr. Ghanshyam Pangte, sir, to please felicitate our chairpersons at the presentation desk. Thank you, sir. So next, we have a panel discussion on recent advances in therapies for preventing and treating complications of diabetes. From groundbreaking medications to emerging technologies, we'll explore how these innovations are transforming the management of diabetes and enhancing patient outcomes. So now I request the following dignitaries to please come on the stage for chairing this session. Dr. Lalit, sir. He is director at his own clinics at Krishna Nagar and East End Enclave. Dr. Parus Kathuria, sir. He is professor medicine at Safdarjung Hospital. Dr. Praveen Bhatia, sir. He is former ICU in charge at Sir Gangaram Hospital, now running his own hospital. And Dr. R.M. Chhabra, sir. He is senior consultant physician and director at Chhabra Medical Center and Max Shalimar Bagh. Now, I would like to invite and briefly introduce our esteemed panelists. Dr. Nishant Raizada, sir. He's Associate Professor and Head of Department of Endocrinology, UCMS and GTB Hospital. Sir is Deputy Executive Editor at IJEM. He has over 40 publications in PubMed indexed national and international journals, and he has received the Sudhir Rehan Memorial Award and Dr. MMS Ahuja Award. Next is Dr. Rajiv Bansal, sir. He's consultant and director at East Delhi Cardiac and Diabetes Center at Krishna Nagar. He's member of ACP, AACE, and Endocrine Society of US. He has 2 international papers and 9 national papers, with an active area of interest in diabetes, non-invasive cardiology, and chest medicine. The third panelist is Dr. S.V. Madhu, sir. He's Director Professor.
Good morning, ladies and gentlemen. Dr. Anupam Prakash has to leave for some urgent cause, and I'll request Dr. Madhur Yadav to take his place. Dr. Madhur Yadav is Director Professor Medicine at LHMC. So today we have 4 panelists and 4 chairpersons, and we have a elite group including Dr. Professor S.V. Madhu, and the topic is recent advancing the therapies to prevent and treat diabetic complications. So this is the prediction in the prevalence of type 2 diabetes, which we can see. Now, we can see from this in North America, Caribbean area, South and Central America, Middle East and North America, Africa, and all these continents, what they are showing this different scenario in 2019, 2030, and 2045. We in South India, in Southeast Asia, along with Middle East and North America, we are leading as far as diabetes is concerned. So if you see the 10 top countries which we have as far as diabetes is concerned, China is leading with around 116 million people, followed by India. And in 2030, India will be having 101 million people, followed, and then by 2045, we will have around 134 million people. These are the people who are having confirmed diabetes. And as per ICMR Indian Health study, another 136 million people, those who are having pre-diabetes, they are also there who develop diabetes. So if you find, and the age group with maximum number of type 2 diabetes is a 20 to 64 years age group, which is the most productive age group. And these are the people who develop diabetic complications. So we need to prevent the onset of diabetes and the diabetic complications. So these are the most important complications of the diabetes, including micro and macrovascular complications, the peripheral neuropathies, diabetic nephropathy, stroke, CVS, heart attack, peripheral arterial disease, diabetic retinopathy, cataract, glaucoma, and diabetic foot disease. And apart from this, there are important behavioral changes which usually happen in patients with type 2 diabetes. They have not been included in this. And we'll start with the questions from our first panelist, and Professor S.V. Madhu sir. Although most of the topic has been covered by Dr. P.K. Saxena, but three important things. Can we have primordial prevention to delay the onset of diabetes or prevent the diabetes altogether? Is GDM preventable, or is it possible to halt the GDM complication in mother and fetus both? Professor S.V. Madhu sir.
Thank you. I think the morning, those who attended the morning lecture probably heard part of this area, but I just want to, it's working, but can you hear me? Yes. Okay. See, yeah, this is better. So primordial prevention, actually first we need to understand what is primordial prevention and look at it independent of GDM as well. So when we talk of primordial prevention in diabetes, we mean that preventive measures targeted at individuals who have normal glucose tolerance. That means you don't identify any high-risk group like IGT or anybody and then intervene to prevent diabetes. That will be primary prevention. So when we talk of primordial prevention, fundamentally it means this. That means the patient is at the moment normal, for example, obese individuals who may be having normal glucose tolerance. So independent of GDM, it is that. So any measure, including lifestyle changes to reduce weight, would be good enough in to cause primordial prevention of diabetes or type 2 diabetes in general. Now, in the context of hyperglycemia and pregnancy, the word primordial prevention actually would mean, because we all know that GDM is one of the important high-risk factors for future diabetes, both in the mother and in the next generation fetus. So if, in fact, it is said that, the risk of diabetes is almost 23 times in the mother. And as was shown in the morning, even the fetus, develops diabetes very soon, or by the age of 17 or 18, and starts developing several features of diabetes. And the programming of this occurs in very early pregnancy, which was told in the morning. Maybe as early as 10 weeks, you have the starting of the programming, which would later on cause diabetes. So if that is to be taken as the benchmark of future generation diabetes, and we want to say that we will prevent it by doing something to GDM, not allow GDM to happen, and keep the glycemic levels below a certain range in pregnancy, right from early pregnancy, and then hope that this will translate into decrease in diabetes in the future, in the mother as well as the next generation. That probably represents the concept of primordial prevention as far as GDM is concerned. Now, how do we do it? And to extend it a little further, there are people who say GDM is just an extension of, let's say, a glucose intolerance of pre-pregnancy. So it's just that somebody who is already in the borderline pre-diabetes or less than pre-diabetes but is predisposed, gets pregnant, he will fall into that mild glucose intolerance in early pregnancy that was talked about in the morning, and therefore probably our measures have to start even before pregnancy. These are the two things. So lifestyle intervention prior to planning a pregnancy probably is one of the measures for primordial prevention, because what does it do? It does two things. It prevents the elevation of hyperglycemia early in pregnancy, prevents GDM, and prevents the long-term consequence. The second more commonly thought out or popularly projected as a primordial prevention is detect early hyperglycemia, let's say 110 or more, that's what some people say, in early pregnancy, maybe 10 weeks, 12 weeks, or earlier than 10, 11 weeks, and then do something there, prevent GDM or maintain the hyperglycemia in pregnancy in that range, in the pre-GDM range itself, and hope that it causes a generational shift or decrease in type 2 diabetes in the next generation altogether. So that is the concept of primordial prevention, and there are several interventions. People have talked of lifestyle interventions in the first trimester. There are some proponents of giving drug treatment, although one has to take that with a little caution, because giving drugs at that phase of pregnancy may be a ticklish question, especially in the absence of a GDM, to treat hyperglycemia just above 110, for example. So, but there are both approaches, and you saw a study in the morning where metformin was given and prevented hyperglycemia, and we don't know about primordial prevention yet. At those studies in the morning and in other centers as well have shown that it decreases GDM. Now, whether this translates into a primordial prevention, we need to wait and see. I think that with that, of course, the other questions are very simple. If you manage glycemia in pregnancy, you will definitely prevent the feto-maternal complications at the end of pregnancy. There is no question about that. Many studies have shown, and as in the morning it was said, there is a linear relationship with the increase in hyperglycemia. It's a continuous relationship, the complication rates. And if you control the hyperglycemia, you do reduce complications, immediate complications, feto-maternal. On that, there is no question. You need to control GDM and treat GDM to target, whereas primordial prevention is probably a newer thing for the future, what we are discussing now.
Thank you, sir. My next question is, to Professor Anupam Prakash, who is left now. Dr. Madhur will be answering these questions. Can early screening help in preventing the onset of diabetes and managing complications? What strategy should we adopt for following complications like nephropathy, neuropathy, retinopathy, or vasculopathy?
Well, as Sir has already pointed out, that there is a prevention and early screening during the course of disease, yes, can help in knowing the disease and halting its progression also. For diabetic nephropathy, as you all know, the common test is microalbuminuria in the spot urine. This can be done early also. Then we have first screening at the diagnosis of type 2 diabetes and 5 years after the diagnosis of type 1. And subsequent screening can be done annually. Strategies for prevention of diabetic nephropathy are the early approach, in which we have got blood glucose control, blood pressure control, as well as lipid control. And intermediate approach includes that we should have a continuous monitoring, and late could be dialysis and organ transplant. This was for diabetic nephropathy.
Yes,
now for diabetic retinopathy, we have retinal screening, the most common being about ophthalmoscopy, the fundal photography, and visual acuity. For first screening, when to be done at the diagnosis of type 2 diabetes, and 5 years after the diagnosis of type 1, and subsequent screening to be done annually. Strategies for prevention of the diabetic nephropathy are the same as we have for diabetic neuropathy: early approach, intermediate, and late approach. Early approach includes blood pressure control, the blood glucose control and lipid control, and the intermediate approach includes ACE inhibitors, and late approach includes dialysis and transplantation. For coronary artery disease, tests are we have screening by ECG. We can use other tests also for detecting latent ischemia, as 24 hours Holter monitoring. The first screening is same as we do for retinopathy and prevention of neuropathy at the time of diagnosis of type 2 diabetes, and clinically appropriate for type 1 diabetes. Subsequent screening to be done annually. Early prevention is the same as blood pressure control, blood glucose control, and lipid control. Intermediate approach is antiplatelet drugs, and late approach is revascularization and or surgery. For peripheral vascular disease, it is nearly the same, except that the test to be done is basically clinical examination of pedal pulses and auscultation for bruise, peripheral Doppler, ankle branchial index. First screening at the diagnosis of type 2 diabetes and clinically approved for type 1 diabetes. Annual screening to be done as subsequent screening. For prevention of peripheral vascular disease, we have blood pressure control and blood glucose and lipid control. Intermediate approach is antiplatelet drug, and the late approach is same as revascularization and surgery. So by these methods, yes, we can control the complications of diabetes.
Thank you, sir. Now we can predict the complications and we can control the complications, and how we should screen the patients of different complication has been depicted by Dr. Professor Madhur Yadav. The next question is to Dr. Nishant Raizada. How helpful is the use of FDC or different OHA in preventing diabetic progression and complication?
Thank you, sir. So in the Indian setting, still the first line pharmacotherapy continues to be metformin, but a fair number of people will not have good control on metformin and they will require a second drug. When we are choosing the second drug, now we have medications which not only improve the glucose, but also address several complications. So based upon the patient characteristics, if the patient has got, let's say, CV risk factors, he's got dyslipidemia also, he's a smoker. So it'll be a better idea to go for a drug which has some proven CV benefits instead of some other drug. Similarly, if somebody is struggling with obesity, where obesity is a dominant factor, you probably would like to go for a GLP-1 agonist. So in these circumstances, the choice of the second drug becomes not only glucose-centric, but also complication-centric. So SGLT2 inhibitors, we already know these drugs are been around for quite some time now. They've got a slightly paradoxical way of working. They cause glycosuria, so you always get a 4+ in the urine, which sometimes scares the patient, so it's better to tell them beforehand that it's going to happen. But despite that factor, they have got protective effects on the kidney. They've shown benefits in the CV outcomes. So they are definitely preferred drug, and even in non-diabetics, as we saw in the previous lecture, they are being used in heart failure also and approved for use in heart failure. So this molecule has got multiple benefits. So broadly coming to the issue of FDC, the advantage of FDC is that FDCs give you better compliance. Probably patient has got less pills to take, so more likely to be taking all the pills. But the downside is that every drug has got a specific way of timing of dosing. The frequency of dosing is there before the meal, after the meal. For example, a commonly used triple drug combination is glimepiride plus metformin plus voglibose. Now, glimepiride is supposed to be before the meal. Metformin is supposed to be after the meal. Voglibose is supposed to be with the meal. So you give it once. So you're going to be erring on at least 2 counts. So if you give it before the meal, then metformin and voglibose is given at the incorrect time. So some loss of efficacy might occur because of these reasons. And second thing is, if you want to uptitrate the dose of one of the particular drugs, then you have to change the entire tablet. So that's another issue. So I think the trade-off is there. So we have to look at the patient characteristics. If the patient doesn't seem to be a very compliant person, probably he'll have to live with a lesser efficacy and go with the FTC. If the patient is educated, if we're able to educate him properly, then probably we can give individual drugs also.
So, Nishant, now after the patent is gone of most of these gliptins and gliflozins, and now there is a bombardment from different companies with the triple drug combination of gliflozins, gliptins, and metformin. So where they stand in our day-to-day clinical practice?
It has been a boon for most patients who earlier were not able to afford because the drugs were exorbitantly priced. Now you can get it quite cheap. And sometimes the combinations appear to be cheaper than the individual drugs taken. So that is a push which comes from the pharma side. So again, the same thing, most of the, for example, dapagliflozin was supposed to be given an OD dose, but if you put in a fixed dose combination, probably you'll have to give it twice a day. So again, issues with those will still be there. But I think there are cheaper individual drugs also available. And so basically it all depends upon what kind of patient you're handling. If your patient is a smart patient, you're able to explain to them the way it should be taken, then there's no need to push for the FDC. But of course, if the patient doesn't seem to be interested in taking too many medications, probably it's better off to get the benefit of the drug even with that FDC.
And the tagline of hit early and hit hard, is it good for diabetic control vis-a-vis legacy effect?
Definitely, sir. Additional advantage the SGLT2 inhibitor would be that they are going to cause some amount of weight loss that will vary from person to person, but especially in the more obese people, the weight loss seems to be more pronounced, and they seem to be quite efficacious in bringing down the HbA1c when given as an add-on to metformin as compared to something like maybe a DPP4 inhibitor or maybe acarbose or voglibose. So in that context, the results would be much better with SGLT2.
Thank you, Dr. Nishant. Now, what are the cutting-edge technologies in preventing that and treating different diabetic complications, including neuropathy, diabetic foot disease, erectile dysfunction, female sexual dysfunction, diabetic liver disease, and diabetic gastropathies? Dr.
Thank you.
Bansal,
Thank
please.
you, Dr. Vijay, and thank you very much for the organizers to giving me an opportunity to part of this panel. I have a nostalgic feeling because I was in Lady Harding from 94 to 2001. So no building was there at that time. A lot of change. So as far as these complications are concerned, first of all, I must say that these are all nightmares for the physician, all these complications which we have enlisted. And they are very less talked about, and they are often neglected. So let us start one by one. Cutting edge treatments for diabetic neuropathy. Diabetic neuropathy is a debilitating complication, and most of our patients at some point of time, they complain about this complication. And the recent advances in the treatment, they aim to manage the symptoms and the patient. So they can be, the emerging therapies are anti-inflammatory drugs, nerve growth factors, and sodium channel blockers. So there are a lot of new research which is going on. Talking about the neuromodulation techniques, spinal cord stimulation is there, where the electrodes are implanted and they deliver targeted electrical pulses. Then peripheral nerve stimulation, where again electrodes are placed near the peripheral nerves and can disrupt the chronic neuropathic pain. Transcutaneous electrical nerve stimulation, non-invasive TENS unit supply electrical stimulation through the skin. Also, as far as the regenerations of the nerve is concerned, the approaches are there in the form of cell therapies, transplanting the stem cells or progenitor cells. Then gene therapies are there, delivering genetic material to enhance the body's own nerve healing and growth, and tissue engineering. All these are still going on, and maybe in future we have definite answers to all these approaches. And on the top of that, the robust foundation should be lifestyle intervention and self-management, because nothing is complete if it is not there. So exercise is very important, like soft exercises like walking, swimming, yoga can improve the nerve function, pain management, like doing mindfulness, acupuncture, and topical treatments. Nutrition is very important, dietary changes to promote the nerve health, such as increasing the antioxidants and health fats. And patient education, again, is very, very important, all this. So, it's a combination of all these things which we can really help the patient. And if you talk about the preventing diabetic neuropathy, strict glycemic control is number one. Then early recognition and early intervention of diabetic neuropathy, simple tests like monofilament test and in the clinics can really, identify these patients. And then comes the comprehensive care, where multiple therapies, integrated approach is required. So the future directions are the ongoing research and interdisciplinary approach between different specialities to provide comprehensive personalized care and patient-centered care. And this is a paper which is talking about a molecule NS1-189, where the amelioration of both central and peripheral neuropathy in mouse models have been found. And maybe in future we have drugs for the humans also. Talking about the extension of this diabetic neuropathy is diabetic foot. And here we can see normal foot on the left side and the diabetic foot ulcer and then amputation stump. So the underlying conditions again are persistent hyperglycemia, which leads to inflammation. And then there are certain predisposing factors, inciting factors, the blood supply, the loss of blood supply, the loss of motor function, autonomic neuropathy, dryness of the skin, and all these factors, they lead to diabetic foot. And then sometimes a stage comes where some amputation has to be done, which is a complication of diabetic foot. This is the severity of diabetic foot ulcer. So I'm not going into the details because it's already it's one lecture. And this is one latest cutting edge machine for the diagnosis of diabetic foot. This is called spectral hyperspectral imaging. And this machine identifies the areas where the blood flow is compromised in the form of deoxy and oxy-deoxy patterns. You can see on the left side where the deoxy pattern is there, the healthy blood supply, and the oxy-deoxy pattern, the blood supply is compromised. So this is a very good machine, very handy, non-invasive machine, which can identify the diabetic foot at a very early stage. The similar machine, this is a little different, and this is a molecular therapy machine showing again use in the identification and diagnosis of diabetic foot. Coming to next important complication, erectile dysfunction, which is again very less talked about and not often discussed with the patients. Male patient, they do tell the complaints, but female patients are definitely, they do not discuss this. It affects almost 40% of men with diabetes, and 40% of men more than 60 years with diabetes have complete erectile dysfunction. So it is common as well as important. And if you see the treatment approaches, first and foremost is the tight glycemic control, and then maybe psychological counseling, behavioral therapy. These are the non-pharmacological approaches. And then self-help techniques, then extensive retraining programs, mechanical aids. Then comes the drugs, oral therapies like PDE inhibitors, injectables, devices, and surgery. So the behavioral and pharmacological therapies in managing erectile dysfunction is very important. I think one should discuss with the patient openly about these complications. And there are newer drugs also. If you see the latest drugs, oral drugs like DPP-4 inhibitors and SGLT2 inhibitors and GLP-1 receptor analogs, they also have positive effects in terms of reducing the endothelial dysfunction and increasing the nitric oxide, thus increasing the blood supply and thus improving the erectile dysfunction. The sexual dysfunction in females is often neglected. We have missed that part. And it is, again, should be discussed with the female patients, because most of the female patients, they are very reluctant to discuss about it. And again, psychological counseling is most important in that, because that plays a major role. And then we have, according to the symptoms, we have drugs for the patients. We have hormone replacement therapy. We have PDE inhibitors. We have topical agents, which can really help and improve the quality of life of the patient. Talking about another complication, NFLD and diabetes. Again, NFLD is very, very common in diabetic patients, and it can be divided into pure steatosis or mild lobular inflammation or NASH. So there is no definite treatment as such till now. Lately, one drug has been approved by FDA, but till now, no definite treatment. The most important treatment for this is strict glycemic control, and second is weight loss. So weight loss is the most important factor. If we can reduce weight by 5 to 10% of the basic weight, we can really help the patient in reducing the fatty liver or reversing the fatty liver. So moderate calorie restriction, around 500 to 750 kilocalories per day, leading to loss of weight of 7 to 10%. And then some studies consider about regular coffee consumption, 2 to 3 cups per day. Exercise is very important. So all these things can improve the liver function. Drugs like SGLT2 inhibitors, they have really shown improvement in the decrease in the visceral fat. E-lift study we all know about with empagliflozin. Then vitamin E has a role, 800 to 1000 international units daily. And pioglitazone have shown remarkable improvement in NASH, but the downside is that it causes weight gain over a period of time, around 4 kg weight gain. So that is not desired. Pentoxifylline, 400 milligrams, have shown improvement in NASH and fibrosis, but there is limited data on histopathology. Then weight loss by doing bariatric surgery in different ways can really help NASH in these patients. So this is a phase 3 randomized controlled trial of this drug, which I was talking about. It's been recently approved by US FDA, resmetirom, in NASH with liver fibrosis. And it has shown around 26% reduction or reversal in NASH by using this drug. Another is targeting a ceramide double bond improves insulin resistance and hepatic steatosis. But these are, again, still not yet approved. Another important complication, diabetic gastroparesis. newer technologies to manage these are electrical stimulation therapies, endoscopic therapies by botulinum toxin injection, gastric peroral endoscopic pyloromyotomy, POEMs, gastrostomy and gynostomy tube placement, surgical therapy. But again, diabetic gastroparesis, again, more of psychosocial. So a lot of patients who have low esteem, or they have a depressive or psychosocial aspects, they suffer from this gastroparesis. So it is important to address that part also. Thank you very much. I think it was.
Now the next question to our chairperson is, how the diagnostic tools help in controlling the diabetes? Dr. Lalit?
Well, we all know that we have been using the diagnostic tool for control diabetes, the glucometers. So we have two types of glucometers, standard and continuous glucose monitoring. Standard we have been using these days, and every time we prick the finger and take the capillary blood and do the blood sugar levels. And continuous glucose monitoring, we have to only prick once only, and we keep changing the sensor for check the blood pressure, sugar level. But only thing I want to say in the standard glucometer is you must check verify whether your glucometer is showing the right reading, and always compare with the lab test also. But for doing the lab test, you would take the venous sample from the lab test, but for the glucometer, you should take the capillary blood only. If there is difference in 15%, then the glucometer is doing well. And in continuous glucose monitoring, as we have been already using in high-risk cases and where the high episodes of hypoglycemia or hyperglycemia is there. So it is very advantageous using such cases, high-risk cases, and we are scared of getting hypoglycemias or very high level of hyperglycemias. Thank you.
So, Dr. Lalit, the use of CGM has been very, very helpful as far as TIR is concerned, because if you maintain the TIR in more than 70% of the time, then there is no glycemic variability. The resultant effect is much better as far as HbA1c is concerned, as far as microvascular complications are concerned. So this controlling HbA1c alone or controlling the TIR has a different effects on the diabetic microvascular complications. Correct. Thank you, sir. So my next question is to Professor Madhu. We all know that in diabetes we have a mixed type of dyslipidemia, especially in the Indian scenario and Indian phenotype. And we have high triglyceride levels most of the time. So I'll request Dr. Madhu to elaborate this, addressing the Indian phenotype and the triglyceride lowering and the CV risk reduction in type 2 diabetes. Professor Madhu.
Okay. I think triglyceride lowering has been a subject of a lot of debate, controversy, and disappointment over the years, because while we know that triglycerides are associated with high CV risk, none of the studies have actually demonstrated that by reducing triglycerides you actually prevent long-term cardiac events. So that has been the disappointment. And I thought and the Asian Indian phenotype is being shown, so we are much more prone to this what we call diabetic dyslipidemia, where TGs are high. Now, the important thing, or I have been always saying, last 20 years I've been working on postprandial triglycerides, and I've always been saying in most of my talks that part of the reason why we don't have good effects on triglyceride reduction is we are focusing on the fasting triglycerides, and we are not targeting the postprandial triglycerides, because many people who have normal fasting triglycerides continue to have elevated postprandial triglycerides, and they are known to be an independent risk factor for cardiovascular risk in future. And unless we target that, you're not going to get the desired benefits. That is one of the important reasons. Now, the same concept has now been, in January issue, I think, of Frontiers in Endocrinology, a very good review article is there for those who want to read, on developments regarding triglycerides and the need to change from an LDL-focused CV risk reduction strategy to a TG and particularly chylomicron-focused anti-CV risk reduction strategy. I've been talking about this for 20 years, but now because of lots of developments which have taken place, and I thought it will be appropriate for this particular discussion. Chylomicrons were never thought to have any cardiovascular risk. Most of the time, we would talk of VLDL to some extent, but the source of VLDL was the liver. So postprandial triglycerides, why should something happen after meal? Because meal only increases chylomicrons. And what has that got to do with cardiovascular risk? That was the concept. But now the concept has totally changed. If you read that review article, I'm not going into the details, every detail has been worked out, and it has been shown that probably the LPL, or the lipoprotein lipase at the muscle and the adipose, is the controlling factor for the postprandial lipids. And it is this elevation which is important for cardiovascular risk. And therefore, newer targets on how to clear chylomicrons from the circulation are emerging. And they probably in the future will become important agents for CV risk reduction. Now, insofar as the TG risk reduction is concerned and the developments in that, although several studies showed that TG risk reduction doesn't cause any CV benefit, sub-analysis did show, even in older trials, that if you were to select out patients who had a high TG along with a low HDL, that means what we see in metabolic syndrome, those people seem to benefit more, or seem to benefit in terms of UV risk reduction. Others would not. If you have TG which is high but a normal HDL, that subpopulation would not. And with that in mind, recent trials were conducted. That whether, the range of 140 to 399, or some people even say 499, where we don't treat triglycerides, they were specifically targeted, especially in association with HDL, low HDLs. And the newer agents, which are the PPR alpha agonists, they were tried. Pemafibrate is a newer agent, which was tried to look at this particular issue, to see whether in this group, actually it is, and it's a randomized double-blind control trial, they did not find any benefit, which means even that so-called sub-analysis has not borne out in a usual randomized control trial as late as 2023 or maybe even 2024. It is not borne out. Same way, all the omega-3 fatty acids. Even a recent study has shown it reduces triglycerides very well, but it doesn't have any cardiovascular benefit. An analog of omega fatty 3, isopentyl, I think, does have cardiovascular benefit, but not related to TG reduction. So these things still remain, and the newer... Yeah, saroglitazole causes decrease in triglycerides. That is fine. But future CV risk reduction, again, a question mark. That is the problem. TG risk reduction, a lot of drugs are available. But the newer agents, which I'm just about to say before I finish, two agents focusing on the chylomicron metabolism and the clearance of triglycerides. One, an anti, we've heard about the lipoprotein C3, apolipoprotein C3, which controls the reuptake into the liver of the fats of the triglycerides. Inhibitors of that have been shown, what is called it's called, I think, olezarsen, and that has shown significant 50% reduction in triglycerides. Again, these are recent studies. Long-term cardiovascular benefit is hoped. We do not know, but that is one thing which is targeting triglycerides with substantial TG reduction, not 20, 30, 25%, almost 50% TG reduction. Whether that's going to translate into CV benefit, we have to wait. And the last agent, which is again for the future, is something we call angiopoietin 3 inhibitors. So these are agents which actually act on the LPL. I was telling you the LPL is the enzyme which clears chylomicrons and the VLDL from circulation. So by using those agents, again, it has been shown very clearly that triglycerides can come down by almost 40%. Even LDL is reduced by 50%. And these agents are recommended in familial hypercholesterolemia now, and approved also. So if these agents, probably because of the amount of TG risk reduction, may be the drugs for the future, where the TG as a target might become more and more important.
Sir, could it be because we are always following the Western guidelines and we never followed our Indian guidelines and our Indian people and Indian studies, that we have mixed type of dyslipidemia, where in Western countries it's not the triglyceride levels which are higher, and most of the time it is the LDL they have targeted.
Yeah, that's what I'm saying. So they have a lot of obesity and more associated with LDL increase, and we have a more carbohydrate-centric dyslipidemia, which is more like a metabolic syndrome, and for us, triglycerides matter.
Yes.
And we need to control it. Particularly in South Asians, TG cannot be, you cannot escape from TG control. The only problem, as I was mentioning, was that studies or trials have not borne out that reducing TGs work. That is the only problem in terms of severe risk reduction. So I think there are certain errors we've been making. We look at postprandials, we look at severe or significant TG reduction by these newer drugs, and maybe it will in the long term also help in severe risk reduction.
Sir, in continuation
Because most of the residual risk after LDL is controlled is due to hypertriglyceridemia. This is a well-known fact.
So
No, Indian fasting TG is the same, but if we have to target postprandial TG, 200 is the target. 4-hour postprandial, 200 is the target. But these have not been borne out by long-term severe risk reduction trials. We need to do them.
So one question to you, sir. So like we see when the blood sugars are high, TG is automatically high, and we control the sugar, TG improves. So ultimately, it is about the sugar control that is also an important factor.
No, what you're saying is correct. So we don't target TGs before we control sugars. That's a basic principle. So first we bring the sugars under control, and if whatever remaining triglycerides are there, we have to target them. And even in non-diabetic individuals, hypertriglyceridemia may be there, and we need to target them even there. But I fully agree that if the patient has hyperglycemia, first you need to target the blood glucose, bring it under control, and then look at triglycerides.
So in continuation with this atherosclerotic phenomena, then yes. Can you elaborate the role of GLP-1 RA? Yes, sir.
Somebody else should answer. I think I've had enough. Maybe Nishant might want to answer. See, these are newer agents which are available. We all know that they're agents which have come up for treatment of obesity. And the main thing about these agents are that, they have been associated with substantial weight loss, which was a major limitation with anti-obesity agents of the past. While 5 to 10%, 5% mostly, rarely 10% weight loss was achievable with the traditional agents with all the side effects, and most of them had to be withdrawn. These agents which have come now actually, which were mentioned, put on the chart, actually have 15 to 25% weight loss achievable, almost like a bariatric surgery. So they might replace bariatric surgery in the long run in terms of, and all the benefits that would accrue by that weight loss in terms of sugar control, severe risk reduction, all those would take place.
Thank you, sir. As Dr. Nishan, the newer therapeutic tool like gene therapy, stem cell therapy, nanotechnology play important role in coming time to prevent and delay the onset of diabetic complications.
So there has always been a lot of interest in these newer tools, specifically nanotechnology. Broadly, nanotechnology refers to small microscopic man-made particles which you could introduce into the body, and you could program them to do specific actions as they're programmed to do. So one example could be like we give the insulin in the systemic circulation, but exactly the body produces own insulin, it goes in the portal circulation. So it's unphysiological. So with the use of nanoparticles, probably you could deliver insulin into the portal circulation. You could have a smart insulin which particles secrete the insulin only when the glucose level goes above a certain value. Then you could send these particles to the kidney and deliver the ACE inhibitor directly to the kidney rather than to the entire circulation. Or you could target specific inflammatory markers in the kidney. You could target the VEGF production in the retina and thereby reduce these complications. But they have been tried out in animal models where the success has been plus minus. There are no human studies at all to my knowledge, and it has been like this for several years and maybe a decade only. So there are some hiccups in translating nanotechnology into a clinical practice. I'm not sure what the hiccups are, but it's still something you have to look forward to.
The last question to Dr. Rajiv Bansal. The newer fast-acting insulins and the insulin analogs, especially the weekly insulins and weekly GLP-1 RAs, how they are translating into the reduction in the diabetic complications?
So medical science is always evolving, and in that context, the insulins are also evolving and the GLP-1 receptor analogs. So it is always better to have newer molecules, and the idea of developing all these new molecules is to decrease the glycemic variability, number one, and to decrease the incidence of hypoglycemia. And number two is to increase the compliance and adherence. That is why these weekly molecules have been developed. And I'm sure these are going to help a lot, especially this weekly basal insulin icodec, which is going to be a major, a game changer in the management of insulin therapies in the patients. Insulin. So all these, newer insulins are always welcome, and newer GLP-1 receptor analogs are always welcome because they are totally, changing the way we used to treat diabetes.
The last question from chairpersons. Any role of insulin pump therapy versus insulin injection in controlling type 2 diabetes complications?
Definitely, especially in the type 1 diabetes, hypoglycemia and the ketosis, both are the very complication. If you use the pump, then there is a chance almost nil. I will not say but nil, but almost nil. The chance of hypoglycemia and the ketosis, both complications can be prevented if you use the insulin pump.
Thank you, sir. I'll thank all the chairpersons and all the panelists. Thank you very much.
Thank you all the panel members for enlightening us and making us wiser. I also extend my thanks to Dr. Vijay Arora, sir, for guiding the conversation. Now I request all the distinguished guests on the stage to please proceed to the presentation desk outside. Now we have a very interesting debate session on whether the diabetes diagnostic threshold should be lowered. So as rates of pre-diabetes and diabetes continue to rise globally, this contentious issue is bound to spark dialogues and discussions among the healthcare professionals. So we'll have experts joining us to weigh the pros and cons of adjusting the diagnostic threshold, considering the potential impact on public health, patient management, and healthcare resources. So now I request the following dignitaries to please come on the stage for chairing the session. Dr. Deepak Sharma, sir, Associate Professor, JIMS, Noida. Dr. Ghanshyam Pangti, sir, Director Professor, Department of Medicine, LHMC. Dr. Lalit Gupta, sir, Professor in Maulana Azad Medical College. Dr. Pooja Garg, ma'am, Consultant, Max Hospital. Dr. Sunita Agrawal, ma'am, Director Professor at Maulana Azad Medical College. And Dr. Rajiv Gupta, sir, Consultant Physician at East Delhi. Now I welcome our esteemed judge for the debate to the stage, Dr. Pankaj N. Chaudhary, sir. And I also invite our two distinguished speakers for the debate, Dr. Paras Gangwal, sir, he will be speaking in favor of the topic, and Dr. S.K. Gupta, sir, he'll be speaking against the topic. Dr. Pankaj Nand Chaudhary, sir, is a senior consultant and academic head at Max Super Specialty Hospital, Vaishali. He's the past president of IMA West Ghaziabad. He's president of EDPA. He has delivered lectures on various state and national academic forums. He has authored few chapters in API Textbook of Medicine and has around 25 publications in various national and international index journals. Dr. Paras Gangwal, sir, is consultant physician internist and critical care expert affiliated with the East Delhi Medical Center and Paras Gangwal Clinic. He has received many awards and honors. He's the founder director of Tohfa, a Gift for Life campaign, and has publications in national and international journal chapters in different books. Dr. Professor S.K. Gupta, sir, he's the honorary professor of medicine, IMA headquarters. He's a teaching faculty at GS Medical College, Uttar Pradesh. He's author of the book Journey of COVID in India and has more than 70 national and international publications. He has received awards, DMA Health Ambassador Award in 2022 and ACP India Internist Award in 2023. So first I call upon Dr. Paras Gangwal, sir, who will be speaking in favor.
I think before Paras starts, right, so what is the topic all about? And I think a lot of postgraduates are there in the audience. I think there is a very interesting debate. So as a judge, Joe, I understand this debate that why diabetes thresholds are, changed to pre-diabetes threshold. This is possibly I understand with this debate, right, Dr. Gupta? So, right. So we all know that, India is the diabetes capital of the world now, more than 100 million people with diabetes. Pre-diabetes we don't know because there are a lot of screening issues. Dr. Maheshwari is there, he's doing a lot of work in diabetes. So I think if diabetes are 100 millions, so what about pre-diabetes, right? So I think that data has been missed, and lot of trials have come up to know the complications in the pre-diabetes. In a clinical practice, I do see a lot of nephropathy, neuropathy in pre-diabetes state also. So the debate is that whether the diabetes threshold is lower to pre-diabetes. So for the motion, I think, I think Dr. Paras, a dear friend of mine and is the past president of EDP also. So he would be taking that why it should be lowered, right? So then we'll invite Dr. Gupta sir. Okay, why shouldn't be lowered? So I think it's a very interesting debate. I think we should all participate, chairpersons, and you do see a lot of complications in pre-diabetes as well. So let's start debate and let we have the conclusion that why we should work on this particular topic. Dr. Paras, your turn now.
Thank you, Dr. Pankaj, for introducing the topic. And dear friends, we'll be discussing why should we be lowering the diagnostic thresholds for diabetes. We all know that more than 2 in 3 people with diabetes already have complications when they arrive in our clinic with the current defined thresholds. But we have diagnostic challenge with currently provided diagnostic thresholds that we have for diabetes and pre-diabetes. What are these challenges? The challenges are that if we apply these guidelines, then within the same community, we find different results like IEC guidelines or ADA-related fasting glucose levels or WHO guidelines. Within the US community, the prevalence of pre-diabetes would vary based on these guidelines from 4.3 to 48.5. And then HbA1c would have a variability within the sex, male to female, within every increasing year. With race and ethnicity, the HbA1c in different races is going to be different. But what is the similarity? Similarity is that whatever time we diagnose pre-diabetes, the hazard ratio for chronic kidney disease, cardiovascular disease, and all-cause mortality is always found to be increased as compared to the normal person. There is one more fact to know, that diabetes is actually a continuum. The dysglycemia is a continuum. It's not defined by the numbers. Whatsoever is above normal is actually abnormal. And we see the evidence here. Like look at time until diagnosis of diabetes. Minus 14 years from the diagnosis of diabetes, you have insulin sensitivity and beta cell functions which are declining. And at minus 6 years or 4 years, you have 2-hour postprandial glucose going up. So we have to actually go further understanding this concept. Pre-diabetes is not a single number, or diabetes this with the available tools and advances. Because what is happening in our body, the biological changes and the damage at the level of cellular level, sorts of micro and macrovascular complications, the whole. So dear friends, there is a need for early intervention, because as the diabetes happens, person is put on a racetrack of cardiorenal metabolic dysfunction, which is speeding fast to make him with a lot of morbidity and mortality die sooner than a normal individual. So we need to intervene fast and early to win this race. And we really need to dissolve these boundaries of pre-diabetes, probably as a better understanding to evolve faster. Because complications in pre-diabetes, I would give you 2 analogies. One, probably God designed us to a temperature. I would define HbA1c 5.5 as 55 degree, 6.5 as 65 degree, HbA1c 7.5 as 75 degree. So God probably designed our body to survive 100 years with a temperature gradient of 35 to 55. But we are putting our patients on a burner at 65 degree, 75 degree, even when they are. I think it's not diabetes. It's cancer diabetes. Our friends in oncology have done better. They are doing such an intensive regimen to make their patients survive for 3 months, giving all the expenses. But we, who can enhance the life by 3 decades, are not having an intensified regimen to control our diabetes. We are every time slow and sluggish. We are always, instead of intensive phase, in a slow phase of our diabetes management. And we learned long back, 3 decades back, there is something known as metabolic memory and the legacy. But what are we giving in the legacy? We are accepting 6.5 and 7 as the target, while my is 4, yours is 5, your patient coming to your clinic saying, doc, my HbA1c is 6, do I need to do something? No, beta, thoda sa exercise kar lo, thoda sa weight loss kar lo, things would be fine. Will accelerate when you reach to 7, will accelerate when you reach to 6.5. That means 1.5 HbA1c higher when everything has been proven. There is something known as metabolic memory and the legacy. So what legacy are we giving in the first decade? You are burning them out. Then we, by not defining this, are denying them the insurance and the treatment accessibility. We are raising the cost of the healthcare of an individual family. Because if they can be managed, in the OPD, as per the available study in India, they spend just 3% of their annual budget on diabetes care. If they are managed in indoor, they spend 10 to 25% of their annual budget in the indoor management of their complexities or when the morbidities have evolved. So there is a huge economic burden. It's a global epidemic with 450 million people. It's the leading cause of premature death. 9% of all deaths, 1.5 million deaths occurring. So we need to evolve to cost effectiveness by lowering the diagnostic thresholds so that all can be managed better. They all can survive to those years when they are going to be productive in the 5th decade of life, 6th decade of life, rather than becoming dependent on 5th decade. I think we need to lower the burden. See, there's 88 trillion economy of the world consuming $1.5 trillion in the management of diabetes. India, GDP 300 lakh crore of Indian economy, 1.5 lakh crores spent on diabetes. 6 lakhs is our defense budget. So that's the huge volume that we are spending on diabetes. And then it is very much clearly shown in the earlier trials that initially it might look that with intensive management the costs are higher, but the approach is cost effective and long term due to the reduction in severe complications that are expensive to treat. So reduce the complications, it's going to be cheaper to treat them. The advances in therapeutic options. There is well-defined algorithm available by the Endocrine Society to take care of our patients from lifestyle intervention to medically assisted weight loss therapy to wonderful drugs in form of metformin, pioglitazone, liraglutide, acarbose, all with proven benefits and if still failing the bariatric surgery. So we have a defined algorithm, but we do not buzz, we do not act, we just allow them to get burned. They need to reduce progression and complications. We all know that we have very good evidence in the literature with the life expectancy as far as the experience of 23 million person years has clearly proven that with diabetes somebody dies 6 to 7 years earlier. The DCCT and ADIC has already proven that lower the HbA1c by 1 point, you have 56%, 42% reduction in morbidity and mortality. We have clear proof and evidence that a chances of dying of a diabetic if he is diagnosed in age group 30 to 39 is 2.7 times higher compared to normal person. If diagnosed in the 4th decade of life, again 2 times higher. Further, in age group 50, 1.84 times higher. So what are we doing? We are going very slow. I think stricter is better. So there's a clear-cut alerts issued warnings. A decade of type 2 diabetes threshold shortens life by 3.5 years. And please, we need to understand that the relationship between HbA1c and prevalent retinopathy or microvascular or macrovascular complications, if are plotted in deciles, that means in parts of 10, vigintiles, that means in parts of 20, it's a continuous variable. As the sugar levels increases, the complexities increase. And pre-diabetes has everything which happens in diabetes. So why are we differentiating the two? It's a continuum of dysglycemia. Let's act fast, let's act together that age group 50, 60, 70, somebody is enjoying his life rather than becoming a burden on his family when his productive years of life are just around in the 5th or 6th decade. So dear friends, there is call for action. The action is, let's define our algorithms better. 3 decades have passed since DCCT and EDIC. There have been a lot of advancements, but our guidelines remain similar. We have CGMS coming our way, we have glycated albumin, we have glycated serum protein testing, we have metabolimics available with us. We have 1 hour OGTT, and we can define our diagnostic algorithm. So my dear friends, there is a call to reevaluate the current diabetes diagnostic thresholds. If we use the US data, somebody diagnosed at age 30 would lose 14 years of his life, somebody diagnosed at age 40 would lose 10 years of life, somebody diagnosed at age 50 would lose 6 years of life. So that much is the morbidity and mortality of diabetes. So let's gift our people with diabetes a longer life. We can increase their life expectancy by 3 to 10 years. So I believe the diagnosis of type 2 diabetes should be broadened to match the glycemic threshold currently used for pre-diabetes. Let's merge the boundaries. This would eliminate the need for a separate category, would allow an earlier therapeutic intervention, reflect the latest advancement in technology and management, and we would have interventions offered earlier to prevent the cell and tissue damage which is occurring very faster. With that, it's time for action, taking timely measures to ensure a steady life, whether it is pre-diabetes, diabetes, it is the same continuum, it is same dysglycemia. नाम कोई भी दे दो, लेकिन काम टाइम पे करना जरूरी है. Let's get into action. Thank you.
So thank you, Dr. Paras. I think he's kept the ball rolling, and I think definitely we'll have the opinion from the house as well, whether this diabetes threshold is lowered. अगर lower करते हैं तो what economic burden that you're talking about, वो मेरे ख्याल से और बढ़ भी सकता है, because मेरे ख्याल से 20-30% और जनता हो जाएगी diabetes, and then we'll have problem again, and I think
half of the world will become diabetic.
That's what I'm saying, that all the person will become diabetic. So yeah, right. So this is an interesting debate. It is, I think, the first time that debate is happening, right? Okay, because we know that the complications of pre-diabetes are much. और हम बोलते हैं कि भाई जब diabetes diagnose हुई है तो 10 साल पहले आपके endothelial dysfunction शुरू हो चुका है, और हम बोलते हैं कि diabetes is CAD equivalent, कि भाई diabetic हो गए तो आपको 2 to 3 times you are prone to die for cardiovascular disease. So why not to treat early, right? So this is an issue of contention, and definitely we'll discuss. And without wasting time, I invite my dear colleague, Dr. S. Gupta sir, to speak against the motion, right? So Dr. Gupta sir. And
Thank
after
you very
that, we'll
much.
have the opinion of the house.
The organizers and the audience. First, I'm very happy to announce that I have been nominated for the WHO Side Event Award, likely to happen in Geneva on 28th of this month. Thank you very much. And my topic would basically revolve around the global perspective of diabetes. What my friend has talked is the local perspective of diabetes. Diabetes is a continuum. Rain is a continuum, but how many of you would open an umbrella before it starts raining? No one. Same is about diabetes. Can I have my slides, please?
The slides are showing up, I think.
Pre-diabetes, should the diabetes diagnostic threshold be lowered? The answer is big no. Why is it so? Why do I say so? We should all learn from the past. Has it been done in the past? Yes. In 1985, the fasting plasma glucose was decreased to more than 140 from more than 145. In 1997, the American Diabetic Association decreased the plasma glucose values to 126 from 140. And those who have been practicing since then, they can recall those days that we were called names. We are branded as thieves. We were branded greedy. We were blamed to have an excess with the pharma companies. And why was it done? It was done on the basis of a trial. Was it not moving? It was done on the basis of a trial called as the Diabetes Complication and Control Trial 1993. It was basically a retinopathy trial and mainly done in the patients with diabetes, type 1 diabetes. And on the basis of the trial, it was found that there are two inflection points. One is at 125 and another 199. But later on, when the criteria has been changed, we came to know that there was a methodological error in the trial itself. So we are all believing in a diabetes threshold which was based on a wrong trial. Done in a haste probably, but since because it has been done, pharma companies had their gain, the continuum goes on. What is pre-diabetes? Current definition of pre-diabetes is still controversial. Not all the agencies, they agree to one definition of diabetes. In 2001, the ADA started to call slightly elevated sugar levels as pre-diabetes. In 2007, ADA began to recommend metformin for the pre-diabetes patients. But in 2009, internal experts rejected pre-diabetes label, calling it as scientifically unsound. See how the pharmaceutical industry is manipulating things. In 2013, ADA began to suggest other diabetic drugs for the management of pre-diabetes. In 2019, ADA said that weight loss drugs can be considered for the pre-diabetes. Not all the organizations, not all the associations agree to one definition of diabetes. ADA says fasting plasma glucose 100 to 125 is pre-diabetes. WHO says 110 to 125 is pre-diabetes. American Association of Clinical Endocrinologists says even the metabolic syndrome is regarded as pre-diabetes equivalent. Let's see what is metabolic syndrome. Abdominal obesity, high blood pressure, high blood sugar, high triglycerides, low HDL. And even if any of these three are present, we can label it as metabolic syndrome. So you plan to label a patient as pre-diabetic even if his blood sugars are not raised. It is going to be a catastrophe. The question to lower the diagnostic threshold of diabetes is a very complex question. Lowering the threshold might identify certain individuals at an earlier stage of disease, potentially allowing slightly earlier intervention to prevent the complications. But nevertheless, more and more people will be classified as diabetic. And it may have implications for the healthcare systems, insurance, also individual concerns like overtreatment, psychological impact of having a chronic disease for all the life, which requires strong and a rigid dietary control and ensuing insulin injections every day. It is going to be a catastrophe. We as doctors are first asked to take Hippocratic oath, and the first component of the oath is do no harm. Do good comes late, but do no harm comes first. By decreasing the threshold, are we following that Hippocratic oath? It is a time to understand. My friend said that diabetic complications, they start early. Let us analyze how much complications are there in pre-diabetes and how much are there in diabetes. About 5 to 10% patients of pre-diabetes, they slip into diabetes every year. Not all patients slip into diabetes. As far as I remember since last 10 years, 12 years, that 1/3 of the patients of pre-diabetes will slip into the diabetes every 3 years. 1/3 will slip to the normal euglycemia, and 1/3 will remain into the pre-diabetic status. So not all patients. So lowering down the threshold to a pre-diabetic level is going to be a disastrous effect. Regarding the cardiovascular disease, there's a slight increase in the cardiovascular complications. about 1.5 times in general population, while in diabetes, the risk is much higher. So calling a low risk to a high risk would be again unethical. Nephropathy and neuropathy, pre-diabetics do not have much risk of neuropathy and nephropathy, while diabetics, high risk of neuropathy, about nearly 50% patients. High risk of nephropathy, nearly 20 to 40% patients. High risk of retinopathy in diabetics, nearly 1/3 patients. Nearly 15% patients would have high risk of skin complications. But these risks are slightly low or nearly negligible in patients with pre-diabetes. There are lots of prevention programs for the diabetes prevention. Nobody prevents you to treat pre-diabetes, calling it as pre-diabetes. Why are you hell-bent to call it as diabetes? You can continue to manage these complications. You can ask the government to run a program for the pre-diabetics. You can make the people aware by education. By making diabetics, you are basically going to help the pharma companies. My dear friends, diabetes is a global public health crisis. And it is likely to threaten the economies of nations, particularly the developing countries. To make the diabetes treatment nearly equivalent, global health program or the Global Diabetes Compact. WHO has standardized by giving some targets, and these targets are 80, 80, 80, and 60. And they are to be achieved by 2025. 80% of the people in any country should be knowing that they have diabetes. 80% of those who are diagnosed should be on treatment. And 80% of those on treatment should be having their HbA1c level less than 7%. And 60% of the people more than 40 years of age should be on statins. This target is to be achieved by 2030. But initial 80-80 targets are to be achieved by 2025. Are we anywhere near these targets? Has India or any other nation, even the developed nations, achieved these targets? The answer is big no. We already have nearly 540 million people with diabetes all across the world, and nearly 740 million people with pre-diabetes. If we club them together, it is going to have a disastrous effect on the economies of many developed nations, and we are going to lag far behind in achieving these targets. What is India's status as far as these targets are concerned? Nearly 27% of Indian population, diabetic population, is aware that they have diabetes. Nearly 20% patients are taking treatment, and only 7% had their diabetes in control. You might be feeling that we are slightly slow in doing things, but things are not far better in the most developed nation, that is the USA. Only 33% patients in USA have their diabetes status controlled to nearly 7% of HbA1c. It is same about China. It is same about many other developed countries in Europe. My dear friends, if you decrease the diabetic threshold, you are going to increase the sensitivity, but at the same time, you are going to compromise the specificity. You are going to include large number of patients who are falsely positive into diabetic classification. So need to be careful. The war on pre-diabetes could be a boon for the pharma companies. There would be widespread conflicts of interest in the panel members. And see, so many pharma companies are sponsoring these panels. Basically, the interest of pharma companies. I do not deny managing the pre-diabetes complication, but they can be managed separately. Why to club them as diabetic? If you do so, the clinicians will be pushed towards overdiagnosis out of fear for litigation or the patient dissatisfaction.
I think so time is running, so just concluding remarks so that we can have the verdict also.
Long-term benefits of the pharma intervention with pre-diabetes are questionable, and quantification of the harm is scant. There is no diabetic drug which has been approved by the FDA for the treatment of prediabetes. It is only the associations and the pharma companies which have been pushing the drugs. The various drugs, which are the pioglitazone, the exenatide, liraglutide, which have been advocated to be used in prediabetes, they all have a black box warning. The insurer is going to get affected. Suffering from diabetes, hypertension, inform the insurer. Otherwise, the insurer might take away our claim, saying that it was a pre-existing disease. Labels do matter, my dear friends. Patients with diabetes are likely to have stigma. And stigma is no small thing. And finally, the take-home message is, do not bite more than you can chew. Thank you very much.
So thank you, Dr. S. Gupta and Dr. Paras, for lovely debate. I think before giving our verdict, I have some few comments from the chairpersons, and then we'll take the verdict from the audience, then my verdict in the last.
Thank you, both the speakers. Very good information given for pro and against. But I would like to give one comment. It is approach should not be like that lowering the threshold. It should be how to identify the pre-diabetes, especially the high-risk patients like the obesity, metabolic syndrome, family history, gestational diabetes, so that we can reverse the pre-diabetes into the normal. Nature has given some normal blood sugar, like we have all the normal cells, for the decades we are basically teaching our students 70 to 110. It should be there, and we should identify the 110 to 126 so that the long-term complication of the diabetes can be reversed at this level, and we should focus on these individuals. My approach is this, not lowering the threshold, but identifying these individuals and reversing the pre-diabetes into the normal.
Very important comment, Dr. Sunita. Dr. Rajgupta, your comment, please.
Very well discussed by both the speakers. The aim probably is that we should prevent complications and not just the diabetic part. And diabetic stigma is definitely a very big stigma. You see, it happens every day in your day-to-day life also. You go to a party, you don't eat anything because you're a diabetic. And you go to a restaurant, you can't eat any food because you're a diabetic. So it's more important that we control the calories, we control the physical exercise, and of course the weight and other factors, which probably we are not, instilling enough amongst our patients.
Especially the elderly populations.
So actually we are considering numbers like, suppose a patient comes to you, right, fasting blood sugars of 118 and post-pregnant blood sugars of, say, 156 and A1C of 6.1. So how you will treat? So definitely you have to look for the risk issues. Whether there is past history of family history of diabetes, having severe risk factors, definitely we are going to treat the patient. If the patient who are not symptomatic, there is no family history, no risk factors, patient is not obese, definitely we should do the lifestyle interventions before adding some medication. Regarding this pharma companies, definitely the lowering the issues, that definitely the boon for pharma, as Dr. S. Gupta has rightly pointed out. So one statement for rebuttal, then we'll take the opinion from the audience. Dr. Paras, your comment on rebuttal?
So the first conflict of interest, there is no pharma sponsorship for this session, right? And we are not guided by the pharma, we are guided by the core academics, and we are purist people. We are for no harm to the mankind. We are here to define things in a larger perspective. Hindustan mein har jagah kooda hai. Do we accept that? That it's a norm. We have to change our mindset someday कि गंदगी को गंदगी बोलें और जैसे कूड़े का hygiene है, that has to be translated similarly to the health. Whatsoever is not normal is abnormal. We need to recognize that. We need to define the guidelines better. और बारिश शुरू होने पे छाता कौन देर से खोलता है और कौन जल्दी खोलता है, वो सब डिपेंड करेगा आप वो कौन इंसान है और आपने कितना मेकअप किया हुआ है. पता लगा 2 बूंदों में सब धुल गया और छाता खुलते खुलते रह गया. So I think it is time to open the things fast. And we are not saying that you just straight away jump to the drugs. We are just saying, please define things properly, right? Use better diagnostic tools. We are saying that let's try to give them more number of years. How would you like to lose 14 years of somebody's life because you could not delay it by a decade? You need to do that. We know that we are losing life by a delay in our action. And we are not saying that the actions are going to be drugs always, they are very well
Right,
defined
sir. I think your
actions.
point second.
Right?
Point second. Not as
But
your point.
no, wait a while. There's something more coming, which is,
Maharaj, I never meant to bitter you so bad.
listen my confession.
Oh yeah. Right.
Audio. चाहत एक ही है, patient benefit.
Dr. Gupta, your comment
Right?
and we'll conclude.
Wait a while.
Sir,
It's still
time
there.
is up. Time is up.
Leadcon 24, thank you for making me believe. Audio, please.
इस हमारी फिल्मों की तरह हमारी जिंदगी में भी, हमारी फिल्मों की तरह हमारी जिंदगी में भी सब ठीक हो जाए। हैप्पी एंडिंग। और अगर ठीक ना तो वो दी एंड नहीं है दोस्तों। पिक्चर अभी बाकी है।
Picture बाकी है। So picture अभी बाकी है, sir. I think Dr. Gupta, sir.
Picture abhi baki hai. The honorable lady over here said that we need to identify people. If we go to the ADA standard of care to 2023, my colleague should have pointed out, there are cohorts in the pre-diabetes which we can identify that these people are likely to develop complications faster, earlier, and they're going to slip into diabetes. So it can be done, and it should be done even without labeling them as diabetes. And the care can be concentrated upon them. Secondly, regarding the good or bad, every bad may not be equally bad. So the treatment cannot be equally good or bad. It has to be defined. Anyway, thank you very much. I think we should now...
Sir, one comment from Dr. Meena Chawla, then we'll conclude.
I think you cannot stigmatize the whole population. My feeling is my young girls get stigmatized, they don't get married, jobs, everything. I will strongly disagree that every obese who has mild dysfunction, they should be encouraged to lose weight. And I think we should conclude that stigmatizing and calling a pre-diabetic and lowering the range and calling them diabetic is not the answer. School health programs, focusing on good food.
Pre-model. This is pre-model.
I asked the same question to Paras whether he's going to find a girl who is a diabetic for his son's marriage.
It's about naam kuch bhi do, lekin kaam to karo. That's the whole idea. Whether you call it pre-diabetes, whether you call it half diabetes, whether you call it dysglycemia, let's start acting when it is not normal. Whenever it is above normal, we need to act. It is 40% of 40% of world population is affected by it.
Yeah.
We are just being too glucose-centric. The whole issue in pre-diabetes, macrovascular complications, the one thing that we are worried about actually is inflammation. Now, we are not talking about inflammation in all this discourse. So that is the true thing, and Dr. S. Gupta has pointed about the metabolic syndrome. We should be considering the abdominal, the waist, any level of dysglycemia, be it pre-diabetes, be it diabetes, and any level of dyslipidemia, HDL, LDL, triglyceride. So I think it should be a more complex approach rather than just one glucose number or a fasting.
Right.
I also agree because previously there were no diagnostic criteria for the cardiovascular disease, and now we do not have any diagnostic criteria for the vessel level diagnosis of the microvascular complication. We are basically concentrating upon the cardiovascular morbidity and the mortality because we can diagnose that this patient is having CAD by doing a coronary angiography. If we can do a similar angiography for the microvascular complications, we might be able to diagnose them better.
So there's not debate of pre-diabetes, diabetes. I think this should be the patient-centric actually, right? If the patient has complications, you start early. The patient doesn't have complications, not Meena said, definitely the lifestyle would do, right? I think, so we have the verdict of the horse. So who is in favor of, for the motion? Just raise the hands. The diabetes diagnosis, the threshold should be lowered for the motion. And for the against the motion? Right.
Thank you very much.
So verdict is out. I think the winner should be the mankind actually, not pre-diabetes and diabetes. We should actually work on the mankind. Yeah. Mankind. Amitabh Bachchan आ गया. Amitabh Bachchan आ गया. So winner should be humanity, right? This should be two. Right. Right. So we have to, we have to individualize, should be patient-centric, and I think verdict is already out by the audience. And both are dear friends. I cannot announce who is the winner, right? So I cannot take. I cannot take. So I think it's a very good debate. It's a So it's a very good debate, and I think a good round of applause to both the speakers. I think so for a wonderful debate. Thank you very much.
Thank you all the chairpersons. I extend my gratitude to both the speakers for their insightful comments and to Dr. Pankaj sir for his expertise and thoughtful contribution. I request all the dignitaries on the stage to please proceed to the presentation desk. For the next session, I'd like to invite the following dignitaries on the stage for chairing the session. Dr. Aman Rohtgi, sir. He's a senior consultant of internal medicine at Shanti Mukund. Dr. Amit Gupta, sir. He's a senior consultant at Diabetes Care Center at Greater Noida. Dr. Meena Chhabra, ma'am. She's senior consultant at Gangaram. Dr. Monica Yadav, ma'am. She's assistant professor and nephrologist at LHMC. Dr. Prahlad Chawla, sir. He's director and head of Nishkam Diabetes Care and Research Center at Ghaziabad. And Dr. L.H. Ghotekar, sir. He's director, professor, and head, Department of Medicine at LHMC. I also invite Dr. Rajesh Kesri, sir, to chair the session. He's director and consultant diabetologist at Total Care Control Diabetes Center at Delhi. So, diabetic nephropathy, we all know, is a leading cause of CKD as well as CKD requiring renal replacement therapy. So to discuss the current landscape of diabetic kidney disease treatment, I call upon the dais Dr. Manoj Singhal, sir. He is the Principal Director in Nephrology and Kidney Transplant Medicine at Max Vaishali. He's done his DN and DNB in nephrology from SGPGIMS Lucknow, and he has fellowship in clinical nephrology. He's also a fellow of Indian Society of Nephrology since 2009. He's a program director for DNB nephrology since 2011, and he has published more than 60 papers in international and national journals and authored 10 chapters in various textbooks. Sir, please.
Thank you. Thank you to organizers for inviting me for this talk and this. What I'm going to talk today is about changing landscape in the treatment of diabetic kidney disease. In my talk today, I will recall the evidence which is now available about the new therapies which can reduce the cardiovascular risk in these patients. I will complicate the management of these patients. And we all know that the declining kidney function or declining GFR and albuminuria independently and additively increase the risk of cardiovascular disease in these patients. Not moving. Slides are not moving. Yeah, that's all right. So, okay. So I think I'll skip. We all know that the same is the state in India. As far as the risk factor for diabetic kidney disease is concerned, there is a strong genetic predisposition for development of diabetic kidney disease. But at the same time, there are certain modifiable and non-modifiable risk factors, which include age, gender, obesity, smoking, and recurrent acute kidney injury. Obesity and smoking, they require special mention because many of these patients have histopathological changes which are similar to diabetic kidney disease without having diabetes in these patients. So these are patients who have nephropathy sans diabetes. So changes are almost similar. Recurrent AKI, again, we now consider AKI and CKD as a continuum. A lot of patients who develop acute kidney injury, they, with follow-up, develop chronic kidney disease. So in patients who have diabetes, if there are frequent episodes of acute kidney injury, that also increases the risk of chronic kidney disease. The prognosis of chronic kidney disease is now can be seen in three things, like cause of kidney disease, GFR level, and albuminuria. As cause, we all know the diabetes is there, but GFR, as there is a progression of GFR or lowering of GFR, there is more and more risk of progressing to end-stage kidney disease. And same thing happens with albuminuria. From normal albuminuria, which is A1 category, to A2, which we used to call microalbuminuria, to A3, which we call macroalbuminuria or severely increased proteinuria. As the albuminuria increases, there is increasing risk of chronic kidney disease. I would like to remember this heat map. This we call heat map. And from green to red, there is progressively increasing risk of chronic kidney disease in these patients. Based on this risk of progression to chronic kidney disease, the strategies which we have been using so far is lifestyle management, which is the cornerstone on treatment of diabetes as well as complications of diabetes, tight glycemic control to retard the progression, and strict lowering of blood pressure. What do we expect from that treatment? I often hear this, that there is no treatment for chronic kidney disease. I agree, it used to be the case earlier, but let me just ask you once again, what is the treatment of diabetes? So whenever there is absolute or relative deficiency of insulin, there is high blood sugar level, we give them medicines to bring their blood sugar level to the normal range. And that's what we call that we are treating diabetes, okay? Let's consider this scenario. This is just showing the slope of GFR. With time, as the GFR decline, more and more patients will slip into end-stage kidney disease. So if the GFR will decline at the rate of 5 ml per minute per year, which is the lowermost line, within, say, 20 years, patient will reach the stage where they will require dialysis. If this deterioration is at the rate of 3 ml per minute, we can have 10 more years of dialysis. So the progression will be slower and 10 more years of dialysis. Same way, if there is a progressive decline in the rate of deterioration, patient can have a normal lifestyle till 75 years without requiring dialysis. The topmost curve shows the normal decay of GFR. So after the age of 45, there is a progressive decline in GFR at the rate of 1 ml per minute per year. And most of these people will not require dialysis in their lifetime. So if we can decrease the rate of decline in GFR to this normal decay in GFR, which occurs in normal population, we can say that we are treating chronic kidney disease, isn't it? Let me take this step back. If we look at the progress in the treatment of diabetes in kidney disease, earlier the rate of decline was somewhere around 10 ml per year. Before, no specific treatment was used for diabetic kidney disease. With the awareness of strict glycemic control and strict blood pressure control, this rate of decline came down to somewhere around 5 to 6 ml per minute. With the use of ACE inhibitors and ARBs, it further declined to 4 ml per minute per year. And now with availability of SGLT2 inhibitor, it has come down to almost less than 2 ml per minute per year. With a newer molecule, we hope that we will come down to somewhere around 1 ml per year per minute, and that's what is the normal decline in GFR with age. So now in 2024, at least we can claim that we can retard the progression of chronic kidney disease to normal aging process, and that's what is the treatment for diabetic kidney disease. Although the pathogenesis of diabetic kidney disease is complex, but these are the important factors which drives the progression of chronic kidney disease. And obviously, hyperglycemia is one. Then there is hemodynamic dysregulation, and then inflammation, and all three of them together will lead to progressive decline in chronic kidney disease. And now we have agents to control all these three factors. Let me bring analogy to heart failure management here. As we know that there are 4 pillars in the management of heart failure, similarly, there are 4 pillars in the management of diabetic kidney disease. Okay? RAS blockade, SGLT2 inhibitors, non-steroidal mineralocorticoid receptor antagonists, and GLP-1 receptor analogs. first of these pillars is RAS blockade. There are studies for more than 30 years, initially done by ACE inhibitors in type 1 diabetes and subsequently done by ARBs in type 2 diabetes. And all of them would show that the retardation is decreased by almost 20% if we use these agents to control blood pressure in patients who have diabetes and chronic kidney disease. The second pillar of therapy is SGLT2 inhibitors. SGLT2 is responsible for reabsorption of glucose in proximal tubule. And if we block this reabsorption in the proximal tubule, it will lead to increased delivery of chloride to the distal tubule, which will reset the tubuloglomerular feedback mechanism and will lead to constriction of afferent arteriole and dilatation of efferent arteriole, and thereby decrease the glomerular capillary pressure and will control hemodynamic dysregulation, which is a hallmark of diabetic kidney disease. In addition, there are other pleiotropic mechanisms. It increases the oxygen utilization and oxygen delivery and will also have a beneficial effect on heart as well as kidney outcome. Important thing is to note that these beneficial effects are seen in patients who are already on RAS blockade. So there is an additive effect of SGLT2 inhibitors when we use them in addition to RAS blockade. The initial cardiovascular trials have shown this effect, but most of these trials were done in patients who were at a very low risk of renal disease progression. So most of these patients were in green category. Then there is Credence trial, which was done in patients in red category. So these are the patients who already have lower GFR and have significant proteinuria. And when we use SGLT2 inhibitor in this category of patients, still we see that there is a beneficial effect of RAS blockade. Then subsequently, there were DAPA-CKD trial and EMPA-CKD trial. They included patients who were not even diabetic. So non-diabetic patients were also included. They included patients with a lower GFR threshold and also included patients who did not even have proteinuria. So they widened the indications or patient population which was seen. And all these trials have shown the similar results. This is Credence trial, which has shown that there was almost 30% reduction in the risk of major adverse kidney events. And the graph started separating as early as 12 months. So if you use these agents for 1 year, you can see a significant benefit in these patients. If you look at the slope of GFR, the patients who were on placebo, the GFR declined by 4.5 ml per minute per year, whereas the patients who were given canagliflozin, the decline was 2.7 ml slower. So the decline was less than 2 ml per year. That will prolong the dialysis-free survival by almost 15 years in these patients. And mind you, these patients have 56 ml GFR when they started this treatment, right? Similar type of results were seen in DAPA-CKD trial, which included 4,000 patients, and EMPA kidney trial, which again showed the similar trial. And the graph again started separating at 1 year. So all these 3 trials using 3 different agents have shown the similar results of protection somewhere around 30 to 40%. This was seen across GFR category. You look at this box, patient with GFR of more than 45, 30 to 45, less than 30 ml. When you start these medicines, they have a similar type of benefit seen in major kidney events. Even in patients with no diabetes, they had a similar effect. So the beneficial effect is not limited to glycosuria or effect on diabetes, but is independent of effect on diabetes level. So these agents are also useful in non-diabetic, irrespective of the etiology, whether it is IgA nephropathy, focal segmental glomerulosclerosis, other glomerulonephritis. In all these category of patients, if you use these agents, there was a beneficial effect and slow in the progression of renal disease. This is a very important slide. So many times when we use RAS blockade, we have to withdraw the medicine if the patient develops hyperkalemia. But when these 2 agents were used together, SGLT2 inhibitor and RAS blockade, when they were used together, the chances of withdrawal of RAS blockade was less. So the odds was 4 versus 4.7. 15% less chances of stopping RAS blockade if you use SGLT2 inhibitor and RAS blockade. And this was seen across the GFR category. RAS blockade dose or serum potassium. And in fact, it was more pronounced when the patient have proteinuria. So both these agents, when they used together, they have a synergistic effect in preventing complications of each other. The third pillar in the therapy is mineralocorticoid receptor antagonist. We all know that it's a protective mechanism. Whenever the blood pressure is low or plasma volume is low, there is increased secretion of aldosterone, which will bring the blood pressure towards normal mechanism. So this is a normal protective mechanism for the body. But it also have a pathological implication, and it independently and because of systemic effect, it leads to increased incidence of chronic kidney disease. There are a number of trials which have shown that blockade of mineraloreceptors will have a beneficial effect on cardiovascular outcomes. But most of these trials were limited because of renal side effects. Many patients will have decline in renal function, increased creatinine, or increase in potassium level. Now we have non-steroidal MRAs, which have been studied in patients who are at a risk of kidney disease. So this Fidelio DKD trial, they have looked at renal outcomes in these patients who had a low GFR and who had diabetes. And what they have shown is 18% reduction in major kidney outcomes. As a secondary outcome, there was also 14% reduction in major cardiovascular outcomes. Another parallel trial, which was primarily looking at cardiovascular outcome, they have shown 13% reduction in cardiovascular outcomes. And in fact, the hospitalization for heart failure was decreased by 30%. Okay? Hyperkalemia occurred in some patients, but leading to withdrawal of therapy was very low, 0.4%. Right? This is a combined pooled data from both these trials, which include a large number of population at the different risk category. And even in this combined, they have shown that there is 23% reduction in major kidney event if you use Finrenon in these patients, and 14% reduction in major cardiovascular events. 15% of these patients were already on SGLT2 inhibitors. And when they analyzed patients who were on SGLT2 or who were not on SGLT2, the effect was similar. In fact, the effect was better in patients who were on SGLT2 inhibitors. And in fact, the incidence of hyperkalemia is lesser if SGLT2 inhibitor was used. Okay? So significantly lesser when SGLT2 was used with Finrenon. When they looked at other trial in Credence, again, there was 23% less chance of severe hyperkalemia if SGLT2 inhibitors was used in this trial, right? In other trials as well, the chances of hyperkalemia was less if we use SGLT2 inhibitors along with MRAs. This is a synergistic effect. So these 20 patients they studied, they started these patients on one drug alone, whether on Finrenon or dapagliflozin, and after 4 weeks, they switched these patients on a combination. So when the combination was used, there was an additive effect on proteinuria reduction when both of these medicines were used. So these medicines are not only effective when they're used alone, but they're also effective or also increase the efficacy and decrease the side effect of other molecules. The fourth pillar now in 2024 is GLP-1 receptor agonist or DPP-4 inhibitors. It is widely distributed in the kidney and it may have a pathogenic role. The early cardiovascular outcome trial have shown the beneficial effect of these agents in all the major renal events, even in patients who had low GFR. So if you look at the middle, the patients who had GFR less than 60 ml, in fact, there was more pronounced effect when these agents were used. And that was the basis for this FLOAT trial, which was started. They wanted to look at the effect of semaglutide in patients with type 2 diabetes and CKD. Patients had high risk. A lot of these patients, the mean age was 66, long-standing diabetes, already have low GFR and proteinuria. 15% already on SGLT2 inhibitor, 95% already on RAS blockade. And it was an event-driven trial planned for 5 years, but it was stopped last year because of efficacy. So even after 1 year, they found that there was a significant benefit of using semaglutide in this patient population, and it is futile to continue this trial for long. We still wait the long-term results, which will be published very shortly, probably in May this year. So now the evolving standard of treatment is combination therapy. The first pillar, as I said, is RAS blockade. The second pillar in the treatment is SGLT2 inhibitor. Both these agents will target the hemodynamic perturbation in diabetic kidney disease. Finerenone will target the inflammation part, which is there in patient with CKD, and potential GLP-1 receptor agonist will control metabolic as well as inflammation part. And these therapies will increase the years without dialysis. Just consider the red line. If you just control blood pressure and blood sugar, patient will reach end-stage kidney disease. If you add RAS blockade, you can decrease by 20%. Patient will take longer to reach end-stage kidney disease. If you add SGLT2 inhibitor, it will take further long. And if you use MRA, there will be almost flattening of the curve, which is similar to normal aging process. But the crux here is to diagnose these patients early. So if you start at a higher level of GFR, you may have at least 20 to 30 years not requiring dialysis. So you can prolong dialysis-free survival by at least 20 to 30 years. But if you start these treatments when the GFR is already 20 or 30, you do not have much leverage at that point of time. There is a data to show that these combination therapy works. So if the individual therapy is used and when the combination therapy is used, there was an additive effect on the combination therapy. Again, the similar data using one agent or two agents or all three agents together, there is a progressive beneficial effect of using all these three agents together in major cardiovascular as well as in renal outcomes. So if we have this type of data available, now what is the barrier to build the house? We have 4 pillars, but we can't build the house. And to have an effective therapy, there are 3 hindrances: education, access, and adherence to treatment. Education is a big problem. We have guidelines for last 30 years, but we still see patients who come to us with advanced renal failure requiring immediate dialysis. There is no screening for kidney disease. We should understand that screening for albuminuria and GFR is like measuring blood pressure and cholesterol in these patients. If you diagnose these patients early, that will lead to initiation of these effective treatment and will prevent complication. Access is not a problem with the availability of a lot of generics and Jan Ausstahle. Most of the patients now have access to treatment. Adherence is a problem, but again, patient education has to be emphasized in these group of patients. So to conclude, ladies and gentlemen, the recent trials have established these 4 pillars of therapy in patients with diabetic kidney disease. Lifestyle modification is the foundation. It's very important, and over this foundation, these pillars will stand. The evolving standard of care is combination therapy, which include RAS blockade, SGLT2 inhibitors, non-steroidal MRAs, and GLP-1 receptor agonists. Screening and early institution of therapy is the key to prevent kidney failure. That's the only way we can prevent these patients from requiring dialysis or transplantation. Match the intensity of treatment to cardiovascular risk. If the patient have a higher risk of cardiovascular events, start these treatments early in their course. Be aggressive in starting these treatments. Be aggressive in their management. And that's the only way to prevent complication in these patients. So I'll stop here and I'll thank you for your patient listening.
Thank you, Dr. Manoj. Very excellent talk, and many of the things have been cleared. But I would like to ask one question before I ask the audience. Because Finerenone is very costly drugs, and every patient of us cannot afford. Can we add on as in spironolactone or eplerenone?
Yes, sir. We can always add spironolactone, eplerenone, but the problem again was hyperkalemia in these patients. So Finerenone being non-steroidal, the risk of hyperkalemia is very less with Finerenone. And now we have other, say, they have a marketing right with Sun Pharma. So the same medicine is now available on slightly lesser cost, and it is widely available. So earlier the problem was also availability. The market penetration was not very common. So now this Sun Pharma, it is available everywhere. So I think with more and more companies available, it will, the cost
definitely,
will
but still it's very costly.
Yeah, it
but
is.
Definitely, if it is nothing is available, we can think of adding at least and monitoring the potassium
Yes,
part.
I completely agree with you. But I think most of the time it's important to start RAS blockade and SGLT2 inhibitors. And then, if required, one can add Finerenone or spironolactone or eplerenone to these patients.
Sir, why do we see so many prescriptions with keto analogs by the nephrologists and you've not even mentioned them? So day in and day out, we'll see, is there any role of keto analogs in kidney disease?
Yeah. Say, there is a theoretical role people have seen in animal. Whenever we have high protein diet, there is rise in GFR, right? This was seen in animal experiments. But whenever this concept was tested in human being, the same results were not seen. None of the study have shown the beneficial effect of restricting protein or giving keto analogs. Where this medicine is used, I agree with you. In my opinion, although I do
Anemia. So two things.
yeah, so whenever the GFR is less than 60, that's when we should increase the dose to double. But if the patient have GFR more than 60 ml, one can give the usual dose which we use in general population for that. Anemia as such, again, as the severity of renal failure increases, more and more patients will develop anemia. The treatment or prevention remains the same. One should look at hemoglobin level, give them supplements like iron. If they are iron deficient, give them iron, give them folic acid and B12. But still, if they are, there is say element of CKD or chronic inflammation, one can add ESAs, erythropoietin stimulating agent. We now have oral agent which is available, desidostat, but that can be used in patients who are not on dialysis or who take treatment at home. So it's a domiciliary treatment which can be used in these patients and quite effective in these patients.
Thank you, sir. Thank you so much for the wonderful talk. I have two questions which I would request you to comment on. One is GLP-1 receptor agonists. So do the GLP-1 receptor agonists have any role in DKD other than their glucose lowering, weight lowering, anti-inflammatory effects? Is there any direct effect on that? The other question which I would request you to address is the role of probiotics in chronic kidney disease, because they're also being promoted, just as Madam was talking about keto analogs.
So GLP-1 receptor, as I said, in the recent trial, FLOW trial, that's what they wanted to see, whether using these GLP-1 receptor agonists will have a specific role in kidney disease. At least in this trial, these patients all were diabetic. But I'm hoping probably just like SGLT2 inhibitor, there will be more trial which will also include non-diabetic patients and see whether it has effect independent of diabetes control or weight loss. So it's quite possible that this molecule may have an effect which is independent of diabetes, but as such, now I don't think there is the data. At least I'm not aware of that data at the moment. Probiotic, again, it's just like a ketosterol type of a thing. People believe that if you use probiotic, you change the gut flora. That will decrease some toxins, which we call uremic toxins. Whether it will retard the progression, nobody knows. There is no data.
But do you use?
No, I don't use.
Thank you.
Thank you, sir, for that comprehensive presentation. One question from my side, sir, is looking at the profound success of SGLT2 inhibitors, but still there is no scientific data to use them in EGFR less than 20. So in your clinical practice, when the patient comes in advanced CKD, do you use them still when the GFR drops down less than 20?
Actually, in all these trials, this was the inclusion criteria, to include patients who had GFR more than 30 or more than 25 or more than 20. But in most of these trials, even when the GFR goes down below 20, these patients will continue to using these medicines. So one can continue to use these medicines. Right now, the guidelines is till they start dialysis. But if we believe in cardiovascular protection, even in the patients who are on diabetes, we can continue to use it.
But do we initiate them when they...
Generally, people don't initiate because whenever we use these agents, there is around 15 to 20% fall in GFR. So if the GFR is already, say, 20, the GFR will go down by 20%, say it will come to 15 or 16, and that creates a little bit of panic in patients as well as in the doctors. So I usually don't start them at that point of time. But if they are continuing these medicine, I will continue it till they go on dialysis.
One more question, sir. You have...
I think there's a mic this way.
So, as you suggested that there is a role of combination therapy. So, as there is a role of combination therapy, at the first visit, do you initiate the patient on ARBs and SGLT2 inhibitors, or you go step by step?
Generally, I go step by step. Say, the first thing I add is RAS blockade if they are not already on RAS blockade. But now I see most of these patients are already taking RAS blockade. So, and call them after 2 weeks with a repeat KFT report or urea creatinine, and if they are acceptable, I add SGLT2 inhibitor. But if the patient have relatively preserved GFR, I at times start both of these agents together. So SGLT2 and RAS blockade, I generally start together if the patient GFR is good. If the GFR is very low, I mean low in the sense less than 45, then I add one by one.
Sir, when do you add the third agent? So do we need to add all the agents in all the patients?
No, not necessarily. I mean, as we have discussed, this third agent, non-steroidal MRA, is relatively expensive. But if the patient is maintained on 2 agents, have a good blood pressure control and everything, I would add third agent. Say I start with 10 milligram of fenrinone, and if the potassium is stable, and then I increase it to 20 milligram. So it's not in every patient, but if we believe these guidelines and if we believe these data, that definitely has an additional role. So patients who are already on RAS blockade, who are already on SGLT2 inhibitor, even if you add MRAs, there is 20% reduction in the risk of progression. So ideally, we should add in all the patients, but in my practice, definitely not all patients are on MRAs, but many of them are.
Thank you so much, sir, for this wonderful presentation. We had a great discussion. One last question, then we'll wind up.
So generally, it doesn't reverse. So you can reverse the changes of diabetes if you treat or say control diabetes. There are studies in animals when you do a pancreatic transplant and after 5 years or 10 years, even the histopathological changes of diabetic nephropathy go away. In humans, there is a data that the patients who have early stage of diabetic nephropathy, when these kidneys are transplanted in non-diabetic individuals, the histopathological changes go away. But in clinical practice, patients who already have, say, histopathological changes of diabetic kidney disease, fibrosis will not go away, but at least the progression of this disease will be slow to a normal aging population. So that's what is the treatment.
Sir, any comparison of data in patients of CKD, when there is fall in the EGFR, any data suggesting there is upregulation or the downregulation of the SGLT2 receptors?
I am not so aware of whether there is upregulation or not. Generally, these receptors are upregulated in all patients who have diabetes.
Sure. In
Right?
we are in patients where there is no diabetes and we are using these SGLT2 inhibitors. And what happens to these SGLT2 receptors? There is no upregulation, and how these beneficial effect of SGLT2 receptors are there on PCT?
Yeah, it's basically because of, say, resetting of juxtaglomerular apparatus. On all these patients who have chronic kidney disease without diabetes, they also have hyperfiltration and reabsorption. So I assume that probably they also have upregulation. But even if they do not have upregulation, and that will prevent the reabsorption of glucose, so patients will have increased delivery of chloride to the distal tubule, and that will reset the tubuloglomerular feedback. And also the oxygen utilization. That another effect is on the oxygen utilization, which becomes better with SGLT2 inhibitors.
The EGFR of between 20 to 30 when we are using SGLT2 inhibitors, there is no hyperfiltration at that time.
No, there is. Say, even if the GFR is 30 ml, there is single nephron hyperfiltration. Say, if there are 100 glomeruli, of these 100, 70 are knocked off, 30 are trying to do the work which 100 were doing. So maybe there is hyperfiltration in each and every nephron. So even at the level of 10 ml of total GFR, the single nephron GFR is much higher than it was at the baseline.
Thank you so much, sir. I think we had a very interesting discussion, and we can continue after the lunch or during the lunch. Thank you so much.
Thank you.
Thank you, speakers and chairpersons. Now I request all the dignitaries on the stage to please proceed to the presentation desk. Now I call upon Dr. Princy Jain, ma'am. She is Associate Professor, Department of Medicine at LHMC, to please take over for comparing.
Thank you, Dr. Prashishti, for the polite introduction. Good morning, ladies and gentlemen, and welcome to the platform of Leadcon 2024. And I shall be your presiding host for the next few sessions. As we all know, dyslipidemia is one of the most important risk factor which affects the adverse cardiovascular outcomes in diabetics. It not only accelerates atherosclerosis, but also nephropathy. So our next segment is a panel discussion on dyslipidemia in diabetes, the facts and controversies. And it's my pleasure to invite on stage our esteemed panelists for the session. Our first panelist is Dr. Ashok Kumar. He's the head of the Department of Medicine, Santosh Medical College, Ghaziabad, and he's the vice president of Delhi Diabetic Forum. Next is Dr. Gaurav Minocha. He's a well-known cardiologist and senior consultant in the Department of Cardiology at Max Vaishali. Next, I invite Dr. Puneet Gupta. He's a professor in the Department of Cardiology at Vardhaman Mahavir Medical College and Safdarjung Hospital. Next is Dr. RPS Makkar. He's a senior consultant physician at Makkar Multi-Speciality Hospital. And other than MD, he also holds a degree in MBA Hospital Management from prestigious FMS Institute. Then I invite on stage Dr. Sanjay Tyagi. He's a well-known interventional cardiologist. He's the ex-head of the Department of Cardiology, GB Pant Institute of Postgrad Medical Education and Research, Maulana Azad Medical College. He has multiple papers and publications to his kitty, and he's a fellow of various organizations such as FAMS, FICP, etc. It's my pleasure to invite on stage Dr. Saurabh Srivastava as a moderator for this session. Sir is the head of the Department of Medicine and Chief Medical Superintendent in the Government Institute of Medical Sciences, Noida. He's also a scientific chairman of Leadcon 2024. He's a recipient of multiple honors and awards like GB Jain Oration, Amar Sham Oration, etc. He's a secretary to UP Diabetes Association and is an ex-joint secretary of RSSTI UP chapter.
Thank you. I am the replacement for the moderator. So please bear with me. So Dr. Amitesh was to moderate this session, and he is busy some important engagement. That's why he is not here. So I am going to initiate the panel discussion on a very important topic, that is dyslipidemia and cardiodiabetes, facts and controversies. I think dyslipidemia is a topic which is often neglected, and all the macrovascular complications of diabetes are because of one factor responsible for the macrovascular complication is dyslipidemia. So I have eminent panelists with me. So I am beginning up with the session with Dr. Puneet. Dr. Puneet, I want your opinion on, is there any difference in approach to lipids in the patients of diabetes and the patients of coronary artery disease? Is there any difference in diabetes or in coronary artery disease, or they are the same? Mike.
So, thank you, sir. Yeah. So, as you already mentioned that diabetes is one of the premier causes of the macrovascular complications of in diabetes. So, obviously, diabetics are much more prone to have a cardiovascular event. So, the presence of coronary artery disease versus the absence of coronary artery disease definitely has a different approach to treatment of dyslipidemia in a given patient. So, the presence of documented coronary artery disease, either by imaging or by a history of clinical event, puts the patient straight away at a very high risk of having a subsequent event. So since the patient is automatically goes into a very high risk category, the indication for treatment and the targets of cholesterol lowering, they change once the patient is documented to have a imaging evidence or a clinical evidence of coronary artery disease. So as we know that with time, the targets for LDL lowering have changed. So it was initially started with 130, then less than 100, and the recent targets have come down to 70 according to ACC EHA, and the ESC recommends a target of less than 55 in very high risk category patients.
who have either a clinical or a imaging evidence of coronary artery disease. So the approach to treatment of dyslipidemia in a patient with and without coronary artery disease is definitely different when we sit in the clinical practice. A patient with diabetes without documented coronary artery disease and having levels age between 40 to 75 and levels less than 190 definitely deserves statin treatment with moderate intensity statin, and levels higher they deserve high intensity statin therapy.
So what Dr. Puneet has told, that there's a different approach if a patient is having cardiovascular disease and diabetes, and if a patient is having only diabetes. So the dyslipidemia approach is different, and we have to lower the targets of LDL and lower the targets for treatment of these patients. So my next question is to Dr. Ravindra, that is there any difference in dyslipidemia pattern of diabetic and diabetic patient and versus a cardiac patient? Patient who is a diabetic and a patient who is just a cardiac patient, not a non-diabetic patient.
Yes, and this is a very typical pattern that we see in diabetic patients who do not have cardiac disease, or cardiac patients who do not have diabetes. There's a pattern that we see in these patients when we do their lipid panels. And the essential difference in diabetics is that you see a lot of hypertriglyceridemia in these patients, and of course with a combination of low HDL levels. The LDL levels may or may not be that high. But if you go to a patient who has a atherosclerotic cardiovascular disease, or is a known case of coronary artery disease without diabetes, you may not find the triglyceride levels to be that high, but the LDL levels are usually on the higher side. Of course, with a combination of low HDL levels. So the triglyceride levels define the distinction in the pattern of these two classes of patients. Triglycerides being higher in diabetic patients, and I believe the reason is because of the insulin resistance or the insulin deficiency that leads to the higher production of triglycerides in these patients as compared to the cardiac patients who do not have diabetes. The other difference that is noted in the diabetic patients who do not have cardiac disease versus the cardiac patients who do not have diabetes is the presence of the small dense LDL particles, the Lp(a) particles, which are again increasingly being recognized as one of the key risk factors for defining the residual risk in patients who may have higher risk of coronary artery disease patients. So I think the essential difference is in the levels of the triglycerides being higher in the diabetic patients versus the cardiac patients who may have a higher LDL levels. And of course, this difference can also be seen in patients who have a familial etiology, familial hypertriglyceridemia, or familial beta lipoproteinemia patients. The approach, as the speaker said, is different in diabetic patients because the etiology is different. The underlying etiology is different in cardiac patients. It's more of a lifestyle and a genetic etiology versus somebody who's a diabetic with higher triglyceride levels. They are more so because of the genetic factors. And of course, there are dietary factors which are in play. If you're consuming a lot of saturated fats or trans-saturated fats, that also increases the triglyceride levels in these patients versus the cardiac patients where there's more of a lifestyle, metabolic syndrome, diabetes, obesity, which is at play. And that's why you see the differences in the pattern in the lipid panels.
So that means that diabetic dyslipidemia is a different type of dyslipidemia than a normal dyslipidemia, and it warrants special attention. So next question to Dr. Ashok is that, are there risk assessment tools for both the group different, or they are the same?
Hello. Whenever we see a patient of dyslipidemia, or as a case of diabetes, we have to see various risk factors. Most of the tools, risk assessment tools, are related to atherosclerotic cardiovascular risk assessment tools are there, which are based on risk enhancers, risk modifiers, and genetic and environmental factor they have taken into accounts. So widely acceptable tools are like they are mostly globals like ASCVD risk estimators and Curious used by NICE, UK NICE one. They are global one. They are just taking a history of diabetes present or absent. But there are two tools are available like advanced risk estimator and UKPDS risk score estimator, which are taken diabetes in as per duration, HbA1c, and target on damage also. They are specifically designed for diabetes. But mostly we are using as ASCVD risk calculator. Diabetes specific, I think many people are not using.
Thank you, Dr.
And the Lipid Association of India, as soon as a patient of diabetes comes, it categorized into very high risk group. So it means diabetes is an independent risk predictor of diabetes.
Thank you, Dr. Ashok. So there are different risk factors for diabetes as well as the plain cardiovascular disease, and we have to take care in account all these things. So there's a strong debate about the use of fasting triglyceride, fasting lipid profile and a postprandial lipid profile. So my question to Dr. Sanjay is that, is there advantage of assessing a non-fasting lipid profile over a traditional fasting lipid profile?
Thank you. I think the standard is the fasting lipid profile level is the standard, but we can have triglyceride level in non-fasting level also as an indicator. But what we need to understand is the difference between the type 1 diabetes and type 2 diabetes in their lipid parameters. Type 1 diabetes have low HDL cholesterol level, much higher triglyceride level, and higher LDL cholesterol level, while type 2 diabetes may even have normal LDL cholesterol level, though the HDL cholesterol level is less and triglyceride may not be elevated to same extent as in type 1 diabetes. So both these need to be differentiated and treatment has to be made accordingly in these patients.
Okay. So we can assess both the lipid profiles. We can assess fasting as well as non-fasting lipid profile also, but we have to take care of what type of dyslipidemia we are dealing with. So my question to Dr. Gaurav is that what should be your main lipoprotein target therapy? Whether it is LDL cholesterol, non-LDL cholesterol, ApoB, or any other lipoprotein fraction?
I think it's fairly well established in all the clinical trials that LDL reduction is strongly correlated with reduction in cardiovascular outcomes. So generally speaking, from a clinical standpoint, LDL is the target that we should be looking at. When we look at beyond LDL, it is only when you are looking at residual risk, in very high risk patients where you see that you achieved a LDL target, then you start looking at, other reduction of other lipoproteins. And frankly, in a clinical setting, since we don't have therapies which are still very commonly available, it is not really clinically pertinent to look at them so much. But yes, on an individual level, they would help because if you have a residual risk which is still persistent, you would probably go on to add other, drugs, newer drugs. And it has been seen that patients who are at high risk, who have recurrent ischemic events, it has been proven that getting LDL down to less than 40. And in that sense, then the newer therapies, the role of newer therapies would kick in, like the PCSK9 inhibitors and the inclisiran. That's also sort of a PCSK.
So there was a discussion in the morning also that the chylomicrons are now also being considered as risk for.
Definitely. So that the risk category of a patient, that is very, very important.
So other therapies also. So my next question to Dr. Puneet is that what are the parameters of monitoring the response to therapy? How will you check the response to the therapy? We have started off with some drugs, then what will the parameters be, and how frequently we should assess those parameters?
Once we've decided to put a patient on statin, so obviously first and foremost monitoring will be the occurrence of an event. So if the patient still has an event on high intensity statin, that itself means that we need to either add on non-statin therapies like ezetimibe or bempedoic acid, or the injectables like evolocumab or inclisiran now. Then the recommendation is that a repeat lipid profile should be done between 4 to 12 weeks to identify the effect of the statin or the lipid lowering therapy that we have used and meet the recommended targets, like the 50% reduction or 30% reduction that we want to achieve. So, especially in case of diabetic dyslipidemia, the atherogenic lipids are not just LDL, but the IDL and the VLDL fragments also. So the LDL may not be representative of the true atherogenic lipid profile. So in that case, the ApoB measurement may aid in further refining the monitoring of the lipid lowering therapy, because ApoB represents the ApoB containing lipoprotein particles, which are itself atherogenic, such as the IDL and the VLDL along with LDL. So there are certain targets for ApoB as well, such as in very high risk patients, it has to be less than 65, and in high risk patients, it has to be less than 80. Similarly, if we want to estimate the atherogenic lipid particles, another measurement is the non-HDL, the non-HDL particles. So that also gives us an idea of the atherogenic lipid component amongst the total cholesterol. So there are certain targets for that also.
Thank you, sir. So, Dr. Ravinder, we have very much debate about hypertriglyceridemia and diabetes. Triglyceride levels are elevated, as you already said, that hypertriglyceridemia is seen in diabetics also. So, are there any targets for treating severe hypertriglyceridemia, or it is just the same, or we can leave it as such, or sometimes it is said that just lower the glucose level, triglyceride will come down, or we have to manage those patients also?
Yeah, so I think the triglycerides have to be looked at as a complex issue in a diabetic patient. So if you are facing an acute crisis in a diabetic patient where the triglycerides levels are, let's say, more than 500 or 1,000, the risk of pancreatitis increases. So in that case, in an acute situation, you have to admit the patient and start treatments accordingly. At that level, the goal is to decrease the risk of pancreatitis in these patients. And therefore, the drugs that are currently available to reduce the triglycerides are usually not the first-line drugs. There you need to treat the patients with IV hydration and, of course, insulin, because insulin, of course, is going to increase the lipoprotein lipase sensitivity in these patients, and therefore the level of triglycerides will come down accordingly. But if you're facing a situation where there's a chronic hypertriglyceridemia in the levels of, let's say, less than 500, as we divide them into various categories, low risk, high risk, and very high risk, let's say between 200 to 499 or 500, at that level you have to start the therapies which are currently available, and especially the phenofibrates that have been available for a very long time. Now, the controversy, of course, as was discussed in the morning also, is that while hypertriglyceridemia is a independent risk factor for atherosclerotic cardiovascular disease or increasing the risk of coronary artery disease, the corollary that if you treat hypertriglyceridemia, does it reduce the risk of cardiac events is still not seen. So that evidence is still lacking. And of course, the discussion that we had in the morning was that we have been always looking at the fasting triglyceridemia levels, while we should also be looking at the postprandial or after meal triglyceride levels. So the clinical approach in a setting with this kind of evidence is that you treat hypertriglyceridemia, of course, and the best options available that we have today are the phenofibrates, and you start phenofibrates. Niacin, of course, has been also available for a very long time. Again, it reduces the triglyceride levels to by, let's say, 20%, 30%. but again, because of the side effects, it's not very patient-friendly. The other options that are available in such a setting are the omega-3 fatty acids, the DHA and the EPA, and these have been available for a very long time. Again, they reduce the triglycerides by about 30%, 20%, 30%. You have to take a higher dose, about 4 grams of omega fatty acids to reduce the triglyceride levels. But in a diabetic patient, I think the key factor is to control the glucose and give wherever there is an insulin resistance pattern, diabetes, metabolic syndrome, use insulin as much as possible to reduce the triglyceride levels in these patients if the indication is there. Otherwise, the phenofibrates, the niacins, and the omega-3 fatty acids are 3 options that are available. Statins, of course, are also available, but their efficacy in reducing the triglycerides is not very high. So they remain an option, but not the best option for triglycerides.
What about the saroglitazar?
Again, the saroglitazar or even the the GLP-1 analogs, now they are being looked at in terms of their efficacy in reducing the triglycerides. But again, the evidence is not very forthcoming in their potency in reducing the triglyceride levels in these patients to an effect where it starts to have an impact, the clinical impact.
Can we have a small question? We always teach our students that we calculate atherogenic index with triglyceride and HDL, but we disrespect triglyceride very much. We always try to reduce LDL.
Yes, sir. So whenever there is hypertriglyceridemia, as you know, the LDL is a
It's not
calculated level.
always, especially in India, we have mixed dyslipidemia because of our high carbohydrate diet, but we don't give any respect to triglyceride.
Yeah, and the reason for not giving too much of an importance to triglycerides is, of course, the evidence that if you reduce the triglyceride level, does it really lead to benefit in the reduction in the adverse cardiovascular events? And that evidence is still lacking. It's still a controversy. Although, as I said, the fallacy lies in looking at the fasting triglyceride levels and not the postprandial.
Then why we calculate atherogenic index by triglyceride and HDL?
That's because the LDL level becomes fallacious at that level because it's a calculated index. So if you have a higher triglyceride level, the best indicator would be to look at probably a non-HDL or directly calculate the LDL, which is not being done in our labs currently. So that's why the best indicator in a hypertriglyceridemia patients is to probably look at the non-HDL as a parameter to assess the efficacy of your treatment.
Decreasing the LDL cholesterol. That's just what I wanted.
So, coming to further on the panel discussion, Dr. Ashok, can you tell about something that what is the statin dosing? Whether we should continue with the fixed dosing, what should be the intensity, whether we should reduce the dose, whether we should titrate the dose, or we should reduce the intensity of statin, something like that, or it has to be continued like as it is?
Use of statin basically like a fixed dose intensification depends on the category in which patient is coming to us. If it is low risk category, we can simply ask them to do lifestyle modification. If it is moderate risk, we can along with lifestyle we can ask them to start with moderate intensity statins like atorvastatin in the less than 40 mg doses or rosuvastatin in the 10 mg doses. When the patient fits into the category of high risk, very high risk, and along with the presence of already occurred ASCVD and extreme risk category 1 and category A and extreme risk category B in which recurrent ASCVD about to occur. So in these categories, the targets are to achieve the target, we have to do the intensification of the therapy. as per the LI, many people may not be agreeable. Even LI has recommended in this year, 2023, even in the low risk category, they have advised a target of LDL less than 100. And in the moderate category, they have kept a target 100, but they are advised to keep at 70 milligram. And in high risk category, they have advised to keep the target 50. And in the extreme category A and B, they have advised to keep the target 50, and below 50 also that is recommended less than 30 in the extreme category B. To achieve that, we have to do the lipid intensification in the high intensity statins, and we have to evaluate the patient fourth weekly by doing the lipid profile, along with as Dr. Puneet has suggested, other markers like ApoB and LPA levels, and we have to add on therapy like bempedoic acid and ezetimibe to achieve the target. And after 8 weeks also we have to repeat, and if the targets are not met, and so definitely lipid intensification has to be done, and fixed dose may not work for many risk categories.
So taking the question from Dr. Ashok to Dr. Sanjay, he is saying that as the category of the risk increases, we have to lower the therapy. So what is your say about safety and efficacy of very low level of atherogenic lipoprotein? How do we know that therapy has gone too far? And we have to, and if we found a LDL level of say 20 or 30, then what should be our management strategy?
See, for that, we have to know what is the LDL level when a child is born and when he is growing. At that time, the LDL level is 20 milligram per deciliter. So even 20 milligram per deciliter, and we have full brain function developing, so that is not too low. And that is intense. At that level, the progression of atherosclerosis is prevented to a much more extent. So it depends on the lowering has to be below 50 milligram per deciliter. In those patients, particularly those having coronary artery disease and diabetes, it has to be intense lowering of the LDL cholesterol level. Apart from that, the triglycerides are also very important. Previously, it was believed that triglycerides are not that important, but at the moment, it is seen that triglycerides are also an important component, and apart from lowering LDL cholesterol level, and particularly the most important component of LDL is the small, dense LDL cholesterol, which gets into the endothelium and leads to the formation of foam cells. So that is important, but triglycerides are also an important component, and should be one of the targets for lowering the atherogenicity in these patients. But the LDL cholesterol level remains the most important target. And lipoprotein A is also an important target, though we do not have any drugs at the moment to lower the lipoprotein little a in the therapeutic range, though the trials are there which have lowered the lipoprotein A level to more than 50%. And those drugs in future may be more effective in these patients to reduce their atherosclerotic risk.
Now, my question to Dr. Gaurav is that, what do you say about PCSK9 inhibitors to be used in diabetics, or we can use in diabetic patients also?
No, I think PCSK9 inhibitors are a wonderful class of drugs. Over the last few years, it is now, we've been looking at drugs beyond statins to mitigate the residual risk, especially in patients who are not able to achieve their LDL targets. So PCSK9 inhibitors have closed that gap, at least as of now, and we've seen that multiple drugs have come in, and they've proven even in the clinical outcome trials, like the Odyssey and the Fourier, that in patients who have coronary artery disease, they are not able to achieve a LDL target of less than 70. These drugs, when you add them, they reduce the cholesterol levels, the LDL levels, by almost up to 50%. And it also helps to reduce in the MACE events. So I think there is a sufficient clinical evidence to use them as lipid-lowering agents in patients who are very high risk, or probably those who are statin intolerant. I would say, in my clinical practice, or I'm in part of some trials with these drugs also, Indian patients, typically if we use very high dose statins or we use the combinations that we have available, ezetimibe, bempedoic, there are hardly 10%, I would say, or less than 10% who need actually to be escalated to PCSK9. And affordability is a concern. But there is a lot of clinical evidence. With the inclisiran having come in, I think, again, I'm part of the trial that they are trying to build up the clinical evidence and the initial data that whatever has been suggested does indicate that there is going to be a clinical benefit. Advantage with inclisiran is going to be that you just give it, every 3 months initially and then every 6 months. So I think that is a major advantage. And once inclisiran is proved, then probably, the other drugs will take a back seat. So I think a wonderful journey ahead for lipid-lowering therapy.
Thank you, sir. Any questions from the audience to the panelists?
Maybe I can ask Dr. Saurabh?
Yes,
Dr. Sanjay, just wanted to go back to the point that you were mentioning how low is low for us, and you said a child born has 20 milligram of cholesterol. So the child is growing at that age, and I believe there are neural connections being made. There is a cognition which is improving, and which is, I believe, an ongoing process. Do you think a long-term statin use of high doses, reducing it to even lower levels, could impact the cognition in the long run in certain patients, or do you think that is only a theoretical risk, or is there any evidence?
See, up till 20 milligram per deciliter, we do not have any major concern. But lowering further may have some concerns, because we know the cholesterol is part of every cell in the body. Even the brain cells have cholesterol. So cholesterol is important for us. Cholesterol is important for life, and we should not say that you totally ban the cholesterol. But we have to lower it to such levels. Our atherosclerosis does not occur. And as you know, the coronary artery disease is the most important cause of death in patients with diabetes. So atherosclerosis has to be reduced. And apart from atherosclerosis, which we tend to forget, is atherosclerosis is an inflammatory process. We have also to reduce the inflammation. So there are trials undergoing at the moment for reducing the inflammation. Besides, though LDL, the statins have a pleiotropic effect, and not only they lower the LDL cholesterol level, they do not much cause the regression of atherosclerotic plaque that has occurred, but make the endothelium much more stable. The plaque becomes much more stable, so chances of disruption and development of myocardial infarction is reduced to a remarkable extent. Even we do not lower the LDL cholesterol level to that extent. So even in patients who are intolerant to statins, giving a small dose of statin is very important, because of these effects of stabilizing the plaque and preventing the myocardial infarction developing in these patients.
Thank you.
So there are no more questions, so we can close up the panel discussion with the say that, if I am wrong, panelists can add, that there is a different approach to a dyslipidemia in a diabetic patients. The dyslipidemia is different in a diabetic. There is small dense lipoprotein levels, LDL levels are a little bit normal, there is a hypertriglyceridemia, and there is a decrease in the HDL cholesterol. The risk assessment tools are different. We have to use different risk assessment tools for diabetic dyslipidemia as well as non-diabetic dyslipidemia. And we can assess both the type of, while assessing the cholesterol, we can do fasting as well as postprandial triglyceride level, postprandial levels also. The targets of therapy are different, and we have to lower the levels as per the risk factors. And if we add on diabetes itself becomes a risk factors, and when we reduce the risk factors, if patient has coronary artery disease, then the risk factor is further increased, so the targets becomes more low, and starting fixed dosing is not very much required. We have to monitor, and we can change the intensity levels and the dosing. The safety and efficacy of lipoprotein levels are less, and we can target even to less than 50. And as Sir has said, that 20 is the requirement when the brain develops. So what I think that the panel agrees with the target of less than 50, and PCSK9 inhibitors are the wonderful drugs which are in the pipelines and will be used in the future. Thank you.
most important, we should not forget about the lifestyle management, which is the first approach to management of these patients, even in diabetes or diabetic dyslipidemias.
Yes, the lifestyle is the first and foremost thing, and every prescription should start with lifestyle modification, that is diet and exercise. That should be the first part of the prescription.
I thank all the panelists and the moderator for such an elusive and illuminating discussion, and request the dignitaries to please move to the presentation desk. Now we move to our next session, and I extend my warm greetings to our respected chairpersons for the next session. Our chairpersons are Dr. H.P. Singh. He is the Senior Consultant in Internal Medicine, East Delhi. Dr. H.P. Singh. Then we have amongst us Dr. Jimmy Pathak. She is a Senior Consultant, Department of Endocrinology, Max Hospital, Vaishali. Dr. Jimmy Pathak, ma'am. We have Dr. Nilesh Kapoor. He's a Senior Consultant and physician, lawyer, and a healthcare entrepreneur. And he's a visiting consultant to multiple hospitals like Kailash Hospital, Yatharth Hospital, and Manipal Group of Hospitals. We have amongst us Dr. Snehalata Verma. Ma'am is the Associate Professor at LLRM Institute of Meerut, and she's a co-opted member of UP RSSDI and editorial board member of NMO Journal. I invite on stage Dr. V.K. Gupta. He's a senior consultant, internal medicine, practicing in East Delhi. As we all know that the status of diabetes management has changed over the generations with the evolution of various modalities of treatment, starting from oral hypoglycemics to insulin, to the gene therapy, beta cell regeneration therapies, and nanotechnology. So in this segment, we talk about the eminent treatment strategies for diabetes, and our eminent speaker for this is Dr. Sandeep Buddhiraja, sir. He is a group medical director of PanMax Healthcare. He has over 50 publications to his kitty, and he has been awarded as Best Innovative Teaching Award by National Board of Examinations in 2019, and also S. Radhakrishnan Award for the National Teachers Award in 1921. I welcome you all to the stage.
Thank you, and it's a privilege to be speaking to this gathering here. So I'll try to do justice to this topic, which is actually quite theoretical. You say it's gonna... So, yeah. So we keep talking about the infections, antibiotic pipeline. Do we have enough antibiotics coming in the pipeline? On the same lines, we see that the prevalence of diabetes, and in this graph, you can see the green line is prevalence, how it is proposed to be increasing over the last 3 decades, over the next 3 decades, and the red line is the increase in type 1 diabetes. So are we having enough pipeline of medications, drugs available to handle this increasing prevalence of diabetes? And if you see the two graphs, the one on the right and the left, they tend to match each other. So there is a good news that at least in field of diabetes, we do have a lot of emerging technologies, emerging therapies, which can probably keep pace with which the diabetes prevalence is increasing. And hopefully, we are at a stage where we may be looking at curing diabetes, and not just treating, but curing diabetes. So I thought it's better that we divide the talk into 3 areas: the conventional targets for diabetes. These are all the drugs which we presently are using. Recent targets, many of these are in use presently and will have higher potential use in future. And most of my talk would be talking about future therapies or future targets for diabetes. And this is a very, very interesting array, because if you see the conventional targets and the recent targets, they mainly focus on insulin resistance, on insulin sensitization, whereas the future targets are more on other etiologies of diabetes, including obesity, adiposity, etc. So that difference you will clearly see as we go further in the talk. Now, I won't spend time on this. This is all the conventional targets of diabetes. All of us are aware, all of us using these for last many, many years and handling our patients when the glycemic, as far as the glycemic control is concerned. What has definitely changed, if you look at this table, is the way we look at managing a diabetic patient. Now, from being glucose-centric and basically focusing on HbA1c to handling the and becoming more complication-centric, and then now pathogenic-centric. And that is what I was talking about, obesity and insulin resistance. At the same time, we then choose the drugs depending upon the efficacy, whether we want to reduce the comorbidities and complications in a person who has a heart disease or a kidney disease or heart failure, a person's weight, whether he's obese or a lean diabetic, and then finally, what are our glycemic targets? So glycemic target is not the only criteria for managing diabetes, and this is a paradigm shift which has happened in how we look at managing diabetes over the last few decades. Now, coming to the recent targets. Now, these are list of certain drugs which presently are in use or potential to be increasingly used in coming future. Now, PPAR, most of us are aware, won't spend too much of time in this, but they are the transcription factors regulating the expression of genes, and they are of three types, alpha, gamma, and beta delta. We know thiazolidinediones belong to this PPAR gamma group. Now, important thing is that after activating, they reduce the free fatty acid levels in the blood. They change the adipokine levels, and they facilitate the lowering of glucose in liver, improve glucose intake into the skeletal muscles and adipose tissues, and increase the insulin release from pancreas. So overall, a very favorable metabolic profile with this group of drugs. Now, glucose-independent insulin-tropic polypeptide, GIP, it acts as at a level of intracellular cyclic AMP and activates protein kinase A. And there is a calcium-dependent increase which leads to transcription of pro-insulin gene, and that helps to increase insulin secretion from the beta cells. So it increases insulin, it increases glucagon, it causes beta cell proliferation, and reduces the beta cell apoptosis. These are all the drugs which are being considered as important targets for future developments. Now, G protein coupled receptor, GPCR, this is found in muscles and liver and in pancreas along in close proximity with beta cells. And they work more like what incretin hormones do and have a positive effect on insulin secretion. So they improve the glucose homeostasis, one by a direct method, which is on acting on the glucose-activated insulin release in the beta cells, and indirectly by release of GLP-1 and GIP from the gut. So because of these two factors, it has a favorable effect on improving glycemic control and overall metabolic profile. Free fatty acid receptor 1, again, has an incretin hormone-like effect, causing increased release of insulin from the pancreatic beta cells. Melatonin has become very controversial. What is the role of melatonin in glucose homeostasis? Interestingly, in type 1 diabetes, because of the activation of enzyme cascades, there is an increased production of melatonin, whereas in type 2 diabetes, there is a decreased production of melatonin because of a increase in the MRA expression. So one really does not know really in terms of melatonin having which side of glucose homeostasis it will work, but this is an important molecule which is being worked presently in research labs. Now, there are a lot of future targets, and these have sometimes been found incidentally and sometimes which have been researched to develop molecules which could promote glucose homeostasis. Now, I'll sort of cover these slides a bit fast. 11-beta hydroxysteroid dehydrogenase. So it affects the cortisol metabolism. Normally, we know that cortisone converted to cortisol, which is the active glucocorticoid. And these are two different types of enzymes, type 1 and type 2 enzyme. And it is a type 1 enzyme which is known to improve insulin sensitivity. So 11B hydroxysteroid dehydrogenase type 1 may have a very favorable outcome in reducing the blood glucose levels and is an important molecular target for treatment of diabetes in future. There's another molecule called ACRP30. Now, adipose tissue we know has a, is a source of hormones like resistin, adipocin, leptin, TNF-alpha, aptonectin, and ACRP30 is one of these. So, increased level of ARCP30 in circulation, the insulin sensitivity increases. So there is a direct correlation. So this again becomes an important future potential molecule for improving the insulin sensitivity. Futin A, it is a glycoprotein synthesized in liver and released into circulation. And it is a major protein which is required to be carrying free fatty acid in the circulation and involved in inflammation of beta cells. So studies reveal that there's an increase in insulin sensitivity in mice, which are having futilin A knockout gene. So if you knock out the gene which produces futilin A, the insulin sensitivity improves. So here there's a negative correlation. So the future molecular target is to block this gene. Visfatin is a multifunctional protein, again found in number of organs, and mostly articulated in visceral adipose tissue. And recent studies have shown that visfatin attaches to insulin receptors at a location other than that of insulin and causes an insulin mimetic action. So it is something which promotes promotes glucose homeostasis in a way of causing normoglycemia, one-to-one direct correlation. Now, this is an interesting molecule called mentrel, which is derived from adipokine, and it basically has presence in multiple cells, muscle, nerve, and liver, and fat. Now, in fat cells, upregulation of mentrel increases the lipid metabolism, and it relieves of free fatty acid-induced inflammation. So again, it is an anti-inflammatory and an insulin mimetic. PEDF, which is the pigment epithelium-derived factor. Now, it was found that in animal studies, it decreases the insulin sensitivity. So anti-PEDF is what will improve. It again now is opposite. So higher levels increase the sugar. So anti-PEDF will be a hypoglycemic agent. Vaspin is again a serum glycoprotein which comes from this serpin superfamily. Now it works at a level of white adipose tissue. And it reduces the blood glucose level by reducing the hepatic glucose production of sugar. So again, it has a direct correlation. There's another molecule, G protein coupled estrogen receptors, and it is working at the level of estrogen by increasing the estrogen hormones. And we know that premenopausal estrogen level is protective. So in that way, it's a direct correlation, and estrogen receptor drugs can help reduce the sugars. Lots have been tried of trying to deliver insulin in oral form. Why it has repeatedly failed is because of the gastrointestinal enzyme depletion and slow absorption. But in 2025, the last line you can see, there's a company which is in advanced stages of coming out with the oral preparation of insulin. Now, these are all various nanoparticles. There's huge development which is happening in delivery of molecules so that the degradation does not happen and a smaller dose can have a bigger effect. So all these are various technologies by which nano carrier-based treatments can be and will be delivered going forward in future. Now, there are some microbiome-based therapies which are being tried. There is this protein inhibitor called EPA-beta-lone, which is considered to be a anti-inflammatory and insulin sensitizer. Now, there is this insulin sensitizing substance, which is a hormonal-based therapy called heptalin, and it is being tried in pre-diabetes. But there are two real breakthroughs in research which are now being used. The second one especially. The first one is a novel therapy which is targeting the hepatic torque axis to suppress ketogenesis. So this pathway presents a potential target for managing diabetes ketoacidosis, especially in type 1 diabetics. Now the second is a therapy called teplizumab, which is a humanized monoclonal antibody, which is supposed to delay the onset of type 1 diabetes. It targets the T cells by binding to CD3. Exact mechanism is not known, but in November 22, teplizumab became the first FDA-approved drug with the intention of delaying the progression of type 1 diabetes. This publication came in 23 December in NEJM. And what you see is that patients treated with teplizumab had a significantly higher C-peptide levels as compared to those receiving other alternative drugs. Adverse events were minimal, so the time for period for glycemic control was higher with teplizumab, and of course, I said the C-peptide levels were higher. Once weekly insulin is something which is going to be available in coming year or two, and there have been a lot of studies on insulin icodec in type 1 diabetes and in type 2 diabetes, and they have shown similar HbA1c reductions and lesser risk of hypoglycemia, except in type 1 patients in this study where they found slightly higher risk of hypoglycemia. So this is something which is on the market probably in a year or so. But most important group of medications, the weight reduction medications, therapies, GLP-1 RAs, so and related families. So this tirzepatide, which is once a week, and there have been a lot of studies, very significant weight reduction, and there have been head-to-head trials between semaglutide, liraglutide, and tirzepatide, and up to 15 to 20% weight reduction. A combination of amylin and GLP-1 dual antagonist. Now, amylin is a pancreatic islet hormone that is co-secreted with insulin. It suppresses postprandial glucagon and delays gastric emptying. Now, there's a long-acting analog of amylin, which is called cagrilintide. Now, this cagrilintide has been shown to be very effective either as a single drug or in combination with semaglutide. So they've done a head-to-head comparison of the combination, which is cargisema, semaglutide, and cagrilintide, and found that the combination therapy has the highest HbA1c reduction and the highest weight reduction of almost 15%. And now there is a triple therapy, which is GIP, glucagon, and GLP-1 triple agonist receptor called retatrutide. And that is also shown to be highly effective, both in HbA1c reduction at optimal doses, up to 2% reduction in HbA1c and 16.9% reduction in weight over a period of about 36 weeks. Then there is this oral GLP-1 non-peptide receptor agonist called orforglipron, which is also effective up to 2% reduction in HbA1c and almost 10 kg weight reduction in a 26 weeks period. So these 3-4 drugs which I have mentioned here are actually going to be very, very prominent drugs when it comes to metabolic control in diabetes. CGM monitoring, presently we associate with glucose monitoring, but there are monitors which are going to be dual glucose and ketone monitoring available. And now we are looking forward for devices which will be completely non-intrusive. So by breath using the VOCs, and by the Raman technology where you just put a finger on the probe and there's a light emission, and both these technologies are being standardized for giving highly accurate sugar readings. So the time of pricking the fingers probably is now going to be out. And this is my last slide. I have not touched on these topics because there's a separate dedicated talk about all these therapies which have a clear potential of curing diabetes, and these includes islet cell transplantation, artificial pancreas, tissue engineering, gene therapy, stem cell therapy, and last but not the least, immunotherapy. We talk about immunotherapy in cancers, now we are talking about immunotherapy in endocrinology and diabetes. So there's going to be a talk in the afternoon, and we are, with these therapies, looking at a potential cure for diabetes in coming 1 decade. So I'll stop here. Thank you.
I must compliment you for a very comprehensive presentation. I mean, it covers everything that a future holds. I want to ask which of these is closer on the horizon?
So the closer would be all the anti-obesity medications which are listed in the last 4-5 slides. Or most of these are available, and some will be increasingly available. Many of these are not available in India, but presently FDA or European approved. Weekly insulin, I am told, would be available by 2025. The oral insulin would enter its phase 2 clinical trial in 2025. And all other therapies which I mentioned as potential targets, the maximum work goes in identifying the target and whether an agonist or an antagonist has to be developed. I think a lot of research is happening. Over the next 5 years, in all those molecules, you'll see phase 2 and phase 3 clinical trials happening. So I think those are still about 5 to 7 years down the line. But a weekly insulin, more GLP analogs, more effective anti-obesity drugs would be coming in next year or two. And I think we'll see a significant change in the overall algorithm of diabetes management with increasing role of GLP, 1 RAs coming up, even as a start of the therapy, not at later stage in diabetes.
Sir, a very comprehensive and very elaborate presentation, and quite a comprehensive glimpse into the future as well. Sir, any thoughts around inhalational insulin? As inhalation is also a kind of delivery mechanism that is being probed right now.
Yeah, so inhalational insulin had come in between, failed. Somehow, I did review the literature of inhaled insulins. Nothing promising seems to be on the avail. They are now focusing more on oral insulin, more on longer-acting insulins. Inhaled insulin somehow. So nanoparticles, they are focusing more on oral and injectable deliveries for nanoparticles. Again, not for nasal. Oral and injectables. Yeah. And nanoparticles, of course, nano molecules, and I mentioned a slide on various technologies being used. I think that's again a big future. And not only for diabetes, but for cancer therapy, for infectious disease. This is going to be a game changer. Nasal insulin, I did not get any encouraging studies which show any. Sorry?
Intranasal.
So that's what I'm saying. So intranasal had come in between, failed. After that, the studies haven't really shown any. Yeah.
Atrophic, because.
Sorry, can you put your mic?
It caused mucous membrane atrophy.
Yes, sir. And also the efficacy in terms of glycemic control wasn't, it was a very erratic spikes and troughs. Yeah.
Thank you, Dr. Sandeep, for awaiting all of us about the future therapies regarding the diabetes. And I am sure that all the audience who are sitting here having much more knowledge after your talk. I just want to know that in the patient of type 1 diabetics, is there any emerging therapies which slows down the destruction of beta cells, or which is having target on the
Yeah, of course. I showed you this molecule which has been approved by FDA for type 1 you are asking, no?
Yes,
yeah.
type 1.
So that is basically, they have tried, and that's a very interesting molecule. The moment a person gets diagnosed or there is, at a very early stage, they have tried this intravenous infusion for 12 days period into 2 doses given at an interval of 26 weeks. So you give 1 infusion for 12 days, 26 weeks interval, and 1 infusion for 12 days. And they have found for next 36 weeks, people who are treated with this monoclonal antibody, it is directed against CD3, it maintains normoglycemia without need for insulin. So that means it is delaying the progression of type 1 diabetes. Now, how long that effect will be sustained? So this is one molecule which has been FDA approved. Now, there are a similar class of molecules under development. So hopefully, from infusion, it will become self-injectable. It may become once a week. Right now, it is intravenous infusion and mostly on a, of course, it's FDA approved, so it is now available for therapies, early therapy also.
Have you aware that the endocrinologists or the persons, doctors who are dealing with type 1 diabetes, are they using that?
No. So this is just, 23 December I'm talking about. So it's just a few months. It's just probably FDA approved, so available only in US. I don't know whether it's even available in Europe or not right now.
Thank you, sir, for an elaborate talk. I would request your comments on invasive methods for type 2 diabetes control, like duodenal mucosal resurfacing and second question is role of prebiotics and probiotics.
Yeah. So the second question I'll take first. There is a clear role of probiotics. And I did mention one slide on a particular study where they have extensively studied the response to a particular a probiotic using a particular strain of bacteria, which improves the insulin sensitivity and are being tried for pre-diabetics patient, again, to delay the onset of diabetes. And in terms of invasive procedures which you are talking, work on exactly the same principle as our gut hormones, GIP and GLP-1. So any interference, and that is also true about the microbiome thing also, whether you do a physical intervention or you do a hormonal targeted intervention or you do a microbiome intervention, all three ultimately act at the level of GIP and GLP-1 and favorably or on the other direction negatively impact glycemic control. So I don't know whether the future use of any interventional technologies for manipulation will really be considered very high up in this thing, but at the molecular level, this is how it takes care of. I don't have any further insights into manipulation of duodenal mucosa in terms of real life experience. Thank you.
We conclude this session with this. Thank you, sir, for such a knowledgeable and informative talk. I request all the dignitaries to please proceed to the presentation desk outside. Thank you. Sure, sir. Now we head for the next plenary, Leadcon 2024 oration session. For this, I would start with inviting and introducing the chairpersons for this session. Our first chairperson is Scientific Committee Co-Chairman, Leadcon 2024, Dr. Amit Gupta. Dr. Amit Gupta, sir, he's the Director for Center for Diabetes Care at Greater Noida. Then I request Scientific Committee Chairman, Dr. Saurabh Srivastava, sir, to please come to the stage. He's the head of the department and Chief Medical Superintendent at Government Institute of Medical Sciences, Noida. Third chief guest we have is the Organizing Secretary for Leadcon 2024, Dr. Amit Kumar Sharma, sir. He's a professor in the Department of Medicine at Lady Hardinge Medical College. And I finally request Dr. Ajay Kumar Gupta, the Organizing Chairman of Leadcon 2024, to please come to the stage for the ceremony. And HOD, he's the head of the department in the Department of Medicine at Max Hospital, Vaishali. Now I request Dr. Amit Kumar Sharma, sir, to please take up the stage for further proceedings.
Thank you, Dr. Pensy. So I welcome you all for this first Leadcon oration. Leadcon was started 3 years back under the banner of Lotus Diabetes, which has been functioning as a scientific body, encouraging and assisting research, enhancing knowledge of practicing physicians, diabetologists, by means of symposiums, CMEs, and seminars that are likely to benefit people with diabetes. With that much of work, we thought of starting the oration, that is the Leadcon oration. Oration is being awarded to those eminent faculties who have done exceptional work in their field of expertise, and they have done a little bit of social work also. So this first Leadcon oration is being conferred upon to Dr. Narsingh Verma, sir, for its outstanding contribution in delivering and improving care for people with diabetes. So this is in recognition of exemplary initiatives that improve the quality of life for people living with diabetes. I request Dr. Tarun Goyal to come and escort Dr. Narsingh Verma, sir, to the dais for this Leadcon oration. Dr. Yasir, please. I would like to speak a little bit about sir. Sir is a professor and head Department of Physiology and officiating head Department of Family Medicine at King George Medical University, Lucknow. Sir has 298 original publications in peer-reviewed journals with thousands of citations. Sir has received 16 international and more than 38 national awards. Sir has done a lot of work in the cardiovascular and the metabolic research. He was a past president in Asia Pacific Society of Hypertension, President International Society for Medical Food and the Nutrition, immediate past president Uttar Pradesh Diabetes Association and International College of Nutrition, Secretary General Indian Society of Chrono Medicine, Treasurer Indian Society of Hypertension, Secretary presently American College of Physicians Indian chapter and the RSDI UP chapter. Sir is presently the Director South Asia Affairs of World Hypertensive League. I now welcome Dr. Pincy to go for the further proceedings.
Just a small addition. Sir is now the principal of Hind Medical College. And recently from 1st of May, he has joined as the principal of Hind Medical College.
Thank you, Amit sir. Now we proceed for the felicitation of our speaker. I invite on the stage Dr. Amit Sharma sir to present the shawl to the speaker. Thank you, sir. Next, I request Dr. Amit Gupta, sir, to present the scroll to our eminent guest. I request Dr. Saurabh Srivastava, sir, to please present the plaque to, to Dr. Narsingh Verma. And finally, I request Dr. Ajay Kumar Gupta, sir, to please present the medal to Dr. Narsingh. Amit sir, to please take the dais.
And now I welcome Narsingh Verma sir for his oration. Welcome you, sir.
First of all, I would like to thank organizers, Dr. Amit Sharma, Dr. Ajay, and Dr. Saurabh Srivastava, and Dr. Amit Gupta for honoring me. My journey started from chronobiology to chronomedicine. And in this oration, I thought that I must give some glimpses how that journey started. And the person behind this journey of chronobiology was the French Helberg. I met to him in 2004, and I was fascinated by his research in chronobiology and circadian rhythms. Then I started working in this particular field. And today, I have 308 publications. Out of that, more than 200 are circadian rhythms. So the credit goes to the fellow who gave the term circadian. French Helberg, born in 1919, and he died in June 9, 2013. He came to India in 2004, was a scientist and one of the founder of the modern chronobiology. He coined the term circadian. The circadian term was given by him. Before that, we used to term the variations in other terms, but not circadian term was not used. And he was the person who started the chronobiology laboratory at the University of Minnesota, and he research laid down the foundation for understanding the timing of biological processes and their relevance in the human health. First, he reported all this. So we know that biological rhythms, every biological action has a rhythm, particular rhythm. And that rhythm varies. And we have very short rhythms like the cardiac rhythms, 1 second. Even shorter than that, the neural rhythms, 0.001 to 1 second. Or we can have the circannual rhythms of 1 year. Our ovarian cycle, you already know, 28 days. Circadian rhythms are the rhythms which are 24 hours. And the rhythms also varies from 10 minutes to 24 hours. That's ultradian rhythms and circannual rhythms. And the rhythms can also for few minutes to few hours. So every physiological mechanism has got a rhythm. Circadian rhythm term is used when a particular biological, physiological mechanism has a rhythm of 24 hours from AM to PM or PM to AM, whatever you like to say. The body clock or circadian system anticipate the 24-hour light-dark cycle physiology in advance of changing conditions, and that is the circadian rhythm. So every physiological process had a particular circadian rhythm, and that has a particular peak at one time and also has a downtrend at a particular time. And if we see, most of the physiological mechanisms have this rhythm. Some have been studied in detail. Others are still to follow. We do not know, but they have a rhythm. That is perfectly fine. And this circadian regulation of central and peripheral clock in various organ systems is known. Now we know them better, and we know that at SCN nucleus, the various neural mechanisms are there, and that is called as central mechanism or central pacemakers. And we do have peripheral pacemakers in almost every cell except the germinal epithelium. Every cell has got a peripheral clock genes, and the central one at the SCN. Normally what happens, that central one is regulating the peripheral one, and peripheral ones are following the command from the central one, and that is the normal physiological mechanism. But when that rhythm is lost, we have a lot of diseases. And we chronobiologists believe that most of disease arise just because of loss of this particular rhythm. What we have learned from all this, for cells to function properly, they need the right material in the right place at the right time. If that is lost, then we develop disease. We chronobiologists believe that, and that is the thing which has not been in detail and not had been researched properly and not being utilized in medical practice. So I'm trying to give some data so that we can utilize this knowledge in our clinical practice and we can serve our patient better. Circadian desynchrony is the basic mechanism behind all mechanisms, but most commonly called in the various metabolic diseases. It is more true. But it is true for almost all diseases that circadian desynchrony is responsible for development of disease. Desynchrony among the SCN and the various oscillators in peripheral tissues result in circadian associated maladies. For example, if you take the example of diabetes, what happens? Normally, the central command says to beta cell that during night time, insulin requirement is less, so less insulin secretion will be there during night time. But if somebody takes dinner at 11 p.m., then what will happen? The insulin will be secreted from beta cell, but this is desynchrony. Because synchronization has lost, even without the permission of central clock, peripheral clock genes or peripheral oscillators are able to produce more and more insulin. So that is probably one of the examples I can put forward for the development of diabetes. Travel across multiple time zones, which has been studied, jet lag, we know it properly, and shift workers have been studied, and it has been found that shift workers have more diabetes, more hypertension, more metabolic disease, and other these NCDs are more common in them. Lifestyle, so-called modern lifestyle of giving impact on the lipid levels that was done during that period. Studies on a novel process for potentiation of oxidation stability of flaxseed oil, that was the basis on which a patent was granted by the government of India. And it was published in the Nature Journal of Human Hypertension, and it is available at ResearchGate. Internal Journal of Human Hypertension published effect of essential fatty acid blend on circadian variation of ambulatory blood pressure in patients with essential hypertension and coronary artery disease. In them, this essential fatty acid oil, blended oil was given, and we were able to show that this oil has some effect on circadian variation and maintains heart rate variability. Another publication was done on the variation in 7-day, 24-hour circadian pattern of ambulatory blood pressure and heart rate of type 2 diabetes patient, and it was published again in Journal of Diabetes Investigation, and we were able to show that in diabetic individual, blood pressure variability is more and heart rate variability is less. And because of that, they have more cardiovascular risk, and that can be known only when we do it for 7 days. 24 hours is not enough. And in that particular study, the salivary cortisol and urinary melatonin levels were also done to see the impact of these hormonal changes for the variation of the blood pressure. Then the reversing time, a possibility through chronobiology effect of time-restricted meal, TRM, was done, and this was done in diabetic patients and hypertensive patients, and we were able to show that in 3 to 6 months, acute effect of the TRM was there, and we were able to show that the diabetes was well controlled and blood pressure control was good. But if we continue that for more than 1 to 3 hours, the effect vanishes. That is the problem. Body physiology again readjusted. So we have to find more ways in the TRM. The circadian hyperamplitude tension, CHAT, is 7-day. In 7-day monitoring only, we can find out CHAT. CHAT term is given when the all 7-day data shows a hyperamplitude tension. And this was able to show that even in normotensive individuals, if the CHAT is there, we have higher risk, not only in hypertensive individuals. It was also published in Journal of Diabetes Investigation. Then the influence of melatonin on circadian pattern of blood pressure and autonomic regulation of cardiovascular system with a coronary artery disease. The patients were recruited from Lari Cardiology, 200 patients, and then melatonin was given. At that time, single melatonin tablet was not available. Aristo was making tablet of melatonin, but also having alprazolam. So I purchased melatonin from market. I asked one company to produce tablets for me for 5,000 tablets, and then research was done. And we were able to show that the influence of melatonin was favorable because of anti-inflammatory action of melatonin. The rhythm was better, and these patients were having the less reduced cardiovascular risk when melatonin was given. Melatonin of 4 milligram melatonin to 6 milligram melatonin was given in the evening time, 4 hours before bed. Then the circadian variability and reproducibility of blood pressure indices and cardiovascular autonomic regulation during different phases of reproductive cycle in premenopausal and postmenopausal women, and their correlation with gonadal hormone melatonin and sleep-wake cycle was studied by one of my PhD candidate, Shipra Bharadwaj, and this was funded by ICMR. In that, the better relationship between all these were studied, and we were able to show that the circadian variability has an impact and more harm on these patients. Then the TRM, we studied it for a very long time, and we were able to show that TRM can check and show the effect in the A1C, fasting glucose, prandial glucose, and in first 6 months, the effect was very nice. And all these patients were asked to take nothing after 7 p.m. And those patients who were not able to follow, they were controls, and those who were able to follow were cases. And we compared such 300 patients for 6 months in the OPD, endocrine OPD of KGMU, and we were able to show these results. The basic results were that the more changes were seen in the lipid levels rather than the glucose levels. And the various inferences in TRM were studied in that. Then the influence of melatonin in circadian pattern of blood pressure was studied again in another crossover study. 6 months melatonin was given, and then the same patient were off to melatonin, and then 6 months were given to the crossover patients, and we were able to show that the effect was not by chance changes early in the course of time. Then the variation in the blood pressure, in the circadian pattern of blood pressure and cardiovascular autonomic regulation in premenopausal women and postmenopausal women with relation to gonadal hormonal profile and melatonin was done again by Shipra Faradwaj, again a project by ICMR. Chronomedicine Insight it published a particular talk evaluating the impact of time-restricted meal intake on lipid profile. That I was mentioning, more effect was seen in lipid profile rather than blood sugar level, and was published in the. Then the impact of time-restricted meal on glycemic and weight management. It is recently published in 2024 in Curious Journal, 18-month longitudinal study we carry on TRM. And recently a paper has been published in Nature in which it has been shown that the TRM, we are more prandial in nature. So that is why fasting physiology versus prandial physiology, and if we stimulate fasting physiology, the effect will be more in Indians. So we must not stray away by the various researches going on in the Western world. We should go by our own study and try to create our own data. Then we will able to have own guidelines and follow up them. Because we Indians are different. We cannot copy to the European and the other US journals. This 24-hour chronomics of the ambulatory blood pressure, heart rate in terms of acrophage and hyperbaric index in night shift nursing professionals, that was the first study done in nursing professionals during night duty. It was done by one of my PhD student, B. Anjum, and was published in June 23, Journal of Hypertension. Then a chapter was written on the basis of our data on blue light, a regression in child development in book, and this particular book was Understanding Child Prenatal to Adolescent. And this was done to show that what is the impact of blue light in the form of mobile and other things which a child started using very early in the course of time, and that has an impact on the regression in child development. Development slows down. So out of all these studies, the time does not permit me to talk more about that. So what is the social significance of all these studies which we are doing, our group is doing? The social significance is rise with sun, rest with sun. That is the motto we have to follow. हमारा देश पिछले 50 सालों से 60 सालों से सोया नहीं है, unnecessary जग रहे हैं. जो नाइट ड्यूटी कर रहे हैं वो जग रहे हैं, जिनको कोई काम नहीं है मोबाइल में जग रहे हैं, अनावश्यक रूप से जग रहे हैं. तो हमारी कंट्री स्लीप डेफिशिएंट कंट्री हो गई है. ये बहुत बड़ा कारण है मेटाबॉलिक डिजीज का. एंड वर्किंग आवर्स मैनेजमेंट, दिस इज अगेन वेरी वेरी इंपॉर्टेंट इम्पैक्ट. आउट ऑफ दिस स्टडीज वी कैन फाइंड आउट इफ यू आर नॉट ए शिफ्ट वर्कर, अवॉइड लेट नाइट वर्किंग. 10 to 12 hours of light is best, and more than that light is not good. We are living in artificial world, artificial light everywhere. And so rise with sun, rest with sun, and choose chrono diet. For metabolic circadian rhythm maintenance and regulation, chrono diet is the best one. Remember that time is money. It was written by Benjamin Franklin, but today we can say, remember, the time is health. Time is important for health. And take home from this message is the association between type 2 diabetes and circadian disruption is clear now, but proper clinical guidelines should be implanted and implemented in clinical practice. Before that, we had to create more Indian data. Recent evidences indicate simply changing the timing of feeding and sleep-wake time can improve type 2 diabetes, and less medication will be required. Taken together, circadian rhythm in humans are regulated by a complex multi-level circadian oscillator system that undoubtedly provides an advantage for human health and essential for maintaining the proper metabolic control. However, this system becomes disadvantageous when lifestyle factors impose time constraints that produce circadian disruption. So we have to avoid circadian disruption as much as possible. This misalignment between internal circadian oscillators and the external environment is producing various diseases. In this regard, understanding the molecular and physiological mechanisms responsible for circadian disruption, associated risk of type 2 diabetes, warrants further research and holds a potential for contributing to the development of novel therapeutic and preventive strategies for patients with type 2 diabetes. Because you will agree, in 1920, there was one drug for diabetes, insulin. Today we have 20 drugs, but the diabetes is still rising. So we have to think beyond drugs, and that's what I'm trying to say. Thank you very much.
Thank you, sir. Thank you very much for this nice oration. And undoubtedly, he receives a standing ovation from the hall. Like what sir said, should be physiologically followed, but practically I don't know how many will be able to follow.
I am following it.
Since we have no questions in this session, so I'll request you please be seated and we'll proceed for the next program of inauguration.
Thank you. Thank you.
Thank you, Verma sir, for the wonderful deliberation. Now I request the honorable chairpersons to felicitate the respected speaker. Please take this. Should we start the inauguration now? Okay. Now we proceed for the inauguration ceremony. Diabetes is one of the important global epidemic. It is affecting millions of people worldwide. In India itself, we have 11.4% of the population affected with diabetes. And this counts to around 100 million people. And it is projected that they will reach around 130 million by 2045. This colloquium represents an opportunity to ignite a spark of innovative ideas and conversations towards a goal of improving diabetes care in our patients and prevent the occurrence in those who are at risk of the disease. On the behalf of Leadcon 2024, it's my pleasure to extend a warm welcome to each and every one of you present here. Now we begin with the inauguration ceremony. To commence with, I would invite on stage our organizing chairman, Dr. Ajay Kumar Gupta. Our next chairperson on stage, Dr. Amit Kumar Sharma, who is the organizing secretary of Leadcon 2024. Then I invite the chairman of scientific committee, Dr. Saurabh Srivastava, and co-chairman scientific committee, Dr. Amit Gupta, on the stage. You've already been introduced to all of these talented gentlemen. Now I would request for a big round of applause for our esteemed guest of honors. Our first guest is Dr. L.H. Kotekar, sir. He's the Director Professor and Head of the Department of Medicine at Lady Hardinge Medical College. I extend my warm greetings to our next guest, Dr. Anupam Prakash, sir. He's a Director Professor in the Department of Medicine at Lady Hardinge Medical College, and he is the President of Indian Society of Atherosclerosis Research. Our next guest is Dr. Gaurav Agarwal. He is a Senior Vice President, Max Hospital, Vaishali. I welcome on stage Dr. Sandeep Buddhiraja, sir, Group Medical Director, Pan Max Healthcare. Next, we have Brigadier Dr. Rakesh Gupta, who is the Dean of Government Institute of Medical Sciences, Noida. And now I welcome on stage our revered chief guest, Dr. Mahesh Verma, Padma Shri B.C. Roy Awardee, Vice Chancellor, Guru Gobind Singh University, Guru Gobind Singh Indraprastha University, New Delhi. I request Dr. Amit sir to kindly escort him to the stage. Now I request Dr. Amit Kumar to please welcome Dr. L.H. Kotekar, sir. Dr. Charu Gupta to please welcome Dr. Anupam Prakash, sir. Dr. Vandana ma'am to please come to the stage to welcome Dr. Gaurav Agarwal. Please get. Please give it to me. Thank you so much. Can I request Dr. Ashok Grover sir to please come to the stage and welcome Dr. Sandeep Buddhiraja sir. Please come and give it to me. Dr. Saurabh Srivastava sir to please greet Dr. Brigadier Dr. Rakesh Gupta sir. Dr. Ajay Kumar Gupta sir to please welcome Dr. Mahesh Verma sir. Warm welcome to all our respected guests of honor. Before we proceed further, I would request all the respected dignitaries, members of organizing committee, esteemed faculty members, Dr. Aparna ma'am, Dr. Ashok Grover sir, Dr. Vandana ma'am, Dr. Anuj Maheshwari sir, Dr. Nasing sir, all our delegates to join us for the lamp lighting session. We begin with invoking the blessings of Mother Saraswati with Saraswati salutations, followed by the lamp lighting. I humbly bid the organizing chairman, Dr. Ajay Gupta sir, to say a few words for the welcome address.
Thank you, Princey. And at the outset, on behalf of my organizing team, which includes my organizing secretary, Dr. Amit Sharma, my scientific chairman, Dr. Saurabh Srivastava, Dr. Amit, and Dr. Amitesh, I welcome all the distinguished guests, Dr. Mahesh Verma sir, Dr. Sandeep Buddhiraja sir, Brigadier Rakesh Gupta sir, Dr. Gaurav, Dr. Anupam, and Dr. Ghotekar. A very warm welcome. And rather, warm welcome to Dr. Gotekar's place, I should say, because we are conducting this program at LHMC. So when we started this Leadcon, this was a novel concept when we started this Leadcon, and there were many questions like, why have you kept these 4 colors of lead? So these are the 4 colors which mention the 4 parts in a diabetic patient which we have to manage and monitor. The first is the blue, the glycemic control. Then the second was orange or light yellowish color, which represents the macula or the retinopathy. Then the third is for the green kidneys. Light green color, if you have green kidneys, if you are a diabetic having green kidneys, you are okay. Like we had a discussion in the morning sessions also about the kidney disease and about the decreasing the level of sugar so that the kidneys remain green. Then the last is the red, and nothing to say, this is for the cardiac and the arterial diseases. So these were the concepts which we had kept in mind when we started this Leadcon. So I congratulate my team for this 3rd annual meet of the Leadcon, and I request Dr. Amit Sharma and Dr. Saurabh Srivastava to just make a detail about this conference. Thank you very much. And thank you all delegates for coming also.
Thank you, sir. I invite Dr. Saurabh Srivastava, sir, the scientific chairman of Leadcon 2024, to address the meeting.
आदरणीय डॉक्टर महेश वर्मा सर, ब्रिगेडियर राकेश गुप्ता सर, मेरे डायरेक्टर सर, डॉक्टर गोटेकर सर, डॉक्टर अनुपम, डॉक्टर गौरव, डॉक्टर बुद्धिराजा और मेरी टीम, डॉक्टर अमित, डॉक्टर अमितेश जो कि यहाँ नहीं है आज की डेट में, डॉक्टर अमित शर्मा, डॉक्टर अजय गुप्ता, ये हमारा एक ग्रुप है जो हम 4-5 लोग हैं जिन्होंने इस ग्रुप को चालू किया और हम ये कॉन्फ्रेंस ऑर्गेनाइज करते हैं। एक ये है लीडकॉन और एक हम डायलॉग्स इन डायबिटीज, 2 कॉन्फ्रेंस ऑर्गेनाइज करते हैं जो कि एक इस तरह से ये एक रीसेंट एडिशन है जिसमें कि अभी आपको डॉक्टर अजय ने बताया कि हमने लीड क्या सोच के रखा था और लीड कैसे हम आगे कर रहे हैं और कैसे हम इसको आगे बढ़ रहे हैं। द मेन आइडिया जो इस कॉन्फ्रेंस को रखने का था, इस बार के जो हमारा थीम थी डायबिटीज स्नीकिंग इनटू द फ्यूचर, और हमने कोशिश ये की कि हमने इसमें टॉपिक इस तरह के रखे जो कि हमें ये बताएं कि हम फ्यूचर में डायबिटीज़ के बारे में क्या करने वाले हैं और क्या क्या फ्यूचर एस्पेक्ट्स हैं जो कि डायबिटीज़ में हैं और हम क्या बेहतर पा सकते हैं डायबिटीज़ के मैनेजमेंट में इन द नियर फ्यूचर। तो अभी तक की जितनी भी टॉक्स हुई हैं उसमें आपने देखा कि बहुत सारी चीज़ें ऐसी हैं जो चलती रही हैं जिसके बारे में हमने देखा कि जो हमारे फ्यूचर में कैसे कैसे हम डायबिटीज़ के मैनेजमेंट को आगे बढ़ाने वाले हैं उसके रिलेटेड थी। और आगे के जो पैनल डिस्कशंस और डिबेट और लेक्चर्स जो हैं वो भी इसी चीज़ के लिए हैं और ये काफ़ी हद तक क्यूरेट किए गए थे पीजी को ध्यान में रखते हुए, क्योंकि हम एलएचएमसी के ऑडिटोरियम में कर रहे हैं तो हमारा टारगेट ये था कि पीजीज़ इससे बेहतर तरीके से सीखें और इसी चीज़ को आगे रखते हुए हमने इसकी थीम रखी थी और इसको हमने डिज़ाइन किया था। और मैं ये होप करता हूँ कि ये हमारी कॉन्फ्रेंस और हमारा ये साइंटिफिक प्रोग्राम उस पैटर्न को मीट करे जिसको सोच के हमने इसको चालू किया था। धन्यवाद।
Thank you, sir. Now I request Dr. L.H. Gotekar, sir, to say a few words of wisdom to all of us.
At the outset, very good afternoon. And on behalf of Leadcon and Lady Hardinge Medical College and all the co-partners, I welcome you all here. And it's a proud privilege for the Lady Hardinge Medicine Department that we could, with the help of all the organizers, we are able to organize this conference, which not only talking about the diabetes, but as such for the healthy lifestyle and how can we prevent the complications. I'm thankful to all team members who had given us an opportunity to organize this conference, Leadcon in Lady Hardinge. So first of all, I would really thank everybody of you that you had given us an opportunity. And fortunately, Dr. Amit Sharma has taken a lead in this Leadcon to organize this conference here. I'm thankful to the Dr. Mahesh Verma sir, who has kindly agreed to inaugurate the session. No conference can be successful without the participants, expert speakers, and whosoever from the resident level or interns who take part actively in this conference. You must be wondering why particularly this topic was chosen. But you know there are so many conferences happens about diabetes. But if you see the scientific content which has been presented here, the main focus about the future and the present, how can we prevent it? That is the basic crux of it. As the theme, you know it, it's about the sneaking into the future. That's the main theme. And I think you should all applaud for this wonderful organizing team who are standing together and making it happen. So I wish all of them a very good success. And thank you very much for coming and enjoying this beautiful property. You might have seen the Lady Harding what it was earlier. Many of you, the Lady Harding students here or a resident, there's a lot of change and we are going to progress this further. This is a promise which I can give it to you. Thank you so much.
Thank you for the wise words, sir. Now I entreat Dr. Anupam Prakash, sir, to address the end gathering with his percipients.
Well, a very good afternoon. I will not take a lot of time here because I know a number of dignitaries are waiting. As President of ISAR as well as a faculty in Department of Medicine, Lady Harding, it is a proud pleasure to welcome you all. And I would say a couple of things because as Dr. Ajay Gupta has said that yes, Leadcon is a venture. So when they approached us for an academic partner, it was two-sided. So we will also be including these things when we hold ISAR annual function also. So it is a measure of coexistence which will go in the long run. So I am sure that we will take this step and further also because ISAR is an annual body conference that we have and it is a body which has persons from all the fields and it has an International Atherosclerosis Society affiliation also. So we have a number of things to offer and I'm sure that everybody who is sitting here and those associations which are also academic partners will benefit from it. Well, thank you. Thank you so much.
Thank you, sir. Now I request Dr. Gaurav Agarwal, sir, to address the audiences.
Thank you. Good afternoon. Namaskar. Respected Dr. Mahesh Verma, sir, Dr. Sandeep Buddhiraja, senior dignitaries on the dais, and all the participants of this wonderful conference. You know, I am an administrator heading Max Hospital, Vaishali, but at the heart of it, you know, I am a physician. So attending such conferences ignite the physician spark in me. More importantly, you know, managing a super specialty hospital, you know, it's all about super specialties. But since, you know, the education has been as a physician, I understand that whatever super specialties we run in any hospital, that the base and the foundation of any good hospital is the Department of Internal Medicine. And diabetes management still forms the mainstay of any form of treatment. Compliments to the organizing team, Dr. Ajay Gupta and the entire management committee of Leadcon for, you know, having these fruitful discussions. And, you know, the most thrilling part was when Dr. Ajay Gupta shared with me that, Dr. Gaurav, do you know where the venue is and who are our collaborators in this conference? It's Lady Harding Medical College, Department of Internal Medicine. To come here and just to see this auditorium, you know, it just motivates you so much. And I was just sharing with Dr. Anupam, what a wonderful venue. And that is what, you know, sometimes we get, you know, clouded in our own world. But, you know, to be here, it's such an honor and such a privilege to be here. Just one more point. Yesterday, I got a call from one of a very senior principal in the most prominent schools in the city of Delhi, that her father is in Muradabad and he's a diabetic and his diabetes is, you know, off the charts. So Dr. Gaurav, can you just get an appointment for him? And he'll be traveling to Muradabad, from Muradabad, and he's not very keen to, you know, come and visit. So I facilitated that. Won't you believe, our physician interacted with this gentleman, and the issue was that his technique of insulin was completely wrong. And he has been on insulin from so many years. So the point I'm trying to make to the young postgraduates is the theory is important, but our communication and the practical tips of diabetes management is also equally important. So thank you so much.
Thank you, sir. Now I invite on stage Dr. Sandeep Buddhiraja, sir, to share his words of wisdom.
So big compliments to the organizers for putting this conference in place. A very important, relevant topic, I think, cuts across specialties. It's not a field which is practiced only by endocrinologists. I think the GPs, physicians, for interns, residents, is a very, very important topic, and especially the focus on recent advances. And personally, for me, it's always nostalgic to come back to this place. I have sort of true, sir, very strong associations with Harding. Of course, I come from Ulama Azad. My wife did her graduation, post-graduation from Harding, and actually stayed in this hostel for 6 months after our marriage for preparing for the final exams. And my postgraduate final exam happened in Harding. So it's actually a complete change of the campus. I have had 1 or 2 opportunities to come in between. Every time you come here, it's a new place. So very, very nice to come back to Harding and interact with people and share the podium with speakers. So thank you, and compliments again to the organizers. Thank you.
Thank you, sir. I request Brigadier Dr. Rakesh Gupta, sir, to please address the floor.
Thank you, Madam. Professor Mahesh Verma, all the dignitaries on the dais, off the dais, senior faculty members, ladies and gentlemen. Firstly, thank you very much, organizers, for making GIMS as a part of this big initiative, big conference. And at the GIMS, I can always say that we are always ready for this good and big cause. All of you must agree with me that diabetes is a problem, and this problem is exponentially increasing. The way the figures are quoting now, 521 billion, and then it's going to 1.3 billion. I think huge patient load is going to increase. What I see, that number of resources is not increasing the way the diabetes is increasing. So we all must be equipped, we all must disseminate, we all must increase the workforce capacity building in this diabetes. Another thing we realized in our institute that diabetes, everybody is seeing diabetic patients, but they are not actually getting a comprehensive holistic treatment. So in our institute, we started the diabetic clinic, and to our surprise, I think within a year, more than 1,500 patients are actually being followed up. It is not only doctor to patient, but among the patient, they are actually getting a lot of knowledge, lot of things which probably they are doing, and we are very happy to share that this center is actually established and doing very good work. Regarding capacity building, we have started fellowships in diabetes. That also is quite popular. Our concern, if we see the profile of diabetic patient, more and more young people are actually getting diabetes. Previously, it used to be only type 1 diabetes. Now, even type 2 diabetes is seen even in 20s and 30s, which is, I think, it is alarming for us. And post-COVID, actually, we have again seen a huge increase in the number. And for that, I'll say it's not only diabetes, but it's all lifestyle diseases which are actually responsible. And I'll be happy in case we have some deliberations on the primary and primordial prevention of diabetes rather than we are fighting diabetes. So I think this conference, this initiative, I think will go a long way in addressing our views. So thank you very much for calling me and inviting me a part of it. Thank you so much.
Thank you, sir. Now, I humbly bid our eminent chief guest, Dr. Mahesh Verma, to share his thoughts.
Dr. Ajay Kumar Gupta, Chair of the Leadcon 2024, Organizing Secretary, Dr. Amit Sharma, Saurabh Srivastav, Chair of the Scientific Program. We have a number of guests of honor here, Dr. Ghotekar, Dr. Anupam Prakash, Gaurav Agarwal, Dr. Sandeep Budhiraja, Brigadier Rakesh Gupta. I'm missing Professor Piyush Gupta. He was supposed to be here from UCMS. I, in fact, chair UCMS. That's why. So thank you for partnering with UCMS also, along with GIBS. And all the organizing team. We also have an orator. I listened to Dr. Verma, who delivered oration just now, Nursing Verma. Yeah, he's here. Very nice. I had a little bit of your oration, very enlightening. And of course, I think we also going to listen to Sandeep Budhiraja, another keynote speaker today. It's such a pleasure, in fact, when I was called by Amit Sharma that I got to be here for Leadcon. I said, okay, I would be here, but I think, something which we are all grappling with, the pandemic of diabetes, which is truly very cause of a concern, as just now said, that young people are getting more type 2 diabetes, and I think it really needs something very urgent. We really need to do something together, because not only that, I think the entire healthcare professionals, they require unwavering commitment, truly, in the real, letter and spirit that we need to do something about it. It's always said that sweet memories, sweet thoughts, and sweet dreams, and sweet talk, all those are fine, but too much of a sweetness in blood is not really welcome. And I think it's our duty today that we, lead the charge. And, as everybody, I endorse the views that, all the preventive measures, early detection and comprehensive management, so that we can really bring down this rising tide of diabetes. ये ऐसा tide, ऐसा ज्वार भाटा है जो बढ़ ही रहा है और घटने में नहीं आ रहा. I think our goal to treat diabetes is not just to empower individuals, take care of them, but also, I think, to inform them, knowledge, information, as Gaurav just said, that the level of communication, so that we do not allow it to happen at the first place. जैसे कहते हैं ना, सावधानी हटी और दुर्घटना घटी. I think that we have to ensure that we carry our strategies so that there is, we prevent it to happen, because, even if we put all our resources together, manpower together, we really cannot treat the kind of humongous problem we are facing today, managing diabetes. So we got to create some kind of andolan, some kind of mass movement, create environment so that we can really prevent this diabetes at a community level, at a public level, at a society level. I think some kind of andolan, really, some kind of mass movement. I think it is around, but we are still not doing it. We need to make a lot of noise. We really, wake up from deep slumbers, all the authorities, all the bodies who are responsible for it. Because, diabetes is something which doesn't discriminate anybody. It affects all ages, all races, anybody, all from different socio-economic background. So I think as a healthcare professional or as a specialist, I think we must strive not only treating patients, but also equity of access to care and resources affected by it. We have seen it, how we treat COX or how we treat TB, how we have seen that equity of access. Today, I think that's a big issue today. And so let us not just wait for diabetes to become bigger problem. I think we got to be proactive so that we prevent. And how does prevention happen? We all know prevention starts with education, awareness, and empowering individuals and take control of their health. And how far we have been able to do that, I think we really need to understand, and we really, the health authorities have to understand that, how much we have done that. And the face of diabetes epidemic, our role as a specialist, I think it extends much beyond our clinic walls, because we got to collaborate with policy makers, the government, the RWAs, the community leaders, and all other stakeholders, so that we can really implement at community level or population level interventions, so that we can promote health and prevent disease. This includes all NCDs, because that has to be an utmost priority today, because not just diabetes, but all over, all the NCDs, I think that has been a big issue. And as a healthcare provider, we have the responsibility, or we got to do that. We need to advocate the evidence-based policies, evidence-based practices, interventions, and what is the root cause of of diabetes, including unhealthy diets, sedentary lives, as we all been talking. And I feel that all NCDs, including diabetes, is a manifestation of plenty. Today everything is available in plenty. We want to eat more. We want to have more pleasures of life. We want to take more rest. We want to enjoy more, and all these are. And so also, when there's a manifestation of plenty, also results in plenty of diseases. So, so the recent intervention, as your theme says, that sneaking for the future, there has been many path-breaking interventions in diabetic management, whether it is precision medicine or personalized care through genetic makeup of an individual, or all those insulin pumps and insulin delivery systems, continuous glucose monitoring systems, GLP-1, as Professor Verma was talking about, all those injectables, Ozempic, all those things. I happen to know some of my international friends who suddenly found, you look like a different individual. He said, I'm taking Ozempic. Every week I take a shot. So, and then all those another oral inhibitors like SGL2 inhibitors as oral medication. So all these are contemporary treatments are very, has been very effective, and they have a distinct advantage. But how do we make them available for masses? Because the problem is so huge, so humongous. And how do we ensure that these technologies become affordable and accessible, ensuring equitable care? We got to start huge campaigns educating our patients and prospective patients, because we know there are likely to be many more patients with all those IC activities. I think we got to empower, transform, redefine diabetes, and navigate diabetes via innovating, educating, advocating, and breaking the barriers and bridging the gaps. Every patient, every step is a diabetologist's mission to empower, educate, and heal. I think together, let's work tirelessly to turn the tide against diabetes by investing in prevention, promotion, and early detection, and delivering high-quality care. We can certainly make a meaningful differences in the lives of millions affected by this disease all over, not only India, but all over. I think the motto of Leadcon, is let us lead the change. So that our patients don't get conned as far as their health is concerned. Thank you very much. I really appreciate calling me for this meeting. Thank you.
Very well said, sir. I thank all the speakers for their communion. Next is our prize distribution session for our participants who participated at the various events in the field, like paper presentation, quiz, and poster presentation. So now I request our Honorable Chief Guest, Dr. Mahesh Verma, sir, to give away the Srimati Usha Gupta Medal for the first best paper. The winner is Dr. Anamika Arun. This award is sponsored by Mr. L.C. Gupta and Dr. Ajay Kumar Gupta, sir. Anamika Arun. अच्छा मिस्टर बोला Now, congratulations. Now I request Dr. Sandeep Buddhi Raja, sir, to award Shri Jawahar Lal Agarwal Medal for the first rankers in the quiz event. This award is sponsored by Dr. Amitesh Agarwal, Co-Chairman, Scientific Committee, Leadcon 24. The winners are the team from RML, Dr. Rajat, Dr. Vipul, Dr. Ishan. नहीं I now invite Brigadier Dr. Rakesh Gupta, sir, to give away the late Shri Janardhan Sharma Medal for poster presentation to Dr. Mansi Hans. This award is being sponsored by Dr. Amit Sharma, the organizing secretary, and Srimati Shakuntala Sharma. Dr. Mansi Hans.
Anybody from her institute can come on her behalf? She's from which institute? She is from?
Ma'am, she's from which institute? Mansi.
Anyway, it can be delivered later.
For awarding Shri Dinesh Chandra Srivastava Medal for second rank among papers, I invite Dr. Gaurav Agarwal to hand over the award to Jai Patel.
Both of you do that.
Dr. Jai Patel. This award is being sponsored by Dr. Saurabh Srivastava, sir. I now request Dr. L.H. Kotekar, sir, and Dr. Anupam, sir, to give away Srimati Sunita Gupta Medal for the second rank in the quiz. The winner team for the second rank is Team Mamsi, Dr. Abhilash, Dr. Rishabh, and Dr. Arun. And this award is being sponsored by our co-chairman, Scientific Committee, Dr. Amit Gupta. Congratulations to all the winners. Now we proceed further towards the felicitation of our honored guests. First, I humbly call upon Dr. Ajay Gupta, sir, to felicitate our adulated chief guest, Dr. Mahesh Verma, sir. I now request Dr. Payal Jain and Dr. Alpana and Dr. Ashish Gupta to felicitate Brigadier Dr. Rakesh Gupta, sir. Dr. Piyush?
Dr. Vivek, huh?
Next है Shubha Kumar, Shubha ma'am, दोनों हैं.
शुभा और महेश, फिर कौन है उसके बाद?
I invite Dr. Ashok Kumar and Dr. Shubhalakshmi ma'am to felicitate Dr. Sandeep Buddhiraja sir. I request Dr. P.N. Chaudhary and Dr. Tarun Goyal and Dr. Nishesh Jain to felicitate Dr. Gaurav Agarwal. Dr. Antul Dhiman and Dr. Pooja Gupta. I don't know. I now call upon Dr. Antul Dhiman, Dr. Pooja Garg to felicitate respected Dr. Anupam sir. Now I call upon Dr. Piyush Jain, Dr. Vivek Suman, and Dr. Nishant Raizada to felicitate respected Dr. L.H. Kotikar sir. Thank you. Now I entreat our organizing secretary, Dr. Amit Kumar Sharma sir, to deliver the vote of thanks.
Thank you, Dr. Princy. And it is my pride privilege to propose the vote of thanks for this third edition of Leadcon. Myself, Dr. Amit Sharma, Professor of Medicine, Lady Hardinge Medical College, on behalf of the whole organizing committee, I extend my warm regards to our chief guest, Dr. Mahesh Verma sir, who is the Vice Chancellor of Guru Gobind Singh Indraprasth University, who has spared his time to address the gathering and highlighting the issues related to diabetes and need for adopting the multidisciplinary approach to deal with these complications. I would like to express my sense of obligation to Dr. Rakesh Gupta sir for the kind guidance for the event and accepting our invitation as the academic partner. We convey our sincere thanks to Dr. Sandeep Buddhiraja sir for his keynote lecture and gracing this occasion. I feel grateful to Dr. Gaurav Agarwal sir for accepting the invitation as an academic partner and for his constant guidance for conducting this conference, sir. I thank Dr. L.H. Kotikar sir, and who is the head of the Department of Medicine, and Dr. Anupam Prakash sir, who is the president of ISAR, for being constant pillars of support in our academic endeavors. I also extend my gratitude to faculty from the institute and from the Lady Hardinge Medical College for their spending their precious Sunday with us. Now I encourage all the speakers and residents to make this session meaningful. Thank you all the residents, students, for your staff, for their support. Hope you enjoy this time totally. Now I welcome everybody for the national anthem and then followed by the lunch. Thank you.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you, everyone. Just an announcement. The team that ranked third in the quiz competition is from UCMS. You guys will receive your e-certificates online. Now, I request everyone to proceed for the lunch. For the delegates, it's on first floor. For the faculty, it's on the ground floor.
Are we heading towards potential cure? And we have our eminent speaker, Dr. Anuj Maheshwari. I would like to invite chairpersons to the desk. Dr. Hardeep, Associate Professor, GIMS. Dr. Preeti, Assistant Professor, Greater Noida Institute of Medical Sciences. Dr. Deepak Verma, Assistant Professor, Greater Noida Institute of Medical Sciences. Dr. Sheikh Yasir Alam, Associate Professor, Medicine, Lady Harding Medical College. I would invite Dr. Saibal Chakravarti, Professor, ESI Medical College, Faridabad, to chair the session. Dr. Anuj Maheshwari, sir, is Professor in Department of Medicine at Hind Institute of Medical Sciences, Ataria, Lucknow. Sir is President-elect at Asia Pacific Society of Hypertension, Secretary General, Indian Society of Hypertension, past Vice President, RSS SDI. Sir holds multiple publications at international and national fora, and especially in diabetes, hypertension, and its complication in index journals. I would invite you, sir, for your talk.
So good afternoon, everybody. Coming to the post-lunch session in this Leadcon. Today we have a very eminent speaker, Dr. Anuj Maheshwari, whom we hear in every conference. Now today, we all know he has very tall claims. Potential cure. Potential cure is a big word. Till date, we have not been able to conquer this disease at all. Of course, we are definitely thinking in terms of potential cure. But several treatments, several therapies came in and went out. Maybe you will discuss all those and let's see what comes further.
Thank you.
Thank you very much.
It's disappeared. Anyway, I can start doing the contact setting. Thank you, Dr. Ajay Gupta, Amit, both the Amit, for giving me this opportunity here. Thank you, Team Leadcon, for facilitating my trip here. And thank you to my many of new friends who have been here in Lady Harding. So I'm really grateful of everyone. So today I shall be... क्या problem? अभी ठीक है? Today I shall be talking about the newer approaches in diabetes treatment. Are we heading towards potential cure? This is really a hot topic of the day. Many a times we see that people start talking about the reversal of diabetes. So potential cure and reversal of diabetes is not very much different from each other. Potential cure means you bring the disease up to the level when there is no need of the medicine. And when we talk about the reversal, almost the similar thing is that. Remission is little bit different, where we think that level of the disease at its minimum possible level with or without medication, or without intervention. Okay. It's not moving, bhai. यहाँ से move करेगा? Okay. अब ये move करेगा? Okay. So, diabetes is a life-threatening condition that requires vigilance and determination to manage. With the right approach, it can be tamed and controlled, allowing you to reclaim your health and vitality. The path of reversal is not very smooth, as diabetes is a chronic metabolic disorder, has long been considered a lifelong condition requiring constant management. However, recent research has unveiled the potential for diabetes reversal. This is to revolutionize the way we approach this widespread health challenge. Reversing the diabetes involves adopting lifestyle modification and, in some cases, medical interventions to restore the body's ability to regulate blood sugar level naturally, potentially eliminating the need for ongoing medication. Multiple times we discussed this thing that in last 30-40 years, a surge in the diabetes has come up. When I started my practice, India was having about 2.5 crores of the diabetes. Today we are having 11 crores of the diabetes. The prevalence has gone up in 15 to 20 years like a jet. Why did it happen? Did we change our genetic structure? Not really. Our genetic structure is the same. The only thing what has changed, our living style. The only thing has been changed that we stopped doing the physical activity. We have been a lot of lazy and we have been continuously eating. Dr. Narsimha Verma has discussed a lot about the bad effects of continuous eating even in the night. And probably this is the reason for upsurge in the diabetes. And if it can be reversed, obviously the diabetes can be reversed up to larger extent. Although, again I say many times, diabetes reversal is not of any benefit until unless we reverse the complications. So if we look for the cutting edge research in the diabetes management, 1921 was the year when the discovery of the insulin pump has been first introduced for the continuous insulin therapy. 1980, development of the recombinant DNA technology for producing human insulin has been discovered, which was one of the largest discovery which really stopped the need of sacrificing animals for the insulin use or insulin supply. 2000 was the year when we could get the approval of some novel diabetes drugs like GLP-1 agonist and DPP-4 inhibitors. 2014, FDA approval for the first artificial pancreas device for automated insulin delivery could occur, and this was the extension of the insulin pump, what has been introduced in the 1964. And 2019 was the promising results from stem cell-derived islet cell transplantation, which really gave us a hope towards the potential cure, that diabetes could be eradicated from the roots. So if we talk about the emerging research on reversing type 1 diabetes, yes, type 1 diabetes can also be reversed with the beta cell regeneration. And latest advancement is going on with the beta cell regeneration. If we talk about the type 2 diabetes, it is also based on the reversal of it on diet, surgical remission strategies, and a lot of other things are also going on, which I shall be discussing in this presentation today. So I have been told that I should not speak more than 15 minutes. That's why I have not included many things here. But there are things which can be discussed in the details for a long time. So if we talk about the digital therapeutics, what is the role in reversing diabetes? Very interesting, this digital twin program. This twin studies, which is being run across the country, and in fact, I am also the part of that. Dr. Verma is also the part of that. Few of our patients are also going on with this digital program, digital twin program. And what is that program? In this particular program, we are studying the glycemic variability, BMI, blood pressure in patients with diabetes in the digital twin precision treatment program retrospectively. And this is being done for 90 days. And after the 90 days of this program, patient achieved lowest level of the glycemic variability, which is important for the prevention of the complications. Significant reduction in BMI, that is actually needed for the reversal of diabetes and potential cure of the diabetes and blood pressure. Anti-hypertensive medications use was eliminated in nearly all patients. Future results will examine the long-term effectiveness of the sustainability of the program, because 90 days is not enough to judge any way of the therapy and any way of the living style which can claim to reverse the disease, because any time after that it may come up again. So in this study, there has been the 7 stages of the diabetes reversal for type 2 diabetes patient. And this study provided evidence that diabetes reversal progression occurs in both non-obese and obese patients and in patients with longer duration of the diabetes. So what were the stages? Stages when the patient is having just around 1 year of the duration of starting with the diabetes, no medication is required, HbA1c is still standing at less than 5.7 when we call it as non-diabetic. Stage 1 is the disease when it is little more than the 5.7. Stage 2 is around 6.4. Gradually it is increasing. Why do you may say that stage 0, what you are saying, this is a non-diabetic stage. But you must remember, when the diabetes is diagnosed, 15 years before, endothelial dysfunction starts taking place. And endothelial dysfunction is the thing which takes up towards the all vascular complication, especially the macrovascular complication, including the heart attack and stroke, and of course the hemorrhages also. So if these twin studies could reverse these responses, then definitely it could be of the great help towards a potential cure. The initial analysis of this study has prospectively designed trial reveals a remarkable improvement in the clinical and biochemical parameters that would determine the complete and prolonged remission of the diabetes. The initial results are an early indicators for the translation of the scientific rationale for the technological intervention through digital twin technology, powered by Internet of Things and artificial intelligence as a modality to enable reversal of diabetes into an achievable outcome that would be durable. The impactful glycemic control appears to have positive, meaningful metabolic health consequences. So what we could see, 35% patients achieved the intended outcome of the reversal of HbA1c, and of any anti-diabetic medication, there was a statistically significant improvement in HbA1c, fasting blood sugar, as well as HOMA2 beta and systolic blood pressure and serum albumin level. So let's see how does the artificial intelligence has played a role in reversing the diabetes, and how can it be having the future prospects of the remission for type 2 diabetes compared to standard care. Baseline mean age, diabetes duration, HbA1c obtained in 319 patients were 45-year-old, 3.9 years was the diabetes duration, and 9% around the HbA1c. And they have been kept for this intervention, and interim analysis of the 262 patients who reached 180 days showed 94.9% those who could achieve an HbA1c less than 6.5% without medication or with metformin only. 83.9% achieved the diabetes remission based on the ADA criteria. All 9 insulin-using patients stopped insulin before 90 days, and this intervention in patients with type 2 diabetes allowed for significant reduction in HbA1c, diabetes remission around 84%, and improvement in multiple metabolic parameters at 6 months. So the emergence of the novel digital technological intervention, especially the artificial intelligence, may help address those obstacles and alleviate the disease burden of the diabetes in the future. So previous studies have shown that applying AI in the diabetes management involves aspects of the disease control, whether we can predict the occurrence of the events, whether we can really prevent those after getting it predicted, how to go for the screening and diagnosis, and until ultimately for the treatment after having the prediction of the events which are yet to occur. Integrating AI into the clinical practice care could shift diabetes care towards precision, penetration, prediction, and personalization of the artificial intelligence in diabetes management, which means data quality control, poor technology design, sometimes privacy concerns are there, lack of clinical integration, non-adherence to the therapy is one of the biggest barriers, and the establishment of the law and regulation, they are coming up in the way of this remission. So newer pharmacotherapy in reversing diabetes. We have heard about the DPP-4 inhibitor, we have heard about the SGLT2 inhibitor, and tirzepatide, which has been recently introduced in the phase 3 clinical trial, which is a dual agonist of the GIP and GLP-1 receptor, enhancing the insulin secretion and reducing appetite. All these three have been discovered in the morning session by Dr. Budhiraja. So once we talk about these GLP-1 receptor agonists, they are having their bigger role in the weight loss. And actually the weight loss have been found to be the most important way which takes towards the potential cure of the diabetes. If you can really help us or help your patient in reducing the weight, out of all the measures of the lifestyle intervention, may it be diet, exercise, weight loss, dietary changes, and exercise, you can find the weight loss is the most effective measure for the reversal or potential cure for the diabetes. Does it really help us in removing the liver fat? I'm talking about the DPP-4 inhibitors, I'm talking about the GLP-1 receptor agonists, I'm talking about the SGLT2 inhibitors. It has been seen that all these medications are capable enough to wipe out the fat in liver or obese patient. Reduction of the liver fat or less than 5% occurred in 89% of the 8 milligram group and 93% of the 12 milligram group at week 48. So in nutshell, what I wish to say, if we reduce the fat, if we remove the fat from the liver, then again it is working to remove the pathophysiology which is underlying the complication. So as I already said, diabetes is not simply the hyperglycemia. Diabetes is having multifaceted heterogeneous group of the disease, and only reducing or only correction of the hyperglycemia is not doing or not giving any benefits unless we can stop all these things which are occurring together with the hyperglycemia. And insulin resistance is playing an important role in this. So I already talked about the SGLT2 inhibitors in NAFLD. SGLT2 inhibitors also plays an important role in removing the Alzheimer's disease and stroke. You must be remembering that Alzheimer's disease is considered as a type 3 diabetes. So does MRAs stop the kidney deterioration? MRAs, the finerenone, which has recently has been talked in the detail by Dr. Manoj Singhal in morning in detail. And in fact, it has also been found to be reducing the complications which has occurred with the progression of the insulin resistance in the kidney. So if you can give the finerenone, you can take back your patient, making it complication-free, and really you can avoid the forthcoming decay. How modifying the immune substance could help potential cure which may arise out of the immunotherapy? Immunotherapy involves modulating the immune system to prevent or reverse the autoimmune destruction of insulin-producing beta cells in the pancreas. This approach aims to restore proper insulin production and regulation, thereby reversing the underlying cause of diabetes. This is the complete mechanism through which we can really see how this immunotherapy can regenerate or restart the insulin secretion in the normal pattern. If we talk about the IgM immunotherapy, which restores the immune homeostasis, reverses the hyperglycemia in new onset type 1 diabetes. So it is not only possible in the type 2 diabetes, but also in the type 1 diabetes, we can see the reversal. Regenerative therapy, let's talk about that. It may be the stem cell therapy, islet cell transplantation. Islet cell transplantation is more effective in the type 1 diabetes, while the stem cell therapy have been found to be working with the type 2 diabetes also. Using stem cells to produce insulin towards the potential cure. Lot of things are coming up in the way in which we can see that thymic regulatory T cells, or Tregs for short. Stem cells in the treatment of the type 2 diabetes has also been applied. And last but not the least is the gene therapy. Already it has been discussed in the morning also. I am not putting up a lot of time on this gene genetic therapy. A lot of varieties of the genetic therapies are there. Metabolic surgery, you all know about the metabolic surgery, which is done in multiple ways. And this important thing is that diabetes remission of the bariatric surgery and non-surgical treatment in type 2 diabetes patient who failure to meet the criteria for surgery has been seen that they are getting 46% of patients with type 2 DM reach to the diabetes remission. So diabetes reversal is a reality, but again, it is important to know about the challenges towards the cure. Scientific, ethical, logistical challenges are there. Navigating challenges on the path of the reversal, which are again a big challenge, especially in a country like India. Implementing the lifestyle changes and monitoring the process is again difficult, and the most difficult thing is the compliance. More difficult thing is the opportunity for the titration, and most difficult thing to keep the patient adhered to the treatment or adhered to the whatever the you have fixed up for him for the reversal or the potential cure. Because here the patient, when you start the insulin, patient doesn't give you an opportunity for the up titration or down titration. Once it has been started, he never or very rarely comes back to you whether it is working or really not working. So few million-dollar questions comes in the mind after all this discussion. When we say the complications of the diabetes starts even before diagnosis of the type 2 diabetes, then why target HbA1c should be mostly 7? When the complications are starting above 5.7, why do we really look for the 7? Endothelial dysfunction starts taking place 15 years before the diagnosis of the diabetes. Can we really reverse it too simply by reversing the hyperglycemia? If we can get the opportunity of reversal of the diabetes, if we get an opportunity for the reversal of the hyperglycemia or without any medications, our patient is normoglycemic, can we go back to the stage of the 15 years before when endothelial dysfunction has not been started? Simply hyperglycemia remission can't reverse the complications also. The potential cure lies simply not in hyperglycemia remission without medication, but also in reversal of complications setting in pre-diabetes or even before that. Thank you very much. Your questions are welcome.
Thank you, Dr. Anuj. So where do we exactly time this stem cell therapy? At 5.7 HbA1c, or the patient has developed it for a long time?
Yes. Whenever patient gives you an opportunity. And best is that earliest is the possible, but many a times at the 5.7, you never know that this patient is having the potential to become diabetic in near future. That's why genetic therapy helps us in identifying those patients, those who are going to be diabetic in near future. And after that genetic therapy, instead of waiting for the HbA1c to go rise up, we should try to do it even 10 to 15 years before when the endothelial dysfunction start taking place.
But how can we reach out to the masses? This is very specific.
Stem cell therapy has not yet established as a method of the potential cure. Still it is in the trials. Still it is being evaluated whether it can really, or if this potential cure is achieved, whether it is going to stay for a longer time or not. The biggest question is that even if a person comes to you today with the hyperglycemia, for the first time he has experienced hyperglycemia or got to know by measuring the blood sugar in some glucometer, and you start giving the GLP-1 receptor agonist, after 1 month, patient will become normoglycemic. And even for a year or 2 years or 3 years, he may not be requiring any medication, possibly, which may be requiring for a hyperglycemia correction. But do we really can say that all those complications which have been developed in that particular patient during the progression of the insulin resistance in last 5 years, 10 years or 15 years, can they be reversed? Because our intention is not simply reducing the glucose. Our intention to make him free from the complication. And that is the most difficult task, what I understand.
We all will agree that we are moving from the stage of undernutrition to a stage of overnutrition in India, and from cycle rickshaw to electronic rickshaw. So in the coming years, we are going to see lots of diabetic patients, and anything which we have at present in our basket will not be sufficient for treatment of diabetes. And sir has given a very good insight what lies in store in future for the treatment of diabetes. And bariatric surgery is one which currently is the one which is being practiced even in our hospital also, and it has got tremendous results.
In fact, we should wait that remission or reversal or potential cure will occur. Better we should try to make the understand our next generation to keep their lifestyle
Yes.
at the same level which our ancestors were doing.
Exactly, as sir also told in the beginning, our genes are same. What has changed? It's our lifestyle. And we see even the poorest of the poor having diabetes now because of the changes in the lifestyle and MACD openings, lots of outlets in every corner of India. So we are going to see a huge burden of diabetes in the coming years.
Agreed.
A great discussion and presentation by Anuj Maheshwari sir. And I believe AI also is a upcoming measure and upcoming tool which can help all the patients and doctors as well, because as in the era of digitalization and modernization, we all are blaming the lifestyle, but the technology is something which can help us to manage the diabetes. As I think my patients are following some digital apps for monitoring the sugar levels, and we are better now to keep the records and to maintain the sugar level. So I believe we as a community must go ahead with the research in AI as with diabetes management as well. And a nice talk by sir. Thank you very much, sir.
Technology is the double-edged sword.
Yeah.
You see.
Yes.
On one hand, it is a cause of the diabetes, keeping you awake late night, may it be for some good reason or some bad reason. You are sitting on the laptop, you are working, you are making slides for this presentation. It is causing a lot of complications in your body for the generation of diabetes. On the other hand, what you are saying, that is also right.
Thank you, sir, for a nice and informative talk. I have a question. As we all know, the SGLT2 inhibitor is gaining so much popularity in recent years. So I have a question that can we use SGLT2 inhibitor as a monotherapy in diabetes?
Yes, definitely, you can use. It is your decision what your patient needs. Guidelines are only for the guidance. Guidance does not mean you will not apply your own brain. You are free to apply your own brain. If you find that your patient needs this thing for his best treatment, but you must be having the good reasons for that. Simply just for the sake of giving something, it should not be there. So if you are having a good reason and there are some justifiable reason, it's not necessary every patient should get the metformin like Hanumanji ka prasad.
Thank you, sir.
Thank you, sir, for this wonderful lecture. So I have a question, like I heard about metabolic endoscopy, like in pediatric surgery.
Metabolic?
Endoscopy.
Yes, yes, yes.
So sir, what do you say about that? Is it helpful or what's the future
Metabolic
of it?
surgery you are talking about,
Sir,
or endoscopy?
metabolic endoscopy, I heard that.
Yes, I have not gone through much about that metabolic endoscopy, whether this can really work or not, because metabolic endoscopy, if it is doing some intervention in reducing the capacity of the
Sir, they
gut,
say they were doing some duodenal resurfacing, mucosal resurfacing.
yeah, then it definitely would be working, because ultimately things are the mechanical only. This is the mechanical intervention, whether it is bariatric surgery or the endoscopic induced intervention, what you are doing just to reduce the capacity of the gut or jejunum or stomach, it's all mechanical. You are simply reducing the capacity to eat and reducing the diabetes.
Thank you, sir.
Thank you.
Thank you so much, sir, for enlightening us with multifaceted approach for diabetes. And I would request you to please gather for a photograph and for the felicitation ceremony at the presentation desk. Thank you so much. For the next session, I would like to invite Dr. Aparna Agarwal ma'am, former Director Professor, Lady Hardinge Medical College, Dr. Nitin Sinha sir, Professor at AB Wims RML Hospital, Dr. Harpreet Singh, Professor at Maulana Azad Medical College, and Dr. Pradeep Kumar, Professor at Maulana Azad Medical College. So for the next session, the topic of the talk is path-breaking innovation in diabetes therapy. And we have our eminent speaker, Mr. Pankaj, Dr. Pankaj Kumar Agarwal. सर हार्मोन केयर एवं रिसर्च सेंटर गाजियाबाद में हार्मोन रोग विशेषज्ञ हैं. सर मेडिकल कॉन्सेप्ट्स इन हिंदी में संस्थापक हैं. सर के लेखनीय में थायराइड ग्रंथि, रक्त एवं लिम्फ विज्ञान एवं MCH मैनुअल ऑफ क्लिनिकल डायबिटीज़ है. और सर ऐसे काफ़ी राष्ट्रीय 26 एवं अंतर्राष्ट्रीय शोध पत्र के लेखक हैं. आई इनवाइट यू सर फॉर योर टॉक.
I request Dr. Pankaj Agarwal to start this talk.
धन्यवाद मैडम. धन्यवाद डॉक्टर अजय गुप्ता, सभी आयोजक, मुझे ये अवसर देने का कि मैं आप लोगों के बीच में ये कैसे चलता है भाई? इससे नहीं चल रहा. ओके. ये एक मिशन है जिस पर हम लोग कार्य कर रहे हैं कि अपनी मेडिकल साइंस को सरल हिंदी भाषा में लाने का, टेक्स्ट बुक्स के, जर्नल्स के और वीडियोस के माध्यम से. और ये पुस्तकें हैं जो अभी हम लोगों ने प्रकाशित की हैं थायराइड पे, डायबिटीज़ पे, और जिसको कि एपिकॉन के नेशनल फोरम में स्थान मिला. और एपिकॉन की ही इस टेक्स्ट बुक में पहली बार हिंदी में आर्टिकल प्रकाशित हुआ. ये जर्नल है जो हम लोग निकालते हैं. और यहाँ पे जो पीजीज़ हैं और जो फैकल्टी मेंबर्स हैं, मेरा आपसे अनुरोध है कि अंडर ग्रेजुएट्स के लिए निकाला जाने वाला जर्नल है जिसमें अंडर ग्रेजुएट से रिलेटेड टॉपिक्स हम लोग हर महीने की 15 तारीख को प्रकाशित करते हैं. और यह कुछ क्लिनिकल ट्रेनिंग प्रोग्राम्स हैं जो सरल रूप में क्लिनिकल एजुकेशन किस प्रकार से होनी चाहिए, क्लिनिकल मैनेजमेंट होना चाहिए, जो हम लोग करते हैं, जिसमें अभी इंसुलिन थेरेपी पे कोर्स अगले 26 मई से आरंभ होने वाला है. मुझे कहा गया है इस स्पॉन्सर टॉपिक पे बोलने का. यह एक आयोजकों की मजबूरी है, स्पॉन्सरशिप. और जब आयोजक ये मजबूरी हमारे ऊपर बाध्यता को डाल देते हैं तो यह हमारे ऊपर ये मजबूरी हो जाती है कि हमें वही चीज़ बोलनी होती है जो हमें दी गई है. शायद ये 10% पॉपुलेशन के लिए जो हमारी फैकल्टी है उनके लिए बहुत अच्छी हो सकती है, लेकिन 90% के लिए हो सकता है कहीं ना कहीं वह उतनी सूटेबल ना हो. खैर, मैं कोशिश करूँगा क्योंकि स्लाइड्स वही हैं, फिर भी मैंने थोड़ा सा अपना छौंक लगा दिया है इसमें, जिससे कि मैं बात को बेहतर रूप से क्लियर कर सकूं. तो दो जो लेटेस्ट इंसुलिन्स हैं अभी, अल्ट्रा लॉन्ग एक्टिंग इंसुलिन्स, उनके ऊपर एक इंसुलिन अकेली और एक इंसुलिन का एक को फॉर्मुलेशन, उसके विषय में हम उसको कैसे यूज़ करें ये हम लोग अगले कुछ मिनटों में डिस्कस करेंगे. तो ये एक केस है. किसी भी चीज़ को समझने का सबसे अच्छा जो तरीका हो सकता है वो क्लिनिकल केसेस के माध्यम से हो सकता है, क्योंकि जो हमने पढ़ा उसको हमें कैसे उपयोग में लाना. अल्टीमेटली वी आर ऑल क्लिनिशियंस. तो जो इसमें मैंने हाईलाइट किए हैं जो बिंदु, वह बिंदु हमारे ट्रीटमेंट के डिसीजन में उपयोगी होते हैं. डायबिटीज़ है कब से है, ये कब से है क्यों इम्पॉर्टेंट है? क्योंकि यंग और अर्ली ऑनसेट ऑफ डायबिटीज़ में बीटा सेल फंक्शंस, जैसे अभी डॉक्टर अनुज माहेश्वरी ने कहा कि वो क्लॉक तो 15 साल पहले शुरू हो जाती है बिगड़नी, और जब हमारे पास आया डायबिटीज़ लेके तब तो 50% बिगड़ चुकी है, और उसके बाद भी वो लगातार 5 to 7% पर ईयर की रेट से वह कम होती जाती है. तो अगर हमारा पेशेंट 10 साल डायबिटीज़ पुरानी लेके आ रहा है तो लगभग उसके पास सब कुछ लुटा के होश में आए तो क्या किया वाली स्थिति होती है. तो यहाँ पे डायबिटीज़ 8 वर्ष पुरानी है, HbA1c 8.8% है. तो यदि हम 50 साल की उम्र के व्यक्ति के लिए हम एक मानक लेके चले कि हमें कितना HbA1c लाना है, तो एक हेल्दी इंडिविजुअल के लिए हमारा टारगेट 6.5 तो होना ही चाहिए. तो इसका मतलब हमारा 2.3% HbA1c ज़्यादा है. फास्टिंग और पीपी अगर हम देखें तो काफ़ी ज़्यादा है. बीपी, यह बहुत आवश्यक है समझना कि डायबिटिक पेशेंट में ग्लाइसेमिक कंट्रोल से ज़्यादा ध्यान हमें ब्लड प्रेशर कंट्रोल का रखना है, क्योंकि ब्लड प्रेशर कंट्रोल हमारा वह टारगेट ऑर्गन डैमेज पे ज़्यादा प्रभावित करता है उसको बनिस्बत की ग्लाइसेमिक कंट्रोल के. तो जो 86 है डायबिटीज़ की दृष्टि से यह भी बहुत ज़्यादा है. LDL कोलेस्ट्रॉल ज़्यादा है, डायबिटीज़ के साथ लेस देन 100 तो रखना ही रखना है. EGFR कम हो रहा है और एल्ब्यूमिन्यूरिया है। तो मल्टी फैसेटेड अप्रोच लेके अगर हम नहीं चलेंगे तो हम अपने किसी पेशेंट को अच्छा ट्रीटमेंट नहीं दे सकते। ट्रीटमेंट ले रहे हैं मेटफॉर्मिन, एम्पाग्लिफ्लोजिन और लिराग्लुटाइड। अब आप क्या समझते हैं इसमें और क्या किया जा सकता है? देखिए, जो ऑप्शंस हैं हमारे पास, हम लोग सल्फोनिलूरिया सेंट्रिक डॉक्टर्स हैं। सबसे पहले हमें पता नहीं क्यों आप पेशेंट आते ही सबसे पहली चीज़ जो समझ में आती है सल्फोनिलूरिया दे दो। तो सल्फोनिलूरियास के अपने लाभ हैं, अपने उसके लिमिटेशंस भी हैं। यहाँ पे अगर 8 साल पुरानी डायबिटीज़ है तो बीटा सेल फंक्शंस बहुत ज़्यादा नहीं बचे होंगे। सल्फोनिलूरियास का जो इस वक्त प्रभाव होगा बहुत सीमित होगा, यह हमें ध्यान रखना है। पायोग्लूटाजोन इज़ वन वंडरफुल ऑप्शन, लेकिन पायोग्लूटाजोन में हमें यह ध्यान रखना है कि आरंभ करने के बाद उसका असर आने में 1.5 महीना लगता है, तो तुरंत हमें उसका लाभ नहीं मिलेगा। और फिर हमारे पास ऑप्शन बचता है इंसुलिन थेरेपी। तो प्रश्न ये आता है कि यदि हम इसमें इंसुलिन थेरेपी, जैसा कि हमसे कहा गया आप इंसुलिन पर ही बोलेंगे, तो इंसुलिन थेरेपी पे हमारे लिए ऑप्शन क्या बचता है? इंसुलिन दें, ठीक है। एडीए कहती है कि सबसे पहले यदि किसी पेशेंट में हमें एक जनरल एक गाइडलाइन है, हम पहले ट्राई कर सकते हैं बेसल इंसुलिन को। तो बेसल इंसुलिन हमें कौन सी यूज़ करनी चाहिए, यह प्रश्न उठता है। और यह प्रश्न बहुत आवश्यक है इस चीज़ को समझना कि क्या साइंटिफिकली इस पेशेंट को बेसल इंसुलिन की आवश्यकता है। और यह चीज़ का निर्धारण जो है वह हम फास्टिंग पीपी वैल्यूज़ के हिसाब से कर सकते हैं। यहाँ पे देखिए फास्टिंग 188 है और पोस्ट प्रांडियल 218 है। हमारा फास्टिंग अगर हम 100 टारगेट लेके चलें तो 88 ज़्यादा है। और फास्टिंग ग्लूकोज को कम करने के लिए जो सबसे अच्छी विधि है वो है बेसल इंसुलिन। तो एक हमारे पास इंडिकेशन ये है कि हमें बेसल इंसुलिन की आवश्यकता है। दूसरा, यहाँ पे फास्टिंग और पोस्ट प्रांडियल में गैप कितना है? फास्टिंग 188, पीपी 218, दोनों के बीच का गैप केवल 30 है। इसका मतलब कि इस पेशेंट में पोस्ट प्रांडियल कंपोनेंट बहुत ज़्यादा नहीं है। तो हमें मेनली अगर हम फास्टिंग कंपोनेंट को इसको टारगेट करके चलते हैं एक बेसल इंसुलिन देके, तो हमारा काम इसमें हो सकता है। और यह जो बेसल इंसुलिन है यह हमें इस पेशेंट के लिए एक फ्रूटफुल थेरेपी हो सकती है। अब ये बेसल इंसुलिन हम कौन से दें? आज 2024 में हमारे पास बहुत सारे ऑप्शंस हैं, 20 साल पहले नहीं थे। 20 साल पहले हमारे पास केवल एनपीएच इंसुलिन थी और वही बेसल के रूप में उपलब्ध थी और उसकी अपनी लिमिटेशंस थी। मिडनाइट हाइपोग्लाइसीमिया, मॉर्निंग हाइपरग्लाइसीमिया, कुछ मज़ा नहीं आता था क्योंकि उसका प्रोफाइल ही कुछ इस प्रकार से रहता था। बहुत अच्छी खासी पीकिंग थी और इफेक्ट केवल 14 घंटे के आसपास रहता है। तो एनपीएच इंसुलिन इज़ नेवर अ गुड चॉइस फॉर बेसल थेरेपी। फिर आई डेटेमिर, थोड़ा और पीक कम हुई, ड्यूरेशन ऑफ एक्शन लंबा हुआ। लेवेमिर के बाद आई ग्लार्जिन, 23 आवर्स तक काम करती है, पीक और कम हुई। फिर ग्लार्जिन 300 और अब हमारे पास है डिग्लूडेग इंसुलिन। तो एडवांटेजेस क्या है? जैसे जैसे उसका ड्यूरेशन बढ़ता गया, ड्यूरेशन बढ़ने के साथ साथ उसकी जो पीक है वो कम होती गई। तो ड्यूरेशन बढ़ने से 24 आवर एक्टिंग से वह ट्रूली बेसल इंसुलिन हो गई और पीक घटने से उसका जो प्रांडियल कंपोनेंट या जो एक मिड हाइपोग्लाइसीमिया का कंपोनेंट था वह कम होता गया। तो इसलिए अगर हमको बेसल थेरेपी में हमें इनमें से सेलेक्ट करना है तो ऑब्वियसली हमारी चॉइस होगी जिस इंसुलिन का जितना लंबा ड्यूरेशन ऑफ एक्शन हो और जिसकी पीक जितनी कम हो, वह हमारे लिए एक बेहतर चॉइस होगी। तो अगर हम इसके पहले वाली जनरेशन से कंपेयर करें तो नो डाउट जितना हमारी नेक्स्ट जनरेशन इंसुलिन लाएंगी उसका प्रोफाइल उतना बेहतर होता जाएगा, हाइपोग्लाइसीमिया उससे उतना कम होगा, एफिकेसी उतनी अच्छी होगी। और बहुत आवश्यक है इस चीज़ को समझना कि जो वेरिएबिलिटी है, जितना हमारा पीकिंग और फिर पीक और ट्रफ्स ज़्यादा होंगे उतना वेरिएबिलिटी दिन में ज़्यादा होगी। अगर वो कॉन्टीन्यूअस एक प्लेट्यू लेवल पे काम कर रही है तो उसमें वेरिएबिलिटी उतनी कम होगी। तो नई इंसुलिन के साथ, लॉन्गर एक्टिंग इंसुलिन के साथ, डिग्लूडेग के साथ ये वेरिएबिलिटी के बहुत एडवांटेजेस हैं। अगर आप ये देखें तो ग्लार्जिन 300 की भी तुलना में डिग्लूडेग का वेरिएबिलिटी कितनी कम है। तो इस प्रकार से बेसल इंसुलिन के रूप में डिग्लूडेग का चयन हम कह सकते हैं कि आदर्श है लगभग, क्योंकि फ्लैट ड्यूरेशन है, मोर देन 24 आवर एक्शन है और पीकिंग असर उसका कम है। आइए दूसरे केस को डिस्कस करते हैं। यहाँ पे 53 ईयर ओल्ड मेल और 11 वर्षों से डायबिटीज़ है। अच्छा, इस बात पे मैं बहुत ज़्यादा फोकस देता हूँ जो पता नहीं क्यों ना हमको भी कभी इस तरह से नहीं बताई गई और ना हम इसको यूजुअली इतना ज़्यादा डिस्कस होते देखते हैं। ड्यूरेशन ऑफ डायबिटीज़ टाइप 2 डायबिटीज़ में बहुत बहुत आवश्यक है जानना, समझना और उसको यूज़ करना। हमारे डायग्नोसिस में टाइप 2 डायबिटीज़ फॉर दीज मैनी ईयर्स ये ज़रूर लिखा होना चाहिए, क्योंकि हमारी पैंक्रियास में जो इंसुलिन है इट्स जस्ट लाइक पेट्रोलियम, हर दिन कम हो रहा है, तो रिजर्व सीमित है। उस रिजर्व के आधार पे 11 साल हो गए, 5 to 7% पर ईयर अगर डिके हो रहा है बीटा सेल का, तो 50% पहले जा चुकी थी डायग्नोसिस पे, बचे हुए 50% में 5% पर ईयर के हिसाब से भी गई तो 10 साल में साफ। तो मोर देन 10 years ऑफ डायबिटीज, लाइकलीहुड ऑफ एंडोजेनस इंसुलिन रिजर्व इज वेरी लिटिल। तो ऐसे में हम कहें कि हम इंसुलिन सिक्रीटोकॉक्स से कुछ लाभ ले लेंगे तो शायद बहुत लाभ नहीं होगा। 11 वर्ष पुरानी डायबिटीज़ में हमें कुछ और तरीकों पे, सेंसिटाइजर्स पे ज़्यादा जाना होगा। HbA1c 9.2%, 53 की एज पे हम चाहेंगे 6.5% रहे, तो ये और भी अधिक है जो कि आसानी से नहीं मानेगा। फास्टिंग ग्लूकोज लेवल 206 और PP 288 काफ़ी ज़्यादा हैं, LDL भी ज़्यादा है। और इस प्रकार से अगर हम देखें जो हमारी करंट थेरेपीज़ है मेटफॉर्मिन, सल्फोनिल यूरियाज और SGLT2 इनहिबिटर्स ग्रुप में, हमारे पास ऑप्शंस क्या बचे इसमें करने के लिए? हमारे पास ऑप्शंस हैं, अगर हम कहते हैं DPP4 इनहिबिटर या GLP1 एनालॉग्स देंगे, तो जब भी हम एक नई मेडिसिन जोड़ रहे हैं तो हमें यह अवश्य ध्यान होना चाहिए कि उसकी पोटेंसी, उसकी कैपेसिटी कितनी है। DPP4 इनहिबिटर्स लेस देन 1% HbA1c घटाते हैं, हमें यहाँ पे 2.7% घटाना है। क्या वो काम होगा? उससे नहीं हो पाएगा। GLP1 एनालॉग पे जाते हैं तो वो मोर देन 1%, 1 to 1.5% घटा सकते हैं, उससे काम नहीं हो पाएगा। फिर पायग्लूटाजोन बहुत अच्छी दवा है, थोड़ा बदनाम हो गई है लेकिन दवा बहुत अच्छी है, जहाँ पे हम उसको ठीक प्रकार से अगर उसको प्रयोग में लाते हैं। अब लेकिन पायग्लूटाजोन को काम करने में 1.5 महीना लगता है, तो हमें उसके लिए वेट करना पड़ता है। घूम फिर के हम कहाँ आ गए? इंसुलिन थेरेपी, और यही भाई लोगों ने हमसे कहा भी है बोलने को। तो अब यहाँ पे इस पेशेंट के लिए यदि हमें इंसुलिन का चयन करना हो तो हम क्या करेंगे? फिर हम अपने उसी फंडे पे आते हैं। इसका पॉइंटर नहीं चल रहा है और ये माउस भी बड़ा हल्का दिख रहा है, तो हैं अच्छा ओके ठीक है, दो हथियार हाथ में, राइट। तो अब फास्टिंग हमारा 206 है और PP 288 है। तो यहाँ पे अगर हम देखें फास्टिंग के बेसिस पे 100 हमारे टारगेट लेवल से 100 से ज़्यादा बढ़ा हुआ है, तो बेजल इंसुलिन की आवश्यकता है, ठीक है। लेकिन पोस्ट प्रैंडियल एक्सकर्शन वह भी हमारे 82 है, काफ़ी ज़्यादा है। तो यदि हम फास्टिंग को 100 कम कर लेंगे, 206 से 106 ले आएंगे, तो यह भी 100 कम होके 288 से 188 तो हो जाएगा। हमारा टारगेट 140, 150, 160 नहीं आता। तो ऐसे केसेस में जहाँ पे हम फास्टिंग कंट्रोल कर पा रहे हो, पोस्ट प्रैंडियल अभी भी बचा रहेगा, तो हमने काम आधा किया। तो क्यों ना हम लोग कुछ ऐसा काम करें जो कि हमें उसके आगे मदद करे। तो इसका मतलब हम यहाँ पे बेजल के साथ कुछ पोस्ट प्रैंडियल हाइपरग्लाइसीमिया को कंट्रोल करने वाला कुछ प्रैंडियल कंपोनेंट भी जोड़ें। तो एक हमारे पास ऑप्शन यहाँ पे रहता है कि यदि हम डिग्लूडेक के साथ एक अल्ट्रा शॉर्ट एक्टिंग रैपिड एक्टिंग इंसुलिन जोड़ दें तो वह काम करता है, और यह दोनों का एक को फॉर्मुलेशन अवेलेबल है इन द फॉर्म ऑफ आइडेक ASP। और यहाँ पे जब हम फास्टिंग और PP दोनों को टारगेट करते हैं तो स्वाभाविक रूप से उसमें हमें लाभ ज़्यादा मिलेगा, इफेक्टिव ज़्यादा होगा और उससे पेशेंट का बेनिफिट ज़्यादा होगा। अब कहा गया कि यदि हम इस पेशेंट को केवल बेजल इंसुलिन दें और बेजल प्लस बोलस दोनों दें तो क्या अच्छा होगा? तो ये तो आम और अमरूद को आपस में कंपेयर करने वाली बात है, जो करना नहीं चाहिए। हम एक इंसुलिन दे रहे हैं जहाँ पे दोनों कंपोनेंट हैं, बाकी इंसुलिन हैं जिसमें एक ही कंपोनेंट है। स्वाभाविक है इन दोनों का प्रभाव कम होगा, इसका प्रभाव ज़्यादा होगा, तो इसलिए यह तो बहुत वैलिड नहीं है। लेकिन अगर हम इसमें देते हैं केवल बेजल इंसुलिन तो उसका प्रभाव कम होगा और हमारे कॉम्बिनेशन का प्रभाव ज़्यादा होगा। यह अगर हम स्विच करते हैं तो ऑब्वियसली बेजल इंसुलिन से बेजल प्लस बोलस पे स्विच करेंगे तो वह भी हमें एडवांटेज ज़्यादा मिलेगा और पेशेंट का सेटिस्फेक्शन रेट ज़्यादा होगा। तो इस प्रकार से अब कहा जाए कि इसके बाद हमें कुछ पेशेंट्स ऐसे हैं जहाँ पे केवल बेजल इंसुलिन देनी है जो फास्टिंग हाइपरग्लाइसीमिया के साथ आए, और कुछ पेशेंट्स ऐसे हैं जहाँ पे बेजल के साथ बोलस कंपोनेंट भी देना है यदि पोस्ट प्रैंडियल ग्लाइसेमिक एक्सकर्शंस ज़्यादा हैं। इसको कब दें और कैसे दें, ये बहुत आवश्यक क्वेश्चन है। आज सुबह भी एक सेशन था जिसमें यही डिस्कशन हो रहा था, तो मैंने बड़ा कंट्राडिक्टरी रिमार्क्स वहाँ पे रखे अपने प्रेजेंटेशन में कि टाइप 1 और ये बेजल इंसुलिन के लिए हम लोगों ने एक रूल बना लिया है, इट शुड बी गिवन एट बेड टाइम। वाई ऑलवेज? जब एनपीएस थी मजबूरी थी, एनपीएस थी हमारा फास्टिंग हाइपरग्लाइसीमिया कंट्रोल करने के लिए हमें इसको बेड टाइम देना था, बिफोर डिनर देने पे मिडनाइट हाइपोग्लाइसीमिया ज़्यादा होता है, तो इसलिए हम बेड टाइम देते हैं जिससे उसकी पीक थोड़ा शिफ्ट हो जाए, थोड़ा जो उसकी पीक सुबह 4-5 बजे हो जब कोर्टिसोल सर्ज हो रही है, उस वक्त वो इस इंसुलिन से हाइपोग्लाइसीमिया हो रहा है, कोर्टिसोल सर्ज से हाइपरग्लाइसीमिया हो रहा है, और दोनों मिलके मिडनाइट हाइपोग्लाइसीमिया की संभावना को घटा दें। लेकिन जब एनपीएच के बाद डेटेमिर आ गई, जब उसके बाद ग्लार्जीन आ गई, ग्लार्जीन 300 डिग्लूडेग आ गई, तो हमारे पास वो बाध्यता नहीं रही। अब हम इस इंसुलिन को किसी भी समय प्रयोग में ला सकते हैं, और डिग्लूडेग जैसे इंसुलिन को तो हम सुबह दोपहर शाम रात कभी भी दें तब ठीक है। प्रश्न उठता है डिग्लूडेग के साथ जब हमने एस्पार्ट जोड़ दिया है तो हम उसको प्रयोग में कैसे लाएं? डिग्लूडेग को हम इंसुलिन ग्लार्जिन को भी कभी भी दे सकते हैं, डिग्लूडेग को भी कभी भी दे सकते हैं, लेकिन जब एस्पार्ट जोड़ दी तब दो तरीके हैं। एक तो जो मील सबसे हैवी है, कार्बोहाइड्रेट कंटेंट सबसे ज़्यादा है, उसके पहले जोड़ें, और दूसरा जब आवश्यकता है, जिस वक्त की मील के बाद पोस्ट प्रैंडियल ग्लाइसेमिक एक्सकर्शन सबसे ज़्यादा है, उस वक्त दें। हम लोग में से बहुत सारे लोग ऐसे हैं जो नाश्ता बहुत हल्का लेते हैं, लंच उससे ज़्यादा लेते हैं, और डिनर सारे काम निपटा के रात में लौट के तब भी ऐसे खाते हैं, थोड़ा डिज़र्ट भी खा लेते हैं। तो अगर हमारे डिनर हैवी है, उसमें पोस्ट प्रैंडियल एक्सकर्शन मैक्सिमम है, तो हम इस इंजेक्शन को डिनर के पहले लें। यदि लंच हैवी है, लंच का पोस्ट प्रैंडियल एक्सकर्शन ज़्यादा है तो उसके पहले लें, और ब्रेकफास्ट अगर है तो ब्रेकफास्ट के पहले। तो इस प्रकार से जो मील के बाद पोस्ट प्रैंडियल एक्सकर्शन ज़्यादा है, जिसका कार्बोहाइड्रेट कंटेंट ज़्यादा है, जो हैवी है, उसके पहले हम इस इंसुलिन को दे सकते हैं। रिकमेंडेशंस में कई बार कुछ बातें आती हैं, 0.1 यूनिट पर केजी, 0.2 यूनिट पर केजी, 0.3 यूनिट पर केजी, कृपया इस पर मत जाएं। यह सजेशन है, गाइडलाइन है। हम लोगों में विशेष रूप से जिस पेशेंट को आप डोमिसिलरी बेसिस पे इंसुलिन शुरू कर रहे हैं, उसमें कृपया ऐसा ना करें। 10 यूनिट इंसुलिन बहुत हो जाती कुछ पेशेंट्स के लिए। तो अगर हम डोमिसिलरी बेसिस पे शुरू कर रहे हैं तो मैं सजेस्ट करूंगा 2-3-4 दिनों में कुछ नहीं जाता है, एक बार हम थोड़ी कम डोज 6 यूनिट दे के देख लें एक 60 kg के इंडिविजुअल में, जो कि 0.1 यूनिट पर केजी बनती है। उसके बाद अगर हमें आवश्यकता होती है तो बेजल इंसुलिन को हमें फास्टिंग हाइपरग्लाइसीमिया से कंट्रोल करना है, तो जैसे जैसे फास्टिंग को हम कंट्रोल लाते जाएंगे, जब तक फास्टिंग 120 प्लस रहे तब तक 1 और 2 यूनिट से उसको हम इंक्रीज कर सकते हैं। तो इस प्रकार से अधिकांश केसेस में तो हम एक बार ये इंसुलिन दे के काम चला सकते हैं, लेकिन कुछ केसेस में जब 2 मील्स के बाद पोस्ट प्रैंडियल एक्सकर्शंस ज़्यादा हों तो हमें इसको 2 मील्स के पहले, जिनके बाद भी एक्सकर्शंस हमारे ज़्यादा होंगे, उनके पहले दिया जा सकता है। तो 2 प्रिंसिपल्स हुए, मील्स के अकॉर्डिंगली, कार्बोहाइड्रेट कंटेंट के अकॉर्डिंगली, या पोस्ट प्रैंडियल एक्सकर्शंस के अकॉर्डिंगली। इस प्रकार से हम आइडेक एएसपी को मेजर मील्स के पहले या पोस्ट प्रैंडियल एक्सकर्शन के अनुसार 1 बार, 2 बार या 3 बार, जिसको कि MSI कह सकते हैं, उस तरह से प्रयोग में ला सकते हैं। तो मित्रों, इस प्रकार से मैं अंत में अगर कहूँ कि डायबिटीज़ एक हेटेरोजेनस डिसऑर्डर है, एक स्पेक्ट्रम है, हर व्यक्ति अलग है, हर व्यक्ति का प्रोफाइल अलग है, तो हमें उसके लिए एक बुटीक खोलना होगा, टेलर मेड थेरेपी, वन साइज डजंट फिट ऑल। तो उसके लिए अकॉर्डिंगली कि कहाँ हमें किस प्रकार से एडजस्ट करना है, प्रैंडियल कंपोनेंट किस प्रकार से बेजल कंपोनेंट, उसके अनुसार हमें उसके लिए एक डिफरेंट इंसुलिन रेजिमेंट डिज़ाइन करना होगा, तब भी हम उस पेशेंट को प्रभावशाली रूप से कंट्रोल कर पाएंगे। और इस इंसुलिन, वैसे तो सभी इंसुलिन्स, हम किसी भी इंसुलिन के साथ एक फ़ायदा है, इंसुलिन हैज़ गॉट नो साइड इफेक्ट अदर देन हाइपोग्लाइसीमिया। तो हम उसको कभी भी किसी भी केस में दे सकते हैं, कार्डियोपैथी, न्यूरोपैथी, नेफ्रोपैथी, हेपेटोपैथी, कहीं पे भी हम इंसुलिन को यूज़ कर सकते हैं। वही हमारी इन इंसुलिन के साथ भी है। जहाँ पे केवल बेजल राइज हो, इंसुलिन डिग्लूडेग, जहाँ बेजल के साथ साथ थोड़ा प्रैंडियल राइज भी हो, वहाँ पे आईडेग ESP, और यह हमारे अधिकांश पेशेंट्स को एक कम से कम हाइपोग्लाइसीमिया के रिस्क के साथ काफ़ी सेफ्टी और एफिकेसी दोनों का कॉम्बिनेशन दे सकती हैं। धन्यवाद। आप लोगों को हिंदी, अब हमारे डॉक्टर नरसिंह वर्मा बैठे हैं, ये हिंदी के विद्वान हैं और इनकी छत्रछाया में हम लोगों ने बहुत हिंदी पे काम किया है। तो यह हमारा मिशन, जिसके अंतर्गत हम लोग कुछ एक्टिविटीज़ भी करते हैं। यदि आप लोगों को अच्छा लगा हो, अच्छा उपयुक्त लगा हो, बहुत सारे लोग डरते हैं कि मेडिकल साइंस में हिंदी घुसा के हमें कमेंट्स क्या मिलते हैं, क्वैक बना दोगे। तो क्या मैंने आपको क्वैक बनाने में सहायता की, ये सोचिएगा। धन्यवाद।
बहुत अच्छी थी और बेस्ट पार्ट था कि रीजंस फॉर सिलेक्शन, क्या चीज़ क्यों देंगे, किस लिए देंगे और क्यों नहीं देंगे, तो दैट वाज द बेस्ट पार्ट। तो रेजिडेंट्स के लिए इट वाज रियली रियली गुड।
धन्यवाद।
और आपने आउट ऑफ द बॉक्स प्रेजेंटेशन की, जो अपनी उसमें मेरे ख्याल से ज़्यादा चीज़ें डाली हैं rather than this।
धन्यवाद।
Thank you very much, sir, for the wonderful session. We have learnt a lot of things, sir. Sir, I have a question. If the patient is on an oral hypoglycemic agent, what is the best time to switch over to this regime? Is there anything apart from the duration? What is the best time to switch over to this regime?
जब आवश्यकता हो, यह आवश्यकता एट द टाइम ऑफ डायग्नोसिस ऑफ डायबिटीज़ भी हो सकती है, कुछ कारणों से, इन्फेक्शन के, प्रेगनेंसी के, स्ट्रेस से, सर्जरी से।
That is what I want to know. What are the indications to shift to that regime?
फिर वही बात आ गई, दो तरह के इंसुलिन थेरेपी के दो रूप हैं, एक टेम्परेरी ट्रांजिएंट इंसुलिन सप्लीमेंटेशन और दूसरा ग्रेजुअली एंड परमानेंट इंसुलिन सप्लीमेंटेशन। तो कुछ स्ट्रेसफुल कंडीशंस में, कॉम्प्लिकेशंस में, सर्जरी में, इसमें हमें टेम्परेरी इंसुलिन देनी पड़ती है। इवन प्रेगनेंसी में हमें टेम्परेरी इंसुलिन थेरेपी देनी पड़ती है और जैसे ही वो फेज समाप्त हुई, हम उसके बाद फिर अधिकांश केसेस में ओरल पे रिवर्ट बैक कर सकते हैं। दूसरी हुई कि हमारी इंसुलिन सिक्रीटिंग कैपेसिटी इतनी कम हो गई कि वो अब ग्लाइसेमिक कंट्रोल को पर्याप्त रूप से नियंत्रण में नहीं रख पा रही है। जब वो नहीं रख पा रही है तो हमें इंसुलिन पे जाना है। यह अब फिर वही वाली बात आ गई कि 5% पर ईयर और 7% पर ईयर, ये फॉर्मूला कहाँ से आया? कुछ पेशेंट्स होते हैं जिन्हें 70 साल पे डायबिटीज़ होती है, कुछ पेशेंट्स होते हैं जिन्हें 25 साल पे डायबिटीज़ होती है। इसमें डिजीज़ का टेम्पो किस में हाई है? ऑब्वियसली जिसमें 25 साल वाले पे। तो जिसको जितने यंग ऑनसेट ऑफ डायबिटीज़ होगी, डिजीज़ टेम्पो उतना हाई होगा, वो उतनी जल्दी इंसुलिन पे आएगा, उसको कॉम्प्लिकेशंस उतनी जल्दी होंगे। तो इसलिए हमें हर पेशेंट को एक अलग रूप से देखना है और यह ध्यान रखना है कि यदि कम उम्र पे डायबिटीज़ हुई है तो वो हल्के में ना लें, जबकि वही लोग सबसे ज़्यादा हल्के में लेते हैं। और उसमें हमें भी एग्रेसिव होना है और हमें भी ये देखना है कि कॉम्प्लिकेशंस भी जल्दी होंगे और शायद इंसुलिन की आवश्यकता भी जल्दी पड़ेगी। सर, किस चीज़ का? अच्छा, ओके, कुछ ग्लाइसिन प्लस लेक्सिस्टिन, बहुत बढ़िया। यह कॉम्बिनेशन बहुत ही अच्छा रहेगा क्योंकि GLP-1 एनालॉग देख के, GLP-1 एनालॉग से हमें लाभ ये है कि एक एडिशनल हमें ग्लाइसेमिक कंट्रोल उसमें मिल जाता है पोस्ट प्रैंडियल के रूप में, और जो हमारी डिग्लूडेक है उसमें हमें बेजल मिल गया। तो हम बेजल प्लस बोलस में, या तो हम बेजल प्लस बोलस इंसुलिन पे जाएं या बेसल प्लस GLP-1 एनालॉग पे जाएं। तो यदि एंडोजेनस इंसुलिन रिजर्व पेशेंट का बाकी है, जो इस स्टेज में अधिकांश लोगों में होता है, और पेशेंट सुटेबल है कि उसका ओवरवेट है और हमें यह भी चाहिए कि थोड़ा सा वेट घटाने में भी हेल्प कर सके, यदि उसके साथ एसोसिएटेड कुछ नेफ्रोपैथी जिसमें कि ये और एडवांटेजेस हो सकता है, और कार्डियोपैथी जिसमें और एडवांटेजेस हो सकता है, तो वहाँ पे हम प्रेफर करेंगे कि हम बेजल बोलस इंसुलिन देने की जगह बेजल प्लस GLP-1 एनालॉग दें। तो वह हमारे उस केस में एक तीर से दो शिकार वाला कार्य होगा।
inferiority in cardiovascular outcomes. It just said that it's non-inferior. तो जब हम GLP-1 चुनते हैं, when we select GLP-1, तो leader trial को ज़्यादा पकड़ के, liraglutide is a better option. I just wanted to know whether liraglutide के साथ कोई combination अभी तक available है internationally?
ये जितने भी लिराग्लुटाइड, लिक्सिसनेटाइड, हमने 10 साल पहले इनके ऊपर शॉर्ट टर्म और लॉन्ग टर्म क्लिनिकल ट्रायल्स मैंने पर्सनली अपने सेंटर पे किए हैं, और इसमें लिक्सिसनेटाइड मैंने जितने भी GLP-1 एनालॉग्स यूज में, लिक्सिसनेटाइड वाज अ वंडरफुल ड्रग, वंडरफुल ड्रग। हाँ, देखिए अब क्या बात है, एक ड्रग अच्छी, एक उसकी मार्केटिंग, और मार्केटिंग के बाद उसका एप्लीकेशन। ठीक है, वो कंपनी टू कंपनी वेरी करता है, कोई कंपनी एग्रेसिव है। लिराग्लुटाइड वाज द फर्स्ट वन टू ब्रिंग इट, तो उस वक्त तो हाइप थी, और लिराग्लुटाइड के ऊपर लिटरेचर सबसे ज्यादा था। लिक्सिसनेटाइड उसके 4 साल बाद आई, उसको उतना ज्यादा आवश्यकता नहीं थी।
क्योंकि आप जब भी कार्डियोलॉजिस्ट फोरम में बैठो तो दे से दैट वी वुड प्रेफर टू यूज लिराग्लुटाइड रादर देन लिक्सिसनेटाइड।
जी ठीक है, क्योंकि लेकिन टेक्निकली दोनों में से कोई अंतर नहीं होगा, लेकिन ये तो है ही, एविडेंस बेस्ड मेडिसिन के नाम पे हम जब भी कहते हैं किसी चीज का हमारे पास एविडेंस ज्यादा है तो हम उसको प्राथमिकता देते हैं।
जस्ट अ कमेंट, थैंक यू, थैंक्स डॉक्टर।
थैंक यू। इजाजत? ओके, धन्यवाद।
थैंक यू सर, आपने डायबिटिक ट्रीटमेंट एल्गोरिदम का बहुत ही डिटेल रूप में विश्लेषण किया और प्रस्तुत किया।
हिंदी में बोलने के लिए धन्यवाद।
थैंक यू सर। Thank you, chairpersons. For the next talk, I would like to invite Dr. Vandana Garg, ma'am, Senior Consultant, Medicine, Max Vaishali Hospital, Noida. Dr. Vivek Suman, sir, Professor, Medicine, Lady Hardinge Medical College. Dr. Sushil Tyagi, sir, Senior Consultant, Internal Medicine, Avantika Hospital, Indirapuram. Dr. Payal Jain, ma'am, Senior Consultant at Greater Noida Institute of Medical Sciences. Dr. Shelly Datta, Assistant Professor at AB Wims RML Hospital. And the topic for the next talk is Understanding Diabetes, a Comprehensive View Beyond Sugar Control. And we have our prestigious faculty, Dr. Pooja Garg, ma'am, who is Consultant Physician at Max Hospital, Vaishali, teaching faculty at a medical college, Scope certified for management of obesity, and she holds many publications in national journals. I invite you, ma'am, for the talk.
Thank you for the kind introduction. Good afternoon, everyone. I welcome you all for today's afternoon session on understanding diabetes, a comprehensive view just beyond glycemic control. So we shall be seeing the other cardiometabolic aspects or other aspects of control of diabetes. As we all know, there is more to chronic cardiometabolic diseases. Chronic cardiometabolic diseases generally do not occur in isolation. They hold hand in hand, and like diabetes, obesity, and cardiovascular disease, they share the same underlying risk factors and increase multimorbidity over the period of time, leading to severe outcomes such as heart attack and stroke. So management of patients who are having cardiometabolic diseases require all in all a holistic, multifactorial, and person-centric approach as suggested by the treatment guidelines. As we can see here in this picture, the diabetes, cardiovascular disease, and obesity together, they increase the risk of myocardial infarction, peripheral arterial disease, chronic kidney disease, non-steatotic, NASH, heart failure with preserved ejection fraction, and a risk of stroke. So all these risk factors increase when diabetes, CVD, and obesity are prevailing together. The effect of type 2 diabetes are far-reaching. They practically affect every organ of the body. Like we can see in the first picture, the diabetes predisposes a patient to brain stroke, cerebrovascular disease, diabetic retinopathy, the risk of cataract and glaucoma also increase, the risk of periodontal diseases, the risk of diabetic neuropathy, cardiovascular diseases, diabetic nephropathy, peripheral vascular disease, and foot damage. All together are the complications of diabetes which practically reach every organ of the body. Similar are the effects of GLP-1 receptor agonists, which provide protection at every aspect of the human body, at every organ. So looking at the effect of GLP-1 receptor agonists at the level of kidneys, they increase natriuresis, diuresis, and reduces the albuminuria, and therefore addresses diabetic nephropathy. And at the level of blood vessels, it reduces blood pressure and also brings down the atherosclerosis. At the level of brain, it reduces body weight by reducing the appetite and provides increased neuroprotection and aversive responsiveness. At the level of heart, it increases the heart rate and helps in cardioprotection. At the level of platelets, it also works at the level of GI system by reducing postprandial lipids and reducing the gastric emptying time by the incretin effect, reduces the glucose and hypoglycemia. At the level of alpha cells, it reduces the secretion of glucagon and increases the insulin secretion from the beta cells. Now, looking at the potential effects or benefits of oral semaglutide across the entire organ system, not only oral semaglutide helps in glycemic aspect of type 2 diabetes, but also provides protection of all these aspects, which I shall be talking in detail. So looking at the comparative glycemic efficacy, talking about the reduction of HbA1c with the usage of semaglutide, oral or subcutaneous form, comparison of this with the standard type 2 diabetes therapies, looking at the Pioneer and Sustain phase 3 programs, right from Sustain 1, which we all know in detail. So looking at the background of patients who were included in Sustain 1, they were treatment-naive patients and the study duration was almost 30 weeks. And the baseline HbA1c somewhere was 8.1%. One semaglutide was given in an injectable dose of 0.5 milligram versus 1 milligram versus the placebo. We can see the effect of the semaglutide in a dose of 1 milligram when given subcutaneously. The HbA1c reduction of almost 1.6% was seen versus 1.5% with semaglutide of 0.5 versus the placebo. In Sustain 2 versus the sitagliptin, we can see on a background of the patient being already on metformin plus minus thiazolidine diones, the study duration was almost 56 weeks. The baseline HbA1c reduced in Sustain 2. The semaglutide led to a reduction of almost 1.6% HbA1c from the baseline when semaglutide was administered in a dose of 1 milligram subcutaneously versus 0.5% with sitagliptin. In Sustain 3, again, when this was conducted versus exenatide, where semaglutide was given injectable subcutaneous versus the exenatide, we can see HbA1c reduction was superior with the usage of oral semaglutide versus the exenatide, which was when administered on a background where patient was already on metformin or a combination of metformin and sulfonylureas or any other therapy. Here, the study duration was almost 56 weeks. In Sustain 4 also, semaglutide was found to be superior versus the basal insulin, where the patient was already on metformin plus minus sulfonylureas, and over a study duration of 30 weeks, where the baseline HbA1c was somewhere around 8.2%, semaglutide was able to bring the glycemic effect or efficacy of bringing down the HbA1c by almost 1.6% in a dosage of 1 milligram subcutaneously versus the HbA1c reduction by almost 0.8% with the usage of basal insulin. In Sustain 5, where the semaglutide was compared to placebo as an add-on to already undergoing ongoing insulin therapy plus minus metformin, the study duration being 30 weeks. Here the HbA1c effect or efficacy that was seen was HbA1c came down by 1.8% with semaglutide in a dose of 1 milligram, while it came down by 1.4% with semaglutide of 0.5. Sustain 7 was conducted versus dulaglutide, and Sustain 6 was done versus placebo. Similar trials were seen demonstrating or highlighting the glycemic efficacy of semaglutide was also seen in Pioneer trials. These Pioneer phase 3 programs was again, Pioneer 1 was conducted in early, most of the patients included here were early diabetics, and patients were randomized on a background of diet and exercise. They were randomized to a dose of semaglutide oral in 3, 7, and 14 versus placebo. Here, clearly in Pioneer 1, we can see in terms of HbA1c reduction, the efficacy of semaglutide in a dose of 14 mg was clearly superior versus the placebo. In Pioneer 2, where the trial was conducted versus the empagliflozin, the HbA1c reduction with semaglutide of 14 was somewhere around 1.3 versus 0.9% with EMPA of 25. Similarly, in Pioneer 3, where this trial was conducted with a semaglutide of 3, 7, and 14 being administered versus sitagliptin of 100, again, semaglutide was found to be superior in a dosage of 14 mg by bringing down the baseline HbA1c by 1.3%. In Pioneer 4, which was conducted versus liraglutide and placebo, again, the HbA1c reduction with SEMA was found to be almost 1.2%. And Pioneer 8 and Pioneer 8 was conducted as an add-on to insulin. Pioneer 5 was conducted in patients who had renal impairment. And across that, Pioneer 6 in patients who had underlying CVD or CKD. Again, across all the Pioneer trials, the efficacy of semaglutide in a dosage of 14 mg could be clearly demonstrated. Now, looking at the efficacy or the percentage of patients who could achieve their target HbA1c goals with the usage of oral semaglutide, we can see in the first picture the proportion of patients who could reach their target HbA1c with the usage of oral semaglutide in 14 mg dose. The almost 80% patients could reach their target HbA1c. In Pioneer 8 also, the maximum patients, almost 60 to 70% patients could reach their target HbA1c with semaglutide of 14. Similarly, in Pioneer 2, with the usage of SEMA versus EMPA, more patients could reach their target HbA1c. So we have now seen across all sustained trials and Pioneer studies that the glycemic efficacy of oral semaglutide is wonderful. Looking at the Pioneer Plus trial, the glycemic efficacy and proportion achieving the HbA1c less than 7%. Here, the patients who were included were diabetics who were uncontrolled, adult patients having HbA1c between 8 to 10.5%, and BMI being more than 25, and patients who were on a stable dose of 1 to 3 oral anti-diabetic drugs. They were randomized to 1:1:1:1 in a dosage of semaglutide. And dose was escalated at every 8 weeks. And in 3 different groups, the dose was escalated up to 50 milligrams, 25 milligrams, and 14 milligrams. Clearly in the picture, we can see in terms of glycemic efficacy, the change from baseline HbA1c. With a semaglutide of 50 milligrams, the HbA1c came down by 2% from the baseline HbA1c. While with semaglutide of 25 and 14, the HbA1c results efficacy was good, but HbA1c came down maximum with a dosage of 50 milligrams daily. But still, oral semaglutide in a dose of 25 and 50 milligrams has not yet been approved for the management of diabetes or obesity. Now, looking at the potential benefits of oral semaglutide across the other organ systems, looking at the usage of the same in patients who have underlying atherosclerotic cardiovascular disease or heart failure with preserved ejection fraction, the CV outcome trial SUSTAIN 6, where subcutaneous semaglutide was given, and Pioneer 6, where oral semaglutide was given. This is an analysis. Inclusion criteria here was age more than 50 years of patients who had underlying cardiovascular disease or CKD. An endpoint here was to check for the first occurrence of MACE, which was defined as CV death or non-fatal MI or non-fatal stroke. The differences in the 2 trials we can clearly see. SUSTAIN 6, here semaglutide was administered in a dose of 0.5 or 1 subcutaneously, along with the standard of care, versus the placebo, where treatment duration was around 104 weeks, and patients included were almost 3,300 patients, while in Pioneer 6, 14 mg oral semaglutide was given along with standard of care versus the placebo. The Pioneer 6 was a shorter trial duration because of the smaller number of events, and here the median follow-up was 2.1 years in SUSTAIN 6 and 1.3 years in Pioneer 6. So pooled analysis of these two, we can see the results were in favor of semaglutide. Combined, they showed that semaglutide showed consistent effects with 24% significant reduction in MACE versus comparators across the varying CV risk. Looking at the pooled analysis of SUSTAIN 6 and PIONEER 6, there was a hazard ratio, the relative risk reduction by 32% with the usage of semaglutide versus the placebo. That there was a significant reduction of risk of stroke by almost 32%. The ongoing SOUL CV outcome trial will further inform about CV outcomes with the oral semaglutide. Looking at the benefit of semaglutide in terms of the patients with heart failure or preserved ejection fraction and obesity. Looking at the Kansas City cardiomyopathy questionnaire, this score has shown the benefit with semaglutide versus the placebo. And along with changes of body weight with semaglutide versus the placebo in the second picture. And the pictures on the right have shown us how semaglutide has shown to be beneficial in terms of primary cardiovascular composite endpoints and death from cardiovascular causes. Clearly, in these aspects, semaglutide has shown much better results versus the placebo. Similar results were also seen in heart failure composite and death from any cause. Semaglutide was seen to be superior versus the placebo. Now, looking at the benefit of oral semaglutide in patients who have underlying obesity, looking at the weight reduction benefits of oral semaglutide, the mechanism of action and patient-centered outcomes in obesity, semaglutide by now we all know that it has an established safety profile, especially in patients who have obesity in line with GLP-1 receptor agonist class. Semaglutide basically acts by reducing the hunger pangs, increasing the satiety, reducing the cravings, and improving the control of eating. So therefore, leading to gross reduction in energy intake with semaglutide 50 mg versus placebo. Semaglutide has demonstrated improvements in weight-related quality of life, including the physical functioning, though still the 25 and 50 mg dosages are neither approved for obesity management or type 2 diabetes, but 50 mg dosage has shown clear benefits in terms of weight reduction. Comparative efficacy of semaglutide and standard type 2 diabetes therapy in all the PIONEER studies in terms of weight reduction, clear benefits were seen with semaglutide of 14 mg versus the other therapies and across all these PIONEER trials and across the SUSTAIN trials. The weight loss efficacy of high dose of oral semaglutide in persons with obesity, this OSS1, has shown that almost a weight, if the patient's baseline weight was 105.4, then change from the baseline of up to 17.4 kgs was seen with a dosage of semaglutide 50 mg once daily versus the placebo. The mean baseline weight of 105.4, the proportion of participants who could achieve body weight reduction of more than 20% or more than 10%, we can see there were a huge number. Almost 75% of participants could achieve a body weight reduction of more than 10%, but only 37% could achieve a body weight reduction of more than 20%. But there were people who could achieve a gross weight loss with the semaglutide dosage of 50 milligrams once daily. Looking at the effects of high-dose oral semaglutide on multiple cardiometabolic risk factors, we can see the reduction of waist circumference, the reduction of systolic BP, diastolic BP, and changes in hsCRP with the usage of semaglutide versus the placebo. Now, looking at the benefits of oral semaglutide across patients in chronic kidney disease, the eGFR declined annually with semaglutide. There's a lesser decline with the usage of semaglutide versus placebo. SUSTAIN 6 and PIONEER 6 for annual change in eGFR from the baseline. We can see across all the GFRs, may it be eGFR less than 60 or more than 60, the eGFR decline was much lesser with semaglutide versus the placebo. Looking at the glycemic efficacy of semaglutide in patients with renal impairment, oral semaglutide had significantly decreased HbA1c versus the placebo in patients who had associated type 2 diabetes and renal impairment. In FLOW trial is also evaluating the renal effects of semaglutide in these patients. and trial was stopped early because efficacy was demonstrated. No dose adjustment was required with semaglutide in patients who were type 2 diabetic and had underlying CKD. Now, looking at the benefit of the semaglutide in EVOKE trial, EVOKE Plus trial was conducted assessing the efficacy of oral semaglutide in patients who had early Alzheimer's disease. Here, patients were randomized to 1:1, where dosage of oral semaglutide was administered in dosage of 14 mg, which was gradually escalated. If the patient was tolerating well, then the dose was escalated up to 14 milligrams once daily versus the placebo. Patients here who were included had age of 55 to 85 years of age, MMSE score more than 22, and CDR, clinical dementia rating global score being around 1, and amyloid being positive, or the mild cognitive impairment or mild dementia patients were included. While in EVOKE Plus, almost 20% patients were included who had underlying small vessel pathology also. Here, the primary endpoint studied was CDR-SB score, and confirmatory secondary endpoints were changed in that score from baseline to week 104. So time to progression of dementia at baseline and baseline to week 104 were assessed in this trial. Now, looking at the potential benefits of oral semaglutide in patients with metabolic dysfunction associated with steatotic liver disease, this was a pilot study looking at the efficacy and safety of oral semaglutide in people who had non-alcoholic fatty liver disease and type 2 diabetes. The efficacy of oral semaglutide in such patients was statistically, there was a significant reduction of weight, BMI, plasma glucose, and HbA1c. ALT, AST, and GGT came down. Looking at the antifibrotic effects of oral semaglutide in patients with NAFLD, oral semaglutide grossly improved the impaired liver functions, hypertriglyceridemia, insulin-resistant, and hepatic steatosis. These changing in liver fibrosis markers, semaglutide significantly improved the FIB-4 index, ferritin, and type 4 collagen. To brief my talk, at the end, I would like to emphasize that multiple studies have been conducted to examine the effects of semaglutide in patients with cardiometabolic diseases, thus emphasizing the safety and efficacy part of it at multiple cardiometabolic factors. Thank you.
Wonderful deliberation.
Thank you.
And discussing the beneficial effect of semaglutide beyond glycemic control.
Yeah.
So the session is open for any questions from the audience.
Once the diabetes is diagnosed, so our aim is to control the hyperglycemia as well as to delay or to prevent the development of complications.
Correct.
At that time, we have to choose an agent which is available for the prevention of the complications. So I think the GLP-1 agonist is one of them, which prevents and delay the progression of the complications. It affects positively of the kidneys, brain, heart, liver. So we have to choose an agent which is available at that time. And particularly the GLP-1, this oral availability increases the compliance of the patient.
True.
So this is a good agent to take care of the use.
Wonderful agent.
To prevent particularly the complication after once we have stabilized the part of hyperglycemia part. So we look to the complication, to prevent the complications.
Yes.
Thank you, Dr. Pooja.
Thank you.
So we'll end the session now.
Thank you.
Thank you so much, ma'am, for sharing the rationale and evidence behind the newcomer drugs. Thank you, chairpersons also. Next, we have a panel discussion. I would request you to proceed for the felicitation ceremony at the presentation desk. Next, we have a panel discussion on the topic biosimilar insulins And I would like to invite Dr. Shubha Lakshmi Margarekar, ma'am, who is professor of medicine at Lady Hardinge Medical College. Ma'am is FICP and FIACM. She holds many publications in various national journals and multiple chapters in the books. She is a recipient of Dr. J.C. Patel and Dr. B.C. Mehta Award in Epicon 2014. I would like to invite you, ma'am. For this session, we have chairpersons with us, and I would like to invite Dr. Tarun Goel, Senior Consultant at Max Vaishali Hospital. Dr. Sanjay Mahajan, sir, Senior Consultant and Intensivist at Kailash Hospital, Noida. Dr. Ritesh Gupta, sir, Professor Medicine at AB Wims and RML. And Dr. Princy Jain, ma'am, Associate Professor at Lady Hardinge Medical College. We have eminent panelists amongst us. I would like to introduce and welcome them on stage. Dr. G.C. Vaishnava, who is associated with the Yatharth Group of Hospitals as a Group Medical Director and Medical Advisory Committee. He has special focus on diabetes and lifestyle diseases. He also takes keen interest in attending social welfare programs across India. And he has been awarded with FICP, with FICM. He's a member of IMA, member of Association of Physicians and Delhi Medical Association, awarded as Noida Ratna in 2007, and awarded as Delhi Ratna in 2011. We also have Dr. Naresh Dang, Senior Consultant Physician, who holds more than 30 years of experience as a consultant at various renowned institutions. And presently, he is at Max Balaji Hospital, Parpatganj. And sir is specialized in metabolic diseases such as hypertension, diabetes, NFLD, and obesity. I would also invite Dr. Neeru P. Agarwal, ma'am, who is the Principal Director and HOD, Department of Nephrology and Renal Transplant Sciences at Max Super Speciality Hospital, Vaishali, Ghaziabad. She holds 30 publications in various journals and chapters in textbooks. Ma'am has been awarded Sushruta Award for Clinical Excellence in 2021. I would also like to invite Dr. Neeti Agarwal, ma'am, who is presently Senior Consultant Endocrinology at Max Super Speciality Hospital, Parpatganj and Vaishali, and Indus Health and Center for Diabetes and Obesity, Metabolism and Endocrinology. Ma'am holds 19 years experience in the field of diabetes, endocrinology, and metabolism. She received honorable mention as Young Investigator during oral presentation at the AACE Annual Meeting and Clinical Congress, April 2006. Ma'am holds over 25 national and international journals, including original articles, case reports, reviews, and abstracts. I welcome all the chairpersons, the panelists, and we can start the discussion, ma'am.
Thank you, Dr. Achal. Now, moving on to our panel. So, as we are aware, biosimilars are the drugs which are used in many diseases, and one of them is diabetes. So, here we are with the panel discussion on biosimilar insulin. And we have panel of experts, as Dr. Achal has already told about. So, moving on to the question directly to Dr. Neeti, ma'am, what exactly is biosimilar insulin?
Biosimilar insulins or the follow-on biologicals. See, before I actually talk about the biosimilars, one thing we need to understand why the need of biosimilars was there. Biosimilar means similar to the original molecule, similar to the biologically produced original molecule. So it is not, the production methodology is different. It is also a biological, it is produced by the same RDNA technology, but the cell line that is chosen is different, the purification process is different, the extraction process is different. So it is similar to the original molecule, but it is not the same process. So because it is not the same, another thing which is important here is the way it is introduced in the market. Why it was introduced is, of course, certainly because as Dr. Previous speaker had talked about the inclusivity, the larger reach, the cost. So over a period of time, once the patent of the biologics, it was getting over. So these biosimilar insulins or the follow-on biologics, they were introduced. So they are similar, but they are not the same. Their production process is similar, but they are different they're not exactly the same.
Okay. So yes, as ma'am told, it is not exactly the same. And there are some words also like reference product, biosimilar product, interchangeable products. So these are all used for biosimilar insulin or the same products.
I just want to add one thing here, that these are actually very the same wording is different, but they actually mean the same.
Yes.
So the thing is that because of all the money involved things, so these terminologies confuse you, but they are the same.
Yes, yes. So thank you very much, ma'am, for this putting these words. So now I would just invite Dr. Ashish to please chair along with the other chairperson, please join us as chair. So moving on to the next question to Dr. Naresh. So are they similar to biological insulin? These biosimilar products, are they similar to biological insulin? Or are there any advantages over biosimilar insulin?
So yes, they are similar, but I would go a little, quality control is very important.
Yes.
And I can tell you there are at least 10 companies that try to get their insulin approved in US.
Yes.
But only one was able to manage it. And that insulin was Simgli by Biocon. And interchangeability is, I was there in this lecture on biosimilars in ADA, US. And the doctor is writing Lantus insulin and the pharmacist can give Simgli.
Yes.
That is where the interchangeability was allowed in US. But he cannot give any other basal insulin.
Yes.
So all that interchangeable insulin has to meet all the criteria of immunogenicity, of hypoglycemia side effects, if there are any more or less. It has to be comparable in efficacy as well as the side effects and immunogenicity. Then only it is biosimilar. The ones which are available in India, we don't have that much of good quality control, so we need to be, very cautious. Thank you. Of course, the cost is an important factor. It is a little less expensive, but I think quality has to be maintained.
Yes, definitely, sir. Quality has to be maintained for better patient care. So now moving on to our next question. As sir has also covered some part, but what are the various concerns with biosimilar insulin? I would like to know from Neeru ma'am.
So as Dr. Neeti and Dr. Naresh Dang has said, so the cost is important, yes, cost is less, but at the same time, different manufacturers are coming into the market. They are manufacturing by different processes. We don't know what would be the protein folding. We don't know what would happen to the sugar moiety. So although the peptide change is same, but at the same time, the molecules that would come out ultimately would not be same. So that creates a lot of problem for my patients. Why? Because they can have hypoglycemia, they can have hyperglycemia. I do not know which, it could be in fact lot to lot variability in the same company. So that could give a erratic diabetic control for my patient. This is one aspect. Then I actually expect that my patient who is getting this biosimilar should show the same pharmacokinetics and pharmacodynamics in my patient in vivo as well as in vitro. I do not know whether it is actually there or not. Then the other part is, if at the time initially when they are launching, there may not be any side effects, but over the time, if some antibody develops against those molecules, that is immunogenicity, their toxicity, their loss of efficacy, because long time back, in case of E-Prex, if you can recall, this was a recombinant DNA decree molecule. Against the stabilizing agent, antibodies were formed, which led to pure red cell aplasia, and the product was withdrawn from the market. Could it happen to biosimilars also? So these are all my fears that I am actually afraid before I start with biosimilars.
Very well said, ma'am, because we are dealing with patient and we have to take care of all safety points, whenever we are starting or we are considering any new drug. So with this, I would like to know how switching from biological insulin to a biosimilar insulin should be done and why. This I would like to know from Neeti ma'am.
So basically, as we just talked, switching from biologics to biosimilar can be done. Now, why is basically, I would say that basically if cost is an issue. So again, in So this is actually a very interesting thing. If you see, once the patents were over, then the basal insulins, for example, if I talk about glargine, the cost, the biosimilars were introduced, right? But if you compare the cost, now the originator molecule, the cost also they brought down. Now they are earning on the basis of the U300. So there is a cost war, basically. So yes, you can replace a biologic with a biosimilar, but personally, if you ask me, I would rather not, because it's not too much of difference is not there in the cost now. So if you maybe you want to initiate with a low cost, and then maybe you initiate with a biosimilar, but probably I would personally not shift over a patient from a biologic to a biosimilar. But if cost is a constraint, then you can. And you can, of course, initiate it on a 1:1 basis.
Yes, so we have to individualize according to the
Certainly,
patient
certainly.
affordability and your concerns. So, okay, ma'am. Thank you so much. So now I would like again that how is the quality of glycemic control in biosimilar insulin as compared to originator insulin we have to take care. So this I would like to know from Dr. Vaishnav if he can, sir.
See, quality of glycemic control is no different because biosimilars are same. It's almost same, and the high similarity is there, except that meaningful difference in the form of safety, purity, and potency should not be there. Otherwise, they are same. Their dosage adjustment, when you are shifting from biological insulin to biosimilar insulin, you don't have to change. And the effect is almost same. My query is that why should we change a person who is already controlled on diabetes, on insulin, biological insulin and oral hypoglycemic agent to biosimilars? The cost is one factor.
Yes.
And what I read in the articles that the cost of biologicals is going down because so many biosimilars have come in the market and competition has grown. So almost the difference is, as Dr. Nidhi said, the difference is not too much now. So if the person is controlled on biological, if a person is not controlled and you want to try something, you can try biosimilars. And you don't have to do any dose adjustment, you can just start.
It can be add-on.
Yeah,
like
it can
of
be
thing.
add-on, yeah.
Anything else you want to add, ma'am? Dr. Neeti, ma'am?
So quality is certainly an issue. Actually, the way the original molecule is allowed in the market is after again phase 1, phase 2, phase 3 trials, and then it's a pyramid, like large number of people undergoing phase 1, 2, 3 trials, and then it is introduced.
Yes.
In this, it is an inverted thing. So in here, what happens is with a biosimilar, you are not undergoing all the phase 2 trial is not there at all. Only you undergo the phase 1 and the phase 3, and your target here is non-inferiority. It should be similar to the original molecule. So with regard to efficacy or with regard to safety, so certainly the quality control is an issue. Also the batch variability with all biologics, because they're produced, they think from the living things, they're not chemically produced. So they are the recombinant DNA technology, they're produced from the yeast cell after the insertion with regard to insulin, I mean. So every batch variability is there. So this variability, because the original molecule has undergone such a stringent process, the batch variability is very less with the original molecule. But because these procedures are not there in the biosimilar molecule, the chances of variability are much higher. So certainly the quality is an issue, sir. Yes. So certainly that appears to be an issue.
You want to add
Also the drug delivery device, the maintenance of the cold chain, because these companies come with their insulin. I know of 1 or 2 companies who brought basal insulin, then they discontinued, then they were not able to supply. Yes. There are some issues with these local.
Yes. The advantage, I think, is certainly that with their coming, the prices of the original molecule has gone down. So certainly a larger number of people are able to afford it now.
Yes, yes, definitely. So definitely we have to take care of all those concerns whenever we are switching from one to another. And glycemic control is almost similar. And This is what we have just concluded with this question. So now, biosimilar insulin, what precautions are to be taken in hepatic and renal impairment patient? So this I would like to know from Neeru ma'am.
So in the presence of renal failure and hepatic dysfunction, the half-life of insulin is prolonged. Hepatic metabolism disturbs, so it increases the half-life of insulin. When the renal failure is there, the half-life of insulin is prolonged. So their requirement for insulin is actually go down. So the patients, I can tell you about the regular insulins, because biosimilars are new molecules, they are yet to come in India, and we have to compare them with the biological molecules in future. So all the patients who have GFR of more than 50%, 50 ml per minute, there is no need to change the dose of insulin. If they have GFR between 10 to 50 ml per minute, the dose should be reduced to 75%. And patients who are of CKD stage 5 or GFR is less than 10 ml per minute, the dose should be reduced to 50% of the normal dose. So this is very important. This applies to dialysis patients, whether they are on hemodialysis or they are on peritoneal dialysis. And as far as HbA1c is concerned, we usually maintain the HbA1c because most of the patients are usually elderly diabetics. They have multiple comorbidities. So we keep their HbA1c between 7 to 7.5 as compared to other population, normal population, where you want to keep it around 6.5 only.
Yes, so correctly said by ma'am. So we don't have to be very strict in patient with the, hepatic or renal impairment for as far as HbA1c or blood sugar levels are concerned. And secondly, as ma'am told, we have to be monitoring more frequently so that the chances of hypoglycemia is more. So we have to be more frequent in monitoring such patients, and so that we can titrate the insulin according to the blood glucose values. So thank you, ma'am.
I also want to add here that mostly when we give insulin in normal patients is 70% in the morning, like when it is and 30% in the evening. So in our CKD patients, because they have a tendency for night hypoglycemia, late evening or night hypoglycemia, we prefer to give their 80% of the dose in the morning hours and 20% in the night only.
Okay, ma'am. So now moving on to our next question, that do we need some special precaution in elderly population? This I would like to know from Dr. Naresh, sir.
Yes, elderly population is the high-risk population. They have problem of administering the injection. They have frail and fragile skin, so they can have more trauma, more bruising on giving the injection, and many of them are unable to take the injection themselves. So they are dependent on their relative and all that. So insulinization in an elderly patient is always a problem. And older people have higher risk of hypoglycemia, high risk of hospitalization because of hypoglycemia and even mortality. So we should go for slightly less stringent targets, lower dose of insulin, and maybe HbA1c of around 8% for elderly as well as for CKD patients is what we target. And it is a challenge, definitely. Thank you.
Yes, so elderly population, we have to take care of the complications because they have multiple comorbidities along with the diabetes. So we have to take care for that also. And hypoglycemia part is to be explained to the patient, so patient as well as the caregivers, so that if at all it happens, they can take care of the situation properly. So thank you, sir. Now moving on to our next session. So what are the impact of biosimilar insulin on healthcare system? So this is the question I would like to know from Dr. Vaishnav, sir.
See, in our country, most of the patients, they shell out money from their own pocket. Outside in US, UK, it has made a lot of impact in the healthcare because the cost has gone down, and they are talking of billions they have saved after introduction of biosimilar. But in India, the patient has to give money for the, especially in OPD patient, insurance doesn't cover OPD. Yes. So I don't think we will reduce the burden on the healthcare system, because these medicines, if they are available for the common people who are going to the general hospital, government hospitals, then fine, then it will definitely help them. But I don't think they will be available. Still, insulin analogs are not available in most of the reputed government hospitals. So patient has to take out money from their pocket, and healthcare, the only impact which it's going to make, which I feel, is that availability, because the biologicals are not available everywhere. So many companies are coming up with biosimilars, so that it will be available almost every nook and corner. My only fear is just when the GPs are going to use it, because now GPs, we have competition with GPs, and they are giving insulin glargine and 2 times, 3 times a day, and premix insulin 3 times a day. So whether these insulins will be introduced to them or not, and how they are going to use, that impact is going to create problem.
Yes, so awareness of patient as well as the physician, whosoever is taking care of the patient, is also very important, along with knowing about the biosimilar or biological as of now. So with these questions, we have just few this thing, what are the experiences with our patient with these type of drugs? I would like to know from maybe first our chairpersons, if anyone of us can.
Thank you, Dr. Shiba. Our learned panelists have been very kind enough to, highlight when and where to use biosimilar insulin. But if you would have noticed, every question that Dr. Shubhalakshmi asked, they had to fumble for words and find out the reason and really dig out a reason to start a biosimilar. The time was when the innovative molecules were quite high and availability was an issue. Biosimilars had some role. But today, when the innovators have come down, Glargine 100 is available at similar prices, biosimilars, there's actually no role of biosimilars today. Biosimilars, as the entire panelist said, that you use them, you don't, because U100 is one basal insulin that everybody has been using, and we know it's on-road practice. Wonderful molecule, we know how it works. Unit to unit, we know what the glycemic control would be and how a fasting sugar could be controlled. The moment you switch over to biosimilars, we're not aware. And since there's no additional advantage, I think in clinical practice today, I would actually refrain from using any biosimilars when the innovative molecule is available. And one thing that Dr. Vaishnav was pointing out, whether since these biosimilars, if they were available in government thing, yes, U100 is available, Lantus is available in all the government institutions. And when we write to the patient, I've seen patients coming with Basalog, Basaglar, these biosimilars coming up. It is there. But I think the cost factor is not a factor right now, so we need to really stick to innovative molecule as far as possible, as of now.
Yes, sir. So thank you.
I think the panelists would agree with this fact.
Sorry, I want to add one thing. I don't think the biosimilars are the thing which can be brushed under the carpet.
Yes.
The main issue is cost. There are many patented drugs where no generics are available, and there the role of biosimilars come into play. So I think they are the new wave technology. I think they are made with a lot of biotechnology research. So these things should be kept in mind, especially in a developing country like India, where you don't have people don't have much access to the healthcare with rising costs.
But today we are talking on biosimilars of insulin.
Biosimilar,
not entire biosimilars.
no, only biosimilar
so
insulin.
The cost is actually equalized.
Yes. Otherwise, so it is.
So there is a difference. Definitely in oncology.
Yes,
oh,
that yes.
Sir, if we talk about the innovator glargine and the glargine biosimilars, there is a difference, sir. Like like the biosimilar glargine, if you buy it from Pradhan Mantri Aushad Kendra, so this barely costs around 350 rupees. But if you could talk about the innovator brand, it will cost 700. And same Aspart, if you buy it from the innovator brand, the cost is more than 800 rupees. And if you buy the biosimilar brand, which is new in the market, then the cost is less, sir. So the cost also sometimes matters. Yes, the question is that whether the biosimilars are equipotent or not.
So in my experience, personally, I don't think they are equipotent. Actually, second thing I just want to say, sir, that the cost is very similar. There is not a 300 rupees difference anymore. हाँ, वो प्रधानमंत्री वाली हैं, sir.
I'm talking about, see, ma'am, I'm not talking about Pradhan Mantri or non-Pradhan Mantri. I'm talking about biosimilars, sir.
Sir, I had tried, but I do not use them now. I had tried, and as I said, that the efficacy I found was not as good, and the control patients who actually, I had shifted over to biosimilars, I had to put them back because they did not, I mean, with insulins, one is of course the efficacy. The second, sometimes I feel that maybe because everybody will be keeping these insulins, all pharmacies. So that cold chain, sometimes I feel is more lax with the biosimilars.
Cost?
Sir, you want to?
Cost factor, it was like those gliptins, you know, when teneligliptin came in, no cardiovascular safety, driver, nano, don't talk of safety features like Mercedes. Well, you could do that. So you could gliptinize everybody. Similarly, if we have that 300 margin of amount of patients, yes, in those subset of patients, you could actually insulinize them with biosimilars. I think that's a very pressing circumstances today. India is moving from developing to developed country. I think this thing is not a significant amount of concern. Yes, in all these oncology drugs and other drugs, yes, it could matter a lot. But in similars of
Your
insulin,
question, Biocon insulin I have used because Biocon is the insulin which is also supplying singly to US. Otherwise, I have not used other insulins. They are fine. I mean, Basalog and Lantus are fine.
I think they are too new in the market. What I personally feel is, yes, if somebody wants to use biosimilar, yes, it can be allowed, but the patient should be monitoring the blood sugar values very stringently, maybe morning, evening, and lunch and night. This is one part. And I think if some brand, you are feeling that there are more control issues with some brand, particular brand, that should be brought to notice, and then it should be rectified also. That's how we can improve upon.
One question. Like,
I just wanted to
we are
add
talking
one
about
point.
biosimilar insulins. They are immunogenic. They're immunogenic. So, do we have any data regarding about them in the pregnancy?
So there is no data as such. So the
Can
point
we use
is,
them in pregnancy?
no, I have not. So again, as Sir said, practice differs. In my kind of practice, I cannot, have, because it's very specific practice. So in my kind of practice, I would rather shift over to the original molecule. But yes, sir. Exactly, sir. That is therefore, you have to really, certainly, sir. That is the thing. If you're talking about masses, then maybe the use of biosimilars may hold ground.
But
if
for
you
special groups,
ask
we
me
have
about
to take
a
care.
clinical practice means what was my experience. Till date, I've had with the analogs, that means I've had only 2 reactions with an insulin, and one was Vosulin, which then I've actually stopped using that, and number 2 was Basaglar. I'm using the names, straight names, I should not be. But these were the biosimilars that we used. Vosulin, so you have to take your decision and call.
Yeah, I would like to make one point. The production of biosimilar insulins is very complex because it involves production of large complex molecules as compared to other biosimilars like aspirin or something which are small molecules. So the production method is very complex and they can be dose to dose and batch to batch variability. Even the delivery system, the apparatus you use to inject the insulin can vary the safety and efficacy of these insulins. So it's a very difficult call to whether we should start the patients on biosimilars or not, and the physician and the patient should be in complete and close, the patient should be under close watch, regular follow-up before we start the biosimilars.
I think he's put in a very valid point. The delivery system, drug delivery system. Yes. With biosimilars, you have miserable pens. But with these innovative molecules, the pens, the devices, they're very good, accurate, and superb delivery. That's very important.
So, Dr. Ritesh, would you
Pradhanmantri
like to
wale
add?
bhi yahi baat hai.
Dr. Ritesh, would you like to add anything? Okay. So now, as we are running short of time, I would like to conclude the session. And I thank all the panelists for this excellent experience sharing, and all the chairpersons also for this excellent discussion. So with this, I would like to end the session, panel discussion. Thank you.
Thank you, ma'am, for... Sir, please. I would like to extend my humble apologies to Dr. Ashish Gupta, sir. We missed on to you because of some confusion. I would request you to proceed for the felicitation ceremony at the presentation desk. Now I would like to call Dr. Soumya Sagar, who is an assistant professor at Lady Hardinge Medical College in Department of Medicine, to take over for the further sessions.
Thank you, ma'am. And thank you, Dr. Shubhlakshmi, ma'am, and other faculty members for an interactive discussion, panel discussion. And we have witnessed many interactive, informative sessions since today morning. And now we have reached to almost the end quarter of this event. But we do have 3 more interesting talks lined up. And so without wasting any further time, I would like to proceed and would request our honorable chairpersons to kindly come on the stage. Dr. Alpana Rezada ma'am, she is Director Professor at UCMS Hospital. Dr. Sameer Gulati sir, he is Professor at LHMC. Dr. Parag Sharma, he is Director at Arogya Hospital. I would also like to call on the stage Dr. Dheeraj Kapoor. He is the speaker for this session and he'll be speaking on how to achieve glycemic control to meet glucocentric and cardiocentric goals. Sir is the Chief of Endocrinology at Artemis Hospitals, Gurugram. He has around 70 publications under his name and has been on advisory board for prestigious national as well as international journals. Over to you, sir.
Good evening. Thank you, Soumya, for that generous introduction, and to Dr. Sharma for inviting me here. It's a rather emotional moment as I stand here because my mother is an alumnus of this college, and she did it in 1968. And obviously, she's now busy enjoying a retired life. Nonetheless, so I would wish to talk on glycemic control and the glucose-centric and cardiocentric goals. Now, the fact of the matter is, and the rather blunt statement is, that diabetes, high sugars don't kill anyone in general. Cardiac disease does. But at the same time, we must understand that albeit hypertension control, lipid control is important, but I guess glucocentricity should not be ignored. And if we could combine glucocentricity and cardiocentricity, it is obviously a boon. So this is type 2 diabetes for you. So obesity is the factor, physical inactivity, and accompanied by high blood pressure, genetic factors, PCOS possibly in the younger age, and PCOS may actually be a risk factor for diabetes in future, dyslipidemia, race, ethnicity. So now we already have a loaded gun in terms of our genes. And pulling the trigger by dietary issues and sedentary lifestyle doesn't help us. So we are actually pointing the gun at ourselves and pulling it. And this obviously is causing problems. Of course, obesity, sleep is very important. You don't sleep for 2 days and see your fasting sugars the next morning, you'll find the difference. Now, I see patients who say diabetes runs in my family. My answer is, actually no one runs in your family. That is the major issue that we need to address. Exercise is a must. And then if we combine the two, you get something called cardiovascular disease, ASCVD. So higher HbA1c predicts severe risk. I will not go into the details here, right from MI to stroke to amputation. And now, heart failure. Heart failure, I guess, the elephant was always in the room. That we did not see is a different matter. And of course, this came into importance after gliflozin, especially the EMPIRIC trial showed that it reduces mortality from heart failure. Now, Eugene Braunwald says that we have so far managed to address most issues in diabetes except for heart failure. So you pull down this by 1% and 14 to 37% reduction in endpoints. Now, there are some patients in which you can never achieve glycemic control for a variety of reasons, diet control, not walking, whatever. But, for example, speaking metaphorically, if you bring down from 13 to 9, and mind you, 9 is nowhere near control, you still have done a lot of service to the patient. 4% fall in HbA1c, you would reduce the complications by this magnitude.
So there's something called a glycemic legacy or a dysglycemic legacy. So if you control sugars early, you reduce the risk by 20% for MI and 19% for all cause. Now, if you delay till 10, you won't get that advantage, but still reduce risk by 7% and 3% respectively, which would mean that it is never too late to control diabetes. The benefit will be less, but it will still be there. So no talk can be complete without UKPDS. Treat early and get benefits. Accord advanced NVDT. Now, these showed that aiming for a tighter than tight control would be counterproductive. Yes, some benefit in microvascular, that too after long, but CV mortality might increase. And there are patients, the so-called students of Google University, they say, we want sugars less than 6% on a sulfonylurea. So that obviously is asking for trouble, and that it's waiting for trouble actually. Now this slide we've seen so many times, it only shows that one size does not fit all. We have to be patient-centric. We don't have to be guideline-centric. Every patient is a different patient. So for example, in extreme ages, the too young or the too old never aim for a tight control. In fact, HbA1c in a type 1 diabetic child less than 7.5%, not 6.5. Disease duration, so longer the disease, well, go slightly slow, because these are the patients in whom complications have set in. In these, there may be autonomic failure, there may be hypoglycemic unawareness, and all of them can be counterproductive. Life expectancy, so if short lifespan, probably terminal disease, go slow, because by tight control, you'll only achieve one thing, and that is hypoglycemia, nothing more than that in the patient who's terminally ill. And of course, comorbidities, complications go slow. Now, resource system is so important. We see so many patients from villages, and obviously advising something like insulin would not be a very sensible choice. So there the guidelines might not work. Even at 10 or 11%, I would go with tablets there. I may, set a few bells ringing here, but the fact of the matter is insulin, injection, storage, then procuring might be a difficult task. So tablets, albeit might not get too good there, but still it would be worthwhile in the patients who have limited resources. So multifactorial approach, glycemic control, hypertension, lipids, and agents with cardiac and renal benefit. Mind you, most drugs are cardiac and renal safe, friendly. But protective, I know of only two classes. Number one is a gliflozin. Number two is the GLP-1 therapies. Yes, there is some data on linagliptin, some data, but still, these are the predominant drugs that we use. So, lifestyle changes are the first and foremost. Evaluate for complications are equally important. Weight management, as we heard, reduce weight, reduce MASLD, reduce pancreatic fat, reduce epicardial fat, and you bring down the mortality. The basic point is that fat is the one which comes and goes as per your choice. It is like a tenant. The longer it stays, difficult to evacuate. So the fat which comes the first is the first to go away. So that is why MASLD, insulin resistance, pancreas, secretory defect, epicardial fat, direct contact with the myocardium, and there it enhances myocardial inflammation and may actually offset or may aggravate heart failure in these patients. So this is the seesaw, drugs with proven CV benefits, lesser risk of hypoglycemia, and of course, weight loss. So any drug which could achieve these three will be a triple whammy for diabetes management. I will jump this slide. We all know about it. So the guidelines are that you must use drugs which are cardioprotective, and if you feel important in certain situations, a gliflozin can even supersede the use of metformin. Honestly speaking, I've never done that because I believe that metformin still has a role to play. And importantly, once the newer drugs hit the market, the older ones which do not have side effects start to develop them, because for whatever reasons, I will not go in there. So since gliptins and GLP-1s have come, metformin is increasingly causes gastritis, increasing diarrhea, increasing B12 deficiency. But 1964 to 2024, it maybe 60 years, it is still there and working. Most guidelines, drug of choice. So I guess metformin does deserve a better deal. And in the UK PDS, the patients who were on metformin actually had cardiac benefit in the longer run because of resistance. So I think metformin does develop deserve a better deal. But nonetheless, GLP-1s and gliflozins, as of date, have the most robust data for cardio and renal protection. So these are the ADA 2024 recommendations. ASCVD, GLP-1s, failure, CKD, gliflozins. So that is the crux. And obviously, if you could combine the two, you address at least 9 to 10 of the ominous 11. Now, out of octet, 7 are addressed if you combine the two. And therefore, any drug which is cardioprotective helps us. So these are the drugs. Metformin is not here, but nonetheless, sulfonylurea, glitazones, AGIs, gliptins, gliflozins, all of them. Efficacy is high for sulfonylurea. Glitazones, very good efficacy. The only drug possibly, except for now, gliflozins, which has been helping MASLD for a long time now. But the problem with glitazones is that increased risk of heart failure, and also it takes long time to act. So neither the physician nor the patient has that kind of a patience. Hypoglycemia, only 2 of these 3, sulfonylureas and insulin, they cause hypoglycemia, otherwise they don't. Weight gain, well, a glitazone, sulfonylurea, and insulin, they cause that. Cardiac benefit, only gliflozins and the GLP-1s. Yes, there is scattered data on AGIs also. There is data on glimepiride that it does not interfere with ischemic preconditioning. Yes, there's data there. But to keep things crisp, I guess gliflozins and GLP-1s are the way to go. So multiple defects: impaired secretion, GLP-1s and DPP-4, decreased production, again metformin, glitazones and DPP-4. Appetite, so gliptins do not impact appetite in general. Metformin does, but now the GLP-1s, through the central mechanism, they impact appetite. Decreased glucose uptake is addressed by glitazones, possibly gliflozins, because gliflozins reduce insulin resistance, but now data is emerging that gliflozins may actually cause loss of muscle mass. And therefore, if your muscle mass is lost, then you might not have a very extensive glucose disposal in the muscle tissue. Glucagon secretion, the GLP-based therapies are the only one which address the alpha cells. None of them. So if you combine maybe a GLP-1 and a gliflozin, you actually nullify the alpha cell response of the gliflozin. We know that gliflozin activates alpha cells, possibly one mechanism by which they cause ketosis. But otherwise, the alpha cell is addressed only by the gliptins. So this is the multicentric approach. So under one umbrella with GLP-1s, you could cover weight loss, you could have CV benefits, Side effect profile, fairly tolerable, at least till 7 milligrams of the glutide that we use. The dulaglutide, yes, up till 1.5. So in America, they're using 3 mg. I have not. 1.5, yes, is fairly tolerable. Approved for a wide variety of patients. Diabetics, then of course the patients who have cardiac events, stroke, you have data on dulaglutide, and also in patients who want to lose weight. Now, contraindications, fine, I'll come to later. So as a result, you reduce fasting, you reduce PP, and the net is fall in HbA1c. Now, these drugs, they cause a glucose-dependent insulin release, which actually means the risk of hypoglycemia is negligible. So that is why it is an OAD. The risk of hypoglycemia with an OAD is similar to that of placebo. That is why it does not qualify as an OHA. There are just two OHAs that are known of. Number one, sulfonylurea, and number two is glinides. They are the only two OHAs. Rest, of course, are OADs. So the GLP-1s, pancreas, beta cell function, insulin biosynthesis, glucose-dependent release, and of course, decrease glucagon as well. From the heart standpoint, reduce cardiac risk, fatty acid metabolism, 4 to 5 millimeters fall in systolic blood pressure. Brain, reduce body weight and satiety. 4 minutes, okay, fair enough. And of course, stomach, gastric emptying. This is the data with semaglutide as regards body weight and HbA1c, anywhere from 26 weeks to 78 weeks. Reduction, 3-point MACE, 14%, stroke, 17%, MI, 10%. Reduces HSCRP, which obviously is a surrogate marker, reduces LDL, and of course reduces BP by 5 milligrams. Of course, it reduces the waist circumference, which is a marker for visceral fat, which goes down. Now for the gliflozins, CVOTs, I'm sorry for this slide, the cursor got shifted, but nonetheless, EMPA-REG trial, predominantly 99% patients were secondary protection, so 14% reduction in MACE, CV death reduction by 38%. Now, Canvas, 2/3 had cardiac disease, 1/3 didn't. Again, MACE by 14%. Rest, of course, was superior numerically, but not statistics. Now, dapagliflozin saw the garden variety of patients, which we see in the OPD day in and day out, that 2/3 patients did not have a cardiac disease. They had risk factors, and therefore not much of a significance in numbers. But if in the DAPA trial you see the ones who had established CVD, improvement was significant statistically. So this data, not exactly skewed, but divergent, because all patients did not have the CVD. Now, the key slide, which to choose. So if you take cardiorenal, well-established ASCVD or a stroke, you may choose GLP. That is a better choice. But if heart failure or CKD, which means GFR less than 60, or a macroalbuminuria or above, if that predominates, gliflozins are the way to go. Glycemic control, history of DKA, yes, you may use GLP-1. And mind you, GLP-1s are stronger agents than gliflozins in terms of glycemic control. Comorbidities, well, obesity, genital mycosis. I have my own data published in IJEM. 21% of patients on gliflozins had a GTI. And then once it recovered, started again, 15% had it again. So GTI is an issue, and this is despite educating the patients. And of course, lower limb amputations, we have data on Canvas. Also EMPA-REG, we have that data. Now patients with active gallbladder disease, any risk of pancreatitis or thereabouts, GLP therapies are best avoided. So gallbladder disease, pancreatitis, gastroparesis, history of empty, so all contraindications of GLP would be
the ones you give gliflozins. So the combination reduces residual risk, myocardial salvage, improves GFR, reduces progression of the disease, reduces MACE, and of course CVD life. I would not go into all that, but predominantly the pipes are addressed by GLP-1s and the pump is addressed by the gliflozins. Okay. So if you combine the two, you cause weight gain, reduce mycosis because fungi has DPP-4 in their walls. So if you give a DPP-4 inhibitor, the fungi might not proliferate. Improvement in hepatic output. Ketone bodies possibly help in improvement in cardiac failure. So that could be one mechanism by gliflozins helping in cardiac failure. So to summarize my talk, that the use of two classes in combination, well, we await trials. Better BP reduction, weight reduction in combination with GLP-1s and gliflozins. No contraindication. MTC, absolute for GLP, pancreatitis for GLP, and relative, you have mycosis and, of course, type 1 diabetes for gliflozins. So with this, I would wish to end my talk. Thank you so much for all your attention.
Thank you, Dr. Kapoor, for enlightening us with your vast knowledge. I would like to ask you my personal question. Like we all talk about physical activity and lifestyle modification. What impact does a mental state or I should say a mental health plays in control of diabetes or related to CV risk? Like a patient is having a override sympathetic drive in comparison to a patient who is having a relatively higher parasympathetic drive by meditations and all these things. So what's the difference in glycemic control of these two type of patients, since lifestyle is getting, definitely we all are undergoing a stressful lifestyle. So what does it counts in this these type of cases?
First of all, lifestyle. So Dr. Amit and Dr. Saurabh,
yeah,
they saw me 6 years back.
Yeah.
They are now seeing me. So I've done it through lifestyle.
Okay.
That's one. Second, so I'll give you an example. I wrote a book called Diabetes in Pregnancy, and there was this one chapter for sleep control only. As I said in my talk, that you don't sleep for 2 nights and see the fasting the next day, or possibly jet lags or mental stress. So many people come in the OPD, sir, यहाँ पे गमी हो गई, बहुत परेशान थे, कुछ एक्स्ट्रा नहीं खाया है और शुगर यहाँ पे है. So the issue therein is that any stressful condition would cause a catecholamine surge.
Exactly.
Would cause a cortisol surge, and
release.
Both those are anti-insulin hormones. Yes, in terms of stress, mind you, tasty food is a very good stress buster, and there's enough data on that. So supposing someone has a stress, I offer him salads, he'll hit me, first thing.
Okay.
So when someone is stressed, and we've seen what happened in COVID, they were all eating parathas and kachoris and enjoying it actually.
Right.
So stress by hormones, by enhancing hedonic appetite. Hedonic means that you actually are not hungry, but you want to eat. Stress increases hedonic, and this GLP-1 actually reduces hedonic appetite. So hedonic appetite, lack of, because stressful you have lack of sleep, acidity, you have muscle aches and pains, you wouldn't exercise. So stress plays a lot of role in terms of eating, lack of exercise, and of course cortisol causes increase in visceral fat. That means.
Great. Thank you, sir.
If there are any questions from the audience, Dr. Kapoor would be happy to take. So thank you, Dr. Kapoor, for a wonderful session, and we close this session.
Thank you, sir, for elaborating some of the very practical aspects in diabetes management, and thank you, chairpersons. You may proceed to the presentation desk for felicitation. Sir, photograph, sorry, sir. Thank you, sir. Thank you, ma'am. Now moving forward, may I call upon the chairpersons for the next session. Dr. Payal Jain, she is professor at JIMS. Dr. Smita Nath, she is associate professor at UCMS GTB Hospital. And Dr. Amit Sharma, sir, he is professor at Lady Harding. May I also request Dr. Amit Gupta, sir, to please come on the stage. He is the speaker for next session, and he'll be speaking on the topic Technology and Advancements in Diabetes Monitoring. Sir is director at Center for Diabetes Care at Greater Noida. He is vice chair and in International Advisory Committee of American Diabetes Association and has contributed significantly to the medicine literature. Thank you, sir. Over to you, sir.
Thank you, chairpersons, and thank you, Dr. Ajay, for giving this opportunity. And I am thankful to all the people who are still sitting in the auditorium because we are already running late. But I think you will find this presentation interesting because there are certain things which we don't do commonly in clinical practice, especially for those who are working in medical colleges. These devices are not very regularly used. So my topic is what are the newer advances in technologies when it comes to diabetes monitoring. So glucose monitoring, as you see, that a lot of things have changed over the last 2 decades. The way the mobile phones have changed, the way you watch television or the content, it has changed. Similarly, the way by which we monitor the glucose has come a long way. We all know that the commonly used method to monitor glucose is the HbA1c. It is still the standard of the care, but right now the people have started to write obituary for the HbA1c, and they believe that HbA1c is not going to be one of the most commonly sought marker in future management of diabetes. So what is going to replace this? So because HbA1c is not able to provide you the impact of hypoglycemia and hyperglycemia, and there is unknown glucose variability. So how did an A1C of 7% became the standard? This was the result of this DCCT trial, where it was found that a 1% reduction in HbA1c could reduce significant mortality. And this cutoff came from certain studies where it was found that if we keep the HbA1c less than 7, then we are able to reduce the complication burden in people with diabetes. Slides are not moving. Can someone help? The slides are not moving. Yes. So what are the clinical advantages and disadvantages of A1C? As I already told you that it cannot give you the hypoglycemia and hyperglycemia predictions. Also, it cannot predict glycemic variation, and it has a limited clinical utility in short-term glycemic control, we all know. And there can be inter-individual variations like ethnic differences, HbA1c level, and sometimes in certain diseases like which have high red cell turnover and hemoglobinopathies, HbA1c may not be a correct marker. So can we do better than HbA1c? So it is still the gold standard, but is there a better test? So for the glycemic control, the metabolic control, the diagnosis, complication risk, or the research. Then the age-old SMBG, it provides information for points in time. However, hypoglycemia and hyperglycemia are again often missed. The overnight data is sometimes impractical to obtain because it is very difficult for the patient to monitor blood glucose level and wake up at night. And logbooks can be very difficult to maintain. And sometimes whenever a patient brings those kind of logbooks to us, it can be very difficult to interpret those also. So this brings me to the topic of today, that is the CGM. It is one of the major advances in glucose monitoring, and it provides significant amount of the glucose data over an interval which can vary from days to months. And reports can be sometimes difficult to interpret, so you need to understand how to interpret these CGM results. And sometimes this can help us in adjusting the therapies also. So I would just show you some of the devices which are available, and this is the CGM technology. You can see one of the Abbott device, that is the Libre, which is now available in India. The Medtronic CGM sensor is again, which is available. The Eversense, which is shown on that side, is this is the Eversense sensor. This is an implantable continuous glucose monitor, but this is not available in India, but this is available globally. And this can monitor glucose level up to 6 months once it is implanted. These are the different sensors which are available globally apart from the Abbott and the Eversense. There is a GlucoRx biosensor. The Dexcom is again a very popular CGM device which is available in the Europe as well as the US market. And this slide is a busy slide, but it is important to see that, for example, Guardian Connect can monitor glucose level for 6 days, the Dexcom G6 for 10 days, the Freestyle Libre for 14 days, the Eversense for 180 days, and now the Eversense has come up with a sensor which can monitor glucose level up to a duration of 1 year. So what is it by CGM? This is in terminology. So there are two types of CGM, the professional CGM and the personal CGM. The real-time CGM, RT CGM, and the intermittently scanned CGM. So I will make it simple for you. A personal CGM is a CGM device which a patient is using regularly, is able to see the data in real time, and able to adjust the behavior as well as the medications like insulin doses in real time to achieve good glycemic control. Intermittently scanned CGM, or the flash technology, also called flash glucose monitoring. Here a device is needed or a mobile phone is needed. And with that mobile phone or the device, you scan the CGM sensor. And this CGM sensor, only then you will be able to obtain the reading. In real-time devices, there is no need for the scanning, and the data comes automatically to the connected device, whether it is a mobile phone or whether it is a handheld device. So this is the difference between two. Globally, if you talk, the flash glucose monitoring is now a thing of past, because most of the sensors, they are the real-time sensors and they don't require to be scanned. So I have already talked about that. So simple, who should we be using for CGM? So obviously all people with type 1 diabetes, they will benefit from the CGM because they need to do SMBG multiple times a day. This may not be practical in many settings. So a CGM can be a good option for them. All people with type 2 diabetes with hypoglycemia unawareness or elevated glucose levels, which we are not able to control. Those people who are coming to you and saying that their glucose is having wide fluctuations, sometimes they have hyperglycemia, sometimes they have hypoglycemia. Those who are checking blood glucose multiple times a day. Sometimes we often encounter patients who do not like to use finger stick method for the glucose monitoring, so CGM can be a better option for them. If somebody is not able to achieve HbA1c less than 7% without hypoglycemia, it is very common that we find a discrepancy between the HbA1c and the SMBG data. So sometimes SMBG may be showing very good results, but the HbA1c may be totally in opposite direction, or it may be vice versa. So here CGM can be a very handy tool. And people who are, again, symptomatic with rapid rise and fall of glucose. So sometimes the rate with which the glucose is rising or the rate with which glucose is falling can also lead to some symptoms. So here the CGM can be one of the important tools. Again, this is how a CGM reports look like. This is a AGP report, which I have taken from a patient. And this is a LibreView platform, the dashboard. You can directly get the report on your platform, or whenever you have the device which the patient brings to you, connect with your laptop or the desktop, you will be able to transfer the data. In a real-time CGM, that data transfer is not required because through the cloud, it will automatically come to your dashboard. Here you will be seeing certain terms like target range. I will just take some time here. So target range is that most of the sensors, we set the target range between 70 to 180. And if these patients, they are spending a good amount of time, mostly in most of the guidelines, 75% of the time, if they spend between a range of 70 to 180, we say that they are able to achieve the time in range. There is another term called time in tight range. Those who are able to achieve a good glycemic control, if we are able to keep them between 70 to 140, then we call it time in tight range. So this is TIR and TITR. And time below range is the amount of time a person spends in hypoglycemia. And time above range, that is the TAR, is the amount of time which a person spends in hyperglycemia. Just to give you an example, this is the CGM graph of a person, which for 14 days, and you will find that there are dots almost every part of this chart. And this is because this patient is experiencing a huge glycemic variability. There are times when he is having hypoglycemia, there are times when he is having hyperglycemia, and nothing is going right in the life of this patient. So once you are able to see that this is what is happening to this patient, and after some time, this is the data of the same patient, then now you can see that most of the readings, they are falling in the green line, that is the green zone, that is the target range. So this means that the glycemic variability has improved, and obviously this will lead to improving HbA1c and other parameters. So this is just another CGM AGP report. This is a report of a Medtronic sensor who is already on a insulin pump. That is a Medtronic 780G pump, which is a hybrid closed loop system. So in this pump, what happens, the CGM gives feedback to the pump, and the pump takes the feedback from the CGM and automatically delivers the insulin, whether it is and the boluses are also delivered automatically. So you can see that this patient is able to achieve almost 80% time in range with the use of a hybrid closed loop system. What else, apart from the CGM, we have connected meters. So connected meters is something, most of the time we know that the people, they don't maintain the data of the SMBG. So connected meters are the devices where you can simply plug the glucometer to the mobile phone, or you have a Bluetooth in the glucometer where the data comes automatically to the mobile application, and the patient is able to see the trends and identify what is happening. So this is just the dashboard of a glucose meter, which is coming to me regularly. So I can see every day in the morning that how many patients they have tested who are on this particular glucometer, and whether they have tested their glucose levels and what are their range. So it comes to their dashboard without any need. So this is again the data only. This is not a CGM graph. This is the data only from the SMBG graph, which is coming to your dashboard. So this is how the connected meters can help in monitoring the patients when it comes to glucose meter. I have already talked about the Eversense sensor. So it is an implantable CGM. It requires a small incision. The sensor can be placed subcutaneously, and this can monitor glucose level for 6 to 12 months. So CGM technology has evolved to include a variety of systems with features which can suit different patients' need. Shared goal is for CGM to provide accessible glucose data and actionable information. And CGM can improve patient diabetes management and clinical outcomes. This has been shown in multiple studies. And earlier, people were saying that CGM is beneficial only for type 1 diabetes, but now there is a lot of data and consensus statement coming from the ATTD, and even from the JAPI, one of the statement was there, which talks about the use of CGM in type 2 diabetes patients. And apart from some of the newer technologies which may be there, so we have something called integrated watches for non-invasive continual glucose monitoring, but though they are not very still FDA approved, but this technology is something which people are very excited and they're talking about it. So by using different algorithms and different mechanisms and different kind of electrodes which an engineer can understand better, these devices may be able to provide a better insight into the glucose levels. And this is just an example. For example, next week we are having an international technology meeting in Kochi, which will be attended by almost 400 people. So one of the company who has developed this kind of technology is going to display this product and give more data on this product, that how a non-invasive sensor can monitor glucose level. Again, these are BioLink. This is again a type of sensors which is there. These are biofeedback sensors. The K-Watch is another something which is available in some of the part of the globe, where they can actually monitor the glucose levels, and they are able to predict the range of the glucose levels, not exactly the data. These are different devices like D-Base, D-Pocket, D-Sensor available, but yet to be approved by FDA. But something is happening in this space, so this is why I wanted to share with you. So sugar beet is again a non-invasive CGM. So most of the time a CGM has a small filament which is placed just underneath the skin. But there are now CGMs which are coming which don't have even a filament, but they have other kind of sensing technology which will be able to sense the glucose levels. So this is again a INA, that is the connected glucose meter. Skin patch development is happening in that space. Also, just day before yesterday, there was a report that some of the IIT students in India, they have successfully tested glucose level from the sweat analysis. So this is something which is happening, and a lot of people, they are trying hands on this, and the testing of glucose level from the tears, and this is from the saliva. So multiple things are happening which may actually impact the glucose change. So connected pens, though this is not part of the monitoring, but whenever a patient is on insulin therapy and he is injecting the doses, so it is most of the times patient, they don't remember that what kind of dose they have taken, whether they have taken the complete dose or not. So connected pens again can help in monitoring, because these pens will have a dial on the top of that, which will be integrated with a Bluetooth application, and whatever dose a patient takes will automatically be logged into the application. So these patients, they will be able to monitor their insulin dosing. And now we have digital therapeutics. So digital therapeutics are kind of applications. One of the major challenge which patients on insulin therapy faces is that we are not able to hold them or guide them regarding the titration of the doses. So now they are technology-based titration. So digital therapeutics like insulin dose calculator, these are the apps which are available, and they can guide the patients that how to change the insulin doses. just few more things, that monitoring is not just about glucose. You can track your food habits. You can do carb counting through the technology. You can track your activity levels, though this is not the talk of or the topic of the today, and I would be brief in my talk. So insulin dose calculators are already available. And we know that digital health and diabetes, this is one of the paper by the Dr. Jyoti Dev and Dr. V. Mohan, which talks about that digitalization is going to help, and it is going to take more and more important role in the field of diabetes management. This is just another thing. This is a new sensor, which is not yet available in India, but will be launched in India next week at Kochi in another, that is a DTEC meeting. And this is a 15-day sensor. This is a real-time sensor. And the sensor will not require any kind of app, any kind of scanning. The data will come automatically to us. So this is coming to the India for the first time, and this will be available for the use of all of us after next week. So it is again one of the accurate devices available. It is a CE approved and available in European as well as in some of the Asian countries. Easy to use, affordable. I myself experienced this sensor. And this is how this mobile application would look like, and this is how the sensor would look like. This is a very small sensor. And this is a dashboard which I get from the patients who are on the Libre. That is a Abbott sensor. So daily you get the reports of the patients who are on these kind of sensors. Another important thing is that the BGEM, that is the blood glucose evaluation and the monitoring. This is a registered, patented by a company in Singapore, and they are using photoplethysmography sensors. I had the opportunity to experience this sensor because I am working to collect the data for this. So they are able to predict by simply using this PPG sensors without doing any invasive thing, and they are able to predict that what is the likelihood, what type of glucose levels will be there at a particular point of time. So I think this is a brief of what is happening in the monitoring space. I think you would find this useful. And if you want to experience CGM, I think in most of the government hospitals or during our PGs, we don't get exposure to these kind of technologies. Private hospitals, they are using it very commonly. But if you get any opportunity, those few students who are sitting here, then do try your hands on using these kind of technology and CGMs. This will make you understand what is happening in technology space. So with this, I would like to thank you. Thank you very much for your patience listening.
Thank you, sir, for the wonderful session. The glucose monitoring devices will not just don't just help physicians plan diabetes control for their patient. I think it's very empowering for the patients also, because they can be a part of their diabetes control, and it goes a long way in removing the fear associated with diabetes once they learn to control it with technology.
Thank you.
If anyone has any questions, please, they may direct it to sir.
Thank you. Thank you.
Thank you, sir, for very informative, precise talk and for upgrading our knowledge in the monitoring aspect of diabetes. You may proceed for the felicitation. Moving to our last session for today, may I call the chairpersons for next session, Dr. Deepak Verma, he is assistant professor at JIMS, Dr. Tarun Goyal, he is consultant at Max Vaishali, Dr. Motilal Negi, he is professor at Lady Harding, and Dr. Kuldeep Kumar, he is associate professor at UCMS. May I also request Dr. Saket Kant sir to please come on the stage. He'll be speaking on the topic of future of diabetes in young. Sir is a senior consultant in the endocrinology department at Max Super Specialty and Balaji Hospital, and he was awarded Best Paper Published Award at 14th ESI AV Gandhi Awards 2016, and he has been associated with many prestigious national as well as international journals. Sir.
All right, thank you very much. I guess all of us are very tired. I'll be very quick in my talk. So if you talk about the diabetes in young, there are various definitions about diabetes in young. Some say it is 30 years, some say it is 45 years, but both of these can be taken as the diabetes epidemic is growing. More and more younger people are getting diabetes now. All right, so So this is what I will be taking you through, rising trend of type 2 diabetes in young. It is not always type 2 diabetes, it is a lot of other type 2 diabetes can also be there. The diagnostic modalities have, the new diagnostic modalities for MODI have been there. Upcoming monitoring modalities are discussed already, once a week basal insulin, inhaled insulins, and the CD3 monoclonal antibody that has been approved now. So I would be very quick. Diagnosis has to be proper in patients who are young diabetics because they have a long life to live with diabetes and they are economic social challenges. Even if the diagnosis is rare, you have to make a diagnosis, and this is what you'll have to find out what type of diabetes the patient has. Young people, 0 to 19 years, both the prevalence and incidence of type 2 diabetes also is growing very rapidly. So family history, age, rapidity of onset, ketosis, weight loss, other symptoms, markers of insulin resistance, clinical features or defects, insulin C-peptide antibodies may be needed for most of our patients. Extra abdomen with egg pancreas. Other specific imaging may also be needed, and you may need testing for MODI, which is now increasingly available at affordable cost. So these are the specific types of diabetes that you have to look for. LADA, we all know 1.5 diabetes, may have GAT65 antibodies positive, may basically be not needing insulin at the type of diagnosis, but will finally need insulin. MODI has grown in number. They may have a family history that may go up to 2 to 3 generations. And a lot of MODI are growing. MODI diagnosis has to be made, and the advances that have been made in MODI diagnosis is that now you have you can have a gene study for MODI, and that can be done around at 25,000 rupees. And the importance is that if you make a diagnosis of a proper MODI, you will know which patient would have additional defects, which patient would respond to insulin, and which patient would respond to a lower dose of secretagogues. So that is very, very important. And a lot of MODIs and MODI are growing in number. There are 14 MODIs now. We used to have 6 in our times when we were postgraduate students. The monogenic also have, they are rare. You have to look for them also, and endocrine disorders we all know. So correct diagnosis is very important. Monitoring devices, I guess, already discussed. But you have got a lot of devices from the blood, saliva, sweat, interstitial fluid, tears, and urine also that would be displaying data for all of these on your devices. So you have variable glucose sensing, sample-based, non-sample-based. Already discussed by sweat, tears, saliva, electromagnetic bioimpedance, photoplethysmography, electrocardiogram, and acceleration. This was discussed. And the continuous glucose monitoring devices, there are non-invasive devices also now that can be placed on the surface of the eye, contact lenses, sensor placed on the blood vessel, fingertip, on the skin, watches worn on the wrist, and gas from exhaled breath also can help you. So I'll quickly take you to therapeutics of type 1 diabetes. That is basically what is new in this. You've got the once-a-week basal insulin, the first acylated insulin analog for once-weekly administration, tightly albumin-bound, ultra-low insulin receptor affinity, ultra-long-acting, fully in vivo potent, and 1 weekly administration in humans in phase 2 trials. Efficacy, safety, very good if you compare it with once-a-day insulin. Glargine versus Icodec, that is the once-a-week insulin. Almost all patients achieved targets, comparable targets, and the CGM profiles were also very, very similar. So you can see Icodec almost achieved a better control almost similar control at a lesser dose as compared to Glargine. The dose Icodec was 33 versus Glargine of 41, and adverse effects were almost similar. The pros of once-a-week insulin is that it is convenient. The cons are that more time may be needed to a steady state because of the longer half-life. It may be difficult to treat hypoglycemia because the reversal of the insulin levels may take time. A mental barrier when you have a patient on, for example, 20 units of insulin per day, and you tell the patient that you have to inject 140 units, that is going to be a mental barrier, and cost would be an issue with this. Insulin pumps, I guess already discussed, open and closed loop. We've got the bionic pancreas also, which basically has an insulin suspend system, and whenever you have hypoglycemia, you will have glucagon also going in. But these are again costly. Medtronic has the best pump right now. You have other novel insulin delivery methods, the rectal insulin delivery, oral insulin delivery, inhaled insulin delivery. Inhaled has been there in US for a very long time, approximately 10 years now, and you have developments on transdermal insulin delivery also. The transdermal insulin delivery is with microneedles, and it is pH-sensitive insulin-loaded microneedle patch, which is a nanocarrier system, and you have silica nanoparticles-based dissolving microneedle patches. The oral insulin delivery systems have been tried. They are in process: microparticles, microspheres, nanoparticles, hydrogels, and liposomes. And these are these are basically in research. And what this would, when these come into practice, what will happen is these would deliver insulin in a glucose-dependent fashion. So whenever you have hyperglycemia, the liposomes or the hydrogels would deliver insulin. Otherwise, there will be no delivery of insulin, and that would decrease the risk of hypoglycemia also. The inhaled insulin also has been there for a very long time, launched in India also. You have Afreeza, Exubera, and the problem with these insulins is the insufficient glycemic efficacy. The 2-unit dose that has to there in one puff. So if a patient is taking around 20-30 units, the puff requirement would be very high. And monitoring of pulmonary function test have to be monitored very frequently for these. And if the patient develops hypertrophy of the nasal terminates, that would basically decrease the efficacy of insulin. Recently, we know that type 1 diabetes is a disorder that is autoimmune. So a lot of things happening in the pancreas. When you get type 1 diabetes, you have a stage of pre-diabetes also, antibodies to GAD65, ZNT8, and you can always look at what is going on in the cell in an inflammatory state when the patient is in an autoimmune process. Various targets, the monoclonal antibodies can target for type 1 diabetes therapy, and one of them has been approved now. Teplizumab has been approved by US FDA for more than 8 years of age children, and can delay the onset of diabetes, type 1 diabetes, by up to 2 years. So you have systemic approaches affecting the T effector cells, B cells, T regulatory cell expansions, anti-inflammatory drugs. GLP-1 receptor agonists are right there, and maybe the future of type 1 diabetes also, because of patients of type 1 diabetes getting double diabetes when they gain weight. And verapamil may provide beta cell stress relief and stimulation. And the cardiometabolic improvements may be needed in patients with type 1 diabetes who get double diabetes because when they get obese. So we've got a lot of things happening in type 1 diabetes. Oral insulin peptides, GLP-1 receptor agonist, verapamil may come in. The stimulation of remaining cell mass by GLP-1 receptor agonist trials are underway. Cytokine blockade, IL-6, IL-21, TNF-alpha, anti-CD3 is already approved. T or B cell pool depletion, anti-CD20 may be there, and low dose IL-2 may be addressing T cell regulatory cell expansion. Then the complications, you may need drugs that you use for type 2 diabetes in type 1 diabetes also, and stem cells is a promising therapy, but it is difficult right now. Then you have the connected technology. You can have glucose monitoring devices, exercise, weight tracking, remote monitoring, communication with diabetes care team, diabetes forums, telehealth appointment question portals, and this would make it totally digitalized, and that is what the future of diabetes looks like. So diabetes in young is increasing in incidence. Proper diagnosis is needed. The first step is a proper diagnosis so that you can plan appropriate treatment. Even if the diagnosis is rare, it will plan appropriate therapy. Advances are specific to the type of diabetes. I discussed only type 1 and the moody ones. There is growing burden of type 2 diabetes in young also, and double diabetes in patients with type 1 diabetes also. Many monitoring therapeutic advances underway, and stem cell does hold promise for type 1 diabetes in the future, but it is still not approved and has not been very successful. Thank you very much. I guess I was quick.
Thank you, Dr. Saket, for enlightening us with the future of diabetes. And along with the previous speaker, I think definitely the use of connected tech will help us both in the patient-centric and the control of patient being given to the patient, as well as in monitoring the treatment. Now, I know already late, but my question is, what are the drugs which are approved in India for the prevention of diabetes?
Prevention, you mean pre-diabetes? Yes. And so I guess one was the stop anhydridium trial that was with acarbose. AGIs are the drugs that are approved. You can use metformin also. So metformin and acarbose are the only drugs. But I guess a lot of other drugs have great potential in the form of GLP-1 receptor agonist and SGLT2 inhibitors. Glitazones, they have great potential because they act on the pathophysiology. But there are no trials as for now for these drugs, but wonderful drugs, GLP-1, SGLT2, and glitazones are wonderful drugs that you can use in pre-diabetes, off-label for now because no approvals. But for now, I guess it is only AGIs in the stop anhydridium trial that they had, and metformin can help. Now you can decide on the basis of whether the patient has a more HOMA IR or less HOMA beta. That will help you decide which drug to use, and a combination can also be used. But weight reduction is the paramount if you have obese overweight patient.
Thank you. So if there are
Dr.
questions
Saket,
from the audience as well.
Dr. Saket, you were not there, I think, when Dr. Verma was giving oration. In circadian rhythm, is disturbed circadian rhythm important cause for the causes of diabetes in young? Because most of our young people, they are doing the shift job night, and it's very difficult to what is the actually according to your point of view, what could be the best management? Because these people, they are working in the night and they are sleeping in the day, so they have the complete change in the.
Well, there was a trial that was looking at shift workers, and they found that the risk of having type 2 diabetes is almost double in patients who work in the night because of the altered circadian rhythm. So difficult to maintain that because most of them who were working in night shifts had habit of eating a lot in the night. If that can be curbed, and in the companies where they work, if they can be provided gyms and healthy snacks, probably that would make a difference. So circadian rhythm was one part, and the second part was snacking that they used to do at night. Whenever they have some time in the night shift, they would do a lot of snacking. So in that trial, they were also looking at the calories intake of both of the day workers and the night workers, and they found around 1.5 times the calorie intake in the night shift workers as compared to the day shift workers. So that was one factor. The number of steps that they were taking, the day workers were somewhat 1.5 times higher than what the night workers were taking. And the third is, of course, circadian rhythm is disturbed. Your cortisol, catecholamines, they change a lot. Your sensitivity to catecholamines changes when you do not sleep at night, and that is what one of the speakers was discussing. Dr. Dheeraj was saying that if you have a patient who comes to you with may not have slept for 2 to 3 days, the blood glucose levels would be on the higher side. And if this is going on for a very long time, it is going to affect the glucose levels. It is going to affect the cardiovascular morbidity, mortality also.
Thank you.
Thank you, Dr. Saket, for such a wonderful talk. Thank you so much.
Thank you, sir, for the precise and informative talk. And thank you, chairpersons. You may gather for a photograph. Sir, you may proceed to the presentation desk.
Start करो मैं तुझे. Good afternoon, distinguished guests, ladies and gentlemen. On behalf of the organizing society of Leadcon 24, I would like to thank all the speakers, moderators, panelists, PG students, all the delegates. Thanks a lot for your participation, and definitely we are going to improve it the next time. We would like to extend our special thanks to our keynote speakers. Their expertise and dedication to their work have inspired us all to continue striving for excellence in our respective fields. We would like to thank our sponsors, exhibitors, partners for their generous support who has enabled us to organize this conference and provide a platform for the exchange of knowledge. Lastly, I would like to thank all of you, our attendees, for taking the time to join us and participate in the conference. We appreciate your enthusiasm and contribution to the discussions and hope you find this event both informative and enjoyable. Once again, thank you all for your support and participation. Leadcon, we hope to see you again in our future events. Thanks a lot. I would like to call. सर एक बार ऑर्गेनाइजिंग टीम को बुला लें. हाँ. ऑर्गेनाइजिंग टीम प्लीज.
अमित,
डॉक्टर सौम्या, डॉक्टर आंचल,
अमित, सौरभ बोस कहाँ हैं? आंचल, ऑल माय पीजी.
अमन. सर. सर बिल्कुल है कहने की जरूरत ही नहीं. विवेक.
डॉक्टर शुभा चली गई मैडम. डॉक्टर शुभा बुला दो.
शुभा बाहर ही है. आपको थोड़ी दे रहे आप तो होस्ट हो। अमन, अरे शुभम आप नीचे क्यों खड़े हो भाई? होस्ट हो आप, कमाल है। इधर खड़े हो साथ में। आओ इधर आओ। शुभा देगी अमन को। आइए अमन। और रखें बेटा बाहर। कहाँ है सोहन और वो कहाँ है? ये अजय खड़ा हो इधर। अजय पीछे से गया। एक मिनट का डिले हो गया सर। फोटो ले लेते हैं। फोटो के लिए तो ले लो, फिर बाद में भी ले लेना। आप आओ ना। आप ले लेते हो सर। हाँ।
उनको बोल दो।
तुम भी आ जाओ।
आ जाओ, इसी से फोटो ले लूंगा। उनको आने के लिए बोल दो। से फोटो इसी से ले लूंगा। वो खोलना नहीं।
हाँ खोलो मत, फोटो इसी से ले लो। और कौन बचा?
जूनियर।
मनु आ जा। मैं फोटो खिंचवा दूं पहले, फटाफट आ जाओ। खाली फोटो खिंचवा लो, डब्बे पैक लेके चले जाना, ठीक है ना? आओ आओ। डब्बा अजय से लो। बच्चों करा दे। नेहा इधर आ जाओ।
उसके बाद नेक्स्ट
आ जाओ नेहा। हाँ फ्री हो गए। अरे इधर आ जाओ। सुभाष जी
आप नहीं जानते? नहीं मुझे
सुभाष जी जरूर लगाना है। आ जाओ।
ऐसा खाओ।
ठीक है।
डब्बा
मैं सबको बाहर पैक वाला दूंगा, खोलूंगा नहीं ताकि वहाँ अब आ जाओ हमारे अशोक जी। दीपक सोनू का दीपक को बुलाओ।
तो एक काम करो, जो भी है
सबको बुलाओ यार, सोचने वाली जरूरत ही नहीं है। और वो अभी गाड़ी में मत भिजवाना नीचे। कहाँ गाड़ी वाला रोक लो। अभी अपने को हुआ है ना, पांचों को बुलाओ। मैं अब तो बाहर वाला काम अभी ये डब्बा मुझे लगता है हो जाएगा। आ जाओ। अरे बड़े इम्पोर्टेंट। हाँ सारी टीम आई हमारी। सुबह मैं आपको दिलवा दूं? पैकेट वाला ले लूं आप? आ जाओ मैडम, आ जाओ।
सर आ जाओ।
ठीक
सर कहाँ गए?
कहाँ है सुंदर? यार सुंदर के बिना तो कैसे, कहाँ गया? अभी आ